So let's begin. Greetings to my colleagues, my teachers who I admire, and my well-wishers. As head of cardiology department at Max Hospital, Shalimar Bagh, I take great pride in welcoming all the eminent speakers, chairpersons, panelists, and attendees from all over the country to this innovative Cardiology Conference 2021. Today, as we all have collected virtually, we shall dedicate few hours to cover a wide spectrum of themes related to cardiology. The conference will cover the important topics like structural heart interventions, like TAVI, trips and tricks, transcatheter mitral interventions. There is a imaging role of imaging in cardiology. There is a live case in the box. There is one session left main bifurcation with a keynote lecture from Dr. Goran Stankovic and one case presentation from GB Pant Hospital. Then there will be a session, a thrilling session of handling emergencies in Cath lab by Dr. Professor V. Trihan. And finally, we have a session on what are the new weapons in the management of congestive heart failure medically as well as interventions. So participants from across India and Asia Pacific have joined us today. All the masterminds are here with us, and with immense pleasure, I welcome and honorable doctors to the conference. As we all know that learning never stops and each day is a new learning for all of us. So I take this opportunity to thank my senior doctors who are here with us. Today is a very special day for our entire cardiology team at Max Hospital Shalimar Bagh, as the opening day of ICC and Teachers Day are falling together. So I wish you all a very happy Teachers Day. So on behalf of my colleagues and friends, I thank you for inspiring and leading us in the right direction. Sir, ऐसा कहते हैं, गुरु ब्रह्मा, गुरु विष्णु, गुरु देवो महेश्वरा, गुरु साक्षात पर ब्रह्म तस्मै श्री गुरुवे नमः. So with this note, let me introduce our moderator and chairpersons for the first session. Now I request, so the chairpersons for the session one is Dr. P.K. Goyal. He is the director of Medanta Hospital, Lucknow. Earlier, he was professor and head of cardiology at SGPGI Lucknow with more than 30 years of experience. He is the person sole behind starting the coronary angioplasty program at SGPGI Hospital in the year 1991. He has a keen interest in complex coronary interventions, CTO programs, imaging, rotablation. He has more than 150 publications in the intervention in cardiology. He is awarded with Vaishya Ratna Award by UP Vaishya Mahasabha. If we talk about the society position, he was a secretary of UP CSI 2004-2006, organizing secretary for ICC in the year 2009, president-elect UP CSI, and co-organizing secretary for NICM. So he has trained many eminent cardiologists of India. So thank you and welcome, Dr. P.K. Goyal. Our next session, thank you, sir. Our next speaker, chairperson will be Dr. Srinivas. A. Srinivas is a director cardiology and clinical research, Apollo Hospital, Jubilee Hills, Hyderabad. He is a senior consultant and director there. He is also professor of medicine at Apollo Hospital, ICMR, Hyderabad. He is chairman and CEO of FACTS, that is Fraternity of Advanced Cardiovascular Technique and Research, course directors for TCT India. Earlier, he was a chairman of CSI NIC in the year 2018 and 19. He has a keen interest in complex coronary interventions, balloon mitral valvotomy, and structural heart interventions. He has trained many young interventionist fellows from India, Germany, Burma, Nepal, Africa, Sweden, and US. And he's a principal investigator for several studies like NEFRIC 2, REDEEM, and CORAL. He has more than 50 publications. I welcome Dr. Srinivas.
Namaste.
Namaste, sir. So over to Dr. Srinivas for further proceedings.
Thank you, Naveen, and happy Teachers Day to all. Incidentally, Dr. Goyal, who was my teacher, and I learned a lot of techniques from here, he is here. Wishing you happy Teachers Day, sir. Greetings from our side.
Thank you, Srinivas.
And then I also see Dr. Balbir, Dr. Ravinder, and Dr. Sukhvinder, and many others. Thanks for getting us all together on this auspicious day of Teachers Day. I think to start the session, we are supposed to have, the first session will be on structural heart interventions. And the first lecture is TAVR tips and tricks. And we have none other than Dr. Ravinder Rao, who is maximum experienced in this field. We're fortunate to have him back in our country after training abroad. And that's how the program took off well. And a lot of credit is given to a lot of other seniors in the country. But I feel this man established even the valve of our own in our country, and has a lot of accolades. And always other great quality of this Ravinder is down to earth, always available for any help. And thank you, Ravinder, for accepting this also. And thank you, Naveen, for making this possible for all our younger colleagues across the country. Let us hear to him from TAVR Tips and Tricks. I think he has a publication to his credit also in Indian Heart Journal with more than a century of cases. We hope to listen a lot of tips and tricks because a lot of interest is created, Ravinder, in the country because this is becoming more and more popular and many hospitals are taking up this. And once you get into it, you love this procedure because patients improve dramatically. And we have very good stories of patients who are very sick, who are not able to sleep, and dramatically improve, become active, all that stories. If you get into it, you will become more passionate about it. So that's how it's very important to have good tips and tricks from a lot of experienced operators like you. With this, I hand over the proceedings to Dr. Ravinder. Over to you, Dr. Ravinder, for your talk. You want Dr. Goel sir also to say a few words now or only in TMVR session, whatever Naveen decides.
Doctor, yes, I want few words from Dr. Goel also, and please introduce the panelist also for this session.
Well, I think Ravinder, as he has said, he has been the key person. He probably started one of our first cases of TAVI, so Ravinder is always there. And I think I was the one who was chairing when he got the first prize in the TISCA. He told me that. So he's a very bright student. That's what I would say. And in the panelists, I think you have already introduced the panelists. Manik, I know because he's also come to our place for TAVI sometimes. That's it. And Balbir, of course, is known to everyone.
Yes.
So now he's in Max. So I think we should get to the proceedings.
Yes, sir.
Yeah.
Can you hear me, sir?
Yes.
Yes, sir.
Yeah. Ravinder, please start.
Happy Teachers Day, everyone, sir, and all the teachers and everybody who has contributed to, I would not say to all the students who are listening to their growth. And thank you, Dr. Srinivas, sir, for kind words, and Dr. P.K. Goel, sir, as well. And most importantly, thank you, Dr. Naveen Bhamri, sir, for having me for this conference. And I totally agree with everybody now that TAVI is happening almost at more than 200 centers. At least more than 200 centers would have done at least one case in our country, and it is increasing for the benefit of our patients. So we all know this, severe aortic stenosis is a deadly disease. And now we also know about how the TAVI has proved itself from high risk to intermediate risk to low risk patients. And we also know that the mortality of a patient is directly related to the STS score. And that is why when we select a patient with a lower STS score, our TAVR outcome is better, provided the patient is suitable for a transcatheter aortic valve implantation. And that is because higher the STS score, higher the chances of dying from other diseases and not only from TAVI procedure itself. This also, we all know how TAVI was established and got an US FDA approval even in low-risk patients. The data from the Partner 3 trial, I'm not going to go over it in detail, but the few parameters which are higher in the TAVR patient population compared to the surgery. One is new permanent pacemaker, and the second one was the paravalvular leak. These are the two things which are still higher in the TAVR patients compared to the surgical aortic valve replacement. However, now the number is in single digits. Earlier, the number was in double digits. This is how patients were undergoing TAVR back in 2007. This is in 2021. Sorry, this slide is I borrowed from a colleague, but this is how even our Indian patients look like. Now the average age is somewhere in the late 60s or early 70s. So the most important thing is the patient selection. You know, if you look at the entire guidelines, it is the TF-TAVI, which is class 1 indication for TAVI even in low-risk patients. If you look at the latest guidelines, again, from the European Society, a non-TF-TAVI is actually class 2B indication. So it is very important for us to understand that we need to tailor our patient to a valve which can be delivered from the femoral artery. So, and that's also highlights the important thing that if you're not able to do a TAVI from a femoral artery, you know, other approaches have their own complications. And that is why the European Society guidelines have put non-TF TAVI into a class 2B indication. So, you know, this is how you can call it as tips and tricks or step-by-step has to be, if possible, a conscious sedation, a TF approach, transfemoral approach, which could be either percutaneous or cut down. But I'm going to come straight to the point because my talk is more focused on tips and tricks, or in fact goes step-by-step TAVI. So obtaining a femoral access, this is the most important thing for a TAVI patient, and that is how do you achieve good femoral hemostasis. So the good femoral hemostasis post-procedure depends on your pre-procedure vascular access. This has to be an anterior single wall common femoral artery puncture. It could be a fluoroscopy guided, a pigtail guided, a road map, or an ultrasound guided. Now we have switched to ultrasound guided puncture because on ultrasound you can identify even the location of the calcification. So here you can see a micropuncture which is being used, and the puncture is obtained on the mid-femoral head. The second important thing is, if you see any tortuosity, a stiff wire test, you put a stiff wire and see whether the vessel straightens or not. And then the third important thing is you advance all your big sheets over a stiff wire and under fluoro guidance. So in short, the femoral axis is very important in a transcatheter aortic valve replacement. Next is you do an aortogram. It's very important for us to identify the coplanar view. All three sinuses should be in a straight line. The nadir of all three cusps should be in a straight line. There is a right cusp rule. If the right and left are overlapped, go to the LAO. If right and non are overlapped, go to the LAO. If right is below, go caudal, or if right is above, go cranial. You try to follow the right cusp. But this is a very important point, or a very important step, especially if you're doing a balloon expandable valve. In a self-expandable valve, now we have moved to the cuspal overlay view, or sometimes you can skip this view, just put the pigtail in non-coronary cusp, come across the annulus with the valve, and then remove the parallax from the ring. So next is, how do you cross the valve? Crossing the valve is in the LAO. Emplazar catheter, it could be an AR1, AR2, AL1, AL2, depending on the angulation. Here you can see how horizontal the root is. So you orient the Emplaz catheter into the jet, and you can see when the catheter bobs up and down, you are in the jet. For my cases, I use AR2 for all tricuspid valve and AL2 catheter for bicuspid valve. But sometimes we have to use a JR catheter, a multipurpose catheter also. So here you can see, you can identify the orifice, and using a straight tip thermowire, the valve is crossed. Now, what happens if there is difficulty in crossing the valve with the wire itself? Number one, change of hands. Sometimes you get fatigued, and you can ask your second operator to try to cross the valve. And the reason it works very well is because, sometimes you might not be orienting your catheter, and your brain and eyes get biased to a particular point. So maybe you can set a timer. How we do is we set a timer in our cath lab, 30 seconds to 1 minute or 1.5 minutes, and then you try to change hands and ask the other operator to change. And second is change the catheter. Don't keep doing the same thing with the same catheter, same wire. You will not be crossing. You have to change the strategy. Change to a straight tip glide wire. Few cases, if you are on top of the orifice and you're not able to cross, you bring your wire to the top of the orifice, do rapid pacing, and you'll be able to cross. There was one case where I was not able to cross, so you have to do a transeptal. The idea is you keep changing the strategy and don't do the same thing multiple times, because by the time you cross the valve, you'll be tired, fatigued, and discouraged. So keep changing your strategy if there's difficulty in crossing the valves. The next very important point is how to position the stiff wire. Once you cross the valve into the LV, you exchange it to a Teflon wire inside a pigtail, go to the RAO, see the apex, and place the stiff wire inside the pigtail. Now, the one important complication which will be very difficult for us to handle is an LV rupture. Or an LV perforation. So basically the LV perforation is not a wire tip perforation. It is more of a laceration. So the curve of the stiff wire just lacerates the myocardium, and that almost always requires a surgical closure and surgical intervention, and carries a very poor prognosis. So here you can see how eccentric the opening is in this patient, and look at how horizontal root is. The way you can see on fluoroscopy, if the level of the pigtail or the tip of the pigtail in the LV and the tip of the pigtail in the aorta, if they are in the same plane, it's a horizontal aorta. Now, very important on the echo, one should also look at the course of the wire in the LV, interaction of the wire with the submitral apparatus. If there is an hypotension immediately on putting the wire, there is a huge possibility that patient must have developed severe mitral regurgitation because the wire must be tenting on the submitral apparatus. So you pull the wire out. Now, sometimes the wire goes and sits on the lateral wall of the LV, and you feel like, let us take it and let's try to do a TAVI. If the wire is on the lateral wall of the LV and it needs support, high chance of free wall perforation again. So take all your time to position the wire right at the apex or in the middle of the LV cavity by using a pigtail catheter, even if you need to do it multiple times. Sometimes the wire comes out, don't get discouraged, cross it again, but wire has to be at the right place. Now, pre-dilatation, very important. Before you do a pre-dilatation, the valve has to be prepped and ready to go. So pre-dilatation is not mandatory for all patients, but it is all cases, but it is required for bicuspid aortic stenosis in a very horizontal aorta, use of a balloon expandable valve, which is directly crimped over the balloon, or a patient in whom we want to implant the valve very high. Now, suppose in the current generation, if I'm using a self-expandable valve and patient has right bundle branch block, and I want to position the valve at 0 depth, you do a pre-dilatation so that you can avoid a post-dilatation. The balloon is equal to or smaller than the short axis. A 4 centimeter or a 6 centimeter long balloon is required. Rapid pacing, pressure decreases, inflate, deflate, and stop pacing, and then remove the balloon. How do we cross the arch? This is very important. You go across the arch in an LAO view, and the tip of the wire and the arch, they should be in the same field of vision. So in such a horizontal aorta, you can see how horizontal this is. You prefer to use a balloon expandable valve, which can be flexed. Now, there are cases which we have done with self-expandable valve, but ultimately you end up using a snare and multiple things, 2 wires, Lunderquist wire to get across that arch. And you can see how that calcium is. As we are crossing the arch, we need to keep an eye on that calcium, and you keep flexing the catheter. And here you can see it's such a horizontal aorta, but keep watching the tip of the catheter and keep watching the tip of the wire. Crossing the wire, crossing the valve. Once you are across the valve, these are certain steps which are specific to a particular valve. Here it's a Sapien 3 valve. You pull back, pull the pusher back proximal to the middle marker. But this is key for all balloon expandables. You do rapid pacing, BP goes down, inflate, deflate, and then stop pacing. Here you can see a balloon expandable valve Sapien 3 is being implanted in a very horizontal aorta. So this again brings to the point. Now, if you have a very horizontal aorta, almost you can see how horizontal it is. A balloon expandable valve which can be flexed so that we can get coaxiality is preferred. And then before you remove the wire, do a pigtail hemodynamics, and this is a picture of the aortogram. For self-expandable valve, again, the CT scan assessment is very important. The advantage of a self-expandable valve at present is it goes through a 5 millimeter vessel. And as I said, all the valves should be tailored to the femoral approach if possible. All patients should undergo a TF TAVR. So I'm just going to come straight to the point, and this is how it is deployed. You keep the pigtail in non-coronary cusp, and do a gentle release. In an RAO caudal view, this is the cuspal overlay view, and the valve and the current times has to be implanted as high as possible. Here you can see a Lunderquist wire is being used, and this is the final depth with no paravalvular regurgitation. The advantage of a self-expandable valve is if a patient has low EF and you want to avoid post-dial rapid pacing multiple times, a self-expandable valve is preferred. This is our outcome. I'm just going to go straight to the outcome slides. Stroke 1.9%, pacemaker 5.7%, paravalvular leak 12%, all-cause mortality was 0.9%. No PVL in 87% of patients, trivial in 6.6, mild 2.8, moderate 1.9. patients who received pacemaker, 84, 81, 70, 82, 82, 82. But interestingly, if you see a patient, majority of these patients had trifascicular AV block, and it was equal in balloon expandable as well as self-expandable. So idea is, if a patient has trifascicular AV block, you're doing a TAVI on this patient, you might as well counsel the family that there's a high chance that patient will require a pacemaker, and I would do a pacemaker on table during the TAVI procedure, because trifascicular block anyhow becomes a two-way indication for pacemaker. This is a comparison with standard trials. Pacemaker rate for our outcome is 5.7%, partner 6.6%, evolute 17%, mortality 0.9%, stroke for us 1.8, partner is 0.6, evolute is 3.4, notion was 1.4. Now, these are the, I'm just going to skip these slides. These are the expanded indications of a transcatheter valve. We can go ahead to a septal puncture. Through the transseptal puncture, we can do a valve-in valve for the mitral position, and then valve-in ring for the mitral position, and then a transcatheter double valve replacement, and a mitral valve in MAC as well. So thank you very much for the kind attention, and thank you, sir. I think if we have discussion, that would clear more doubts, because for tips and tricks, and we can continue talking for almost an hour, but I just wanted to stick to the basics. Thank you very much.
Thank you, Dr. Ravindra, for an excellent talk, and for guiding all the beginners also to how to take you through these steps. I think you have covered many of these important aspects regarding the decision making, and also to how to avoid complications you did mention. But do we have time, Naveen, to add 1 or 2 points to this? I think what he has told is very well valid, but a little more, I think, stress should be given for everybody to understand the CT scan and how we depend on echo before. I think this procedure is a lot dependent upon the CT analysis of the valve and the calcium extent, and then probably annular sizing, especially in bicuspid anatomies, whether it is cylindrical or tapered, where the valve is going to anchor. Those are some of the things, apart from the importance of femoral arteries, how they are, and what axis you prefer. And that is a thing which all of us, we need to become comfortable with 3Mensure software. That's why I keep requesting companies, rather than doing other things, provide the software to all the people who are interested in it. And that's how I think this will be more useful for all of us to learn more and more about this TAVR valve. Some of the tips you mentioned regarding the femoral artery, that's basically what we are all taught as an interventionalist, even in the coronary interventions, to do the puncture in the right place. There's nothing actually new. That's what we were doing. We were told antegrade puncture mainly in the femoral artery. That's what is stressed upon now. And you showed that extra tip for putting a straight wire, how the artery becomes straightened. That is a very valid point. And when you are crossing, how to avoid the calcium. That is, again, if you know the anatomy, Dr. Goel always stresses on this. Arch, if it is opened well, in LO only it opens. So probably you take that through. And then you also stressed upon how to take care in the horizontal aorta and many other important things. And recently, Dr. Rajmakar was mentioning, where the fellows were there, he is recommended that always he now does puncture with 1 French micro puncture set. And irrespective of whatever position it is, and still the complication rates have gone down significantly, he was telling. That is one of the important things for the fellows to learn. And then probably if you are in a wrong place also, even if you remove and then do it again, it is not mattering much, he said. That is another important thing, but we should have those micropuncture sets in our lab. Otherwise people follow that bullseye method of pigtail putting in the center. Now you mentioned ultrasound guidance. That is again important thing. If you're comfortable with ultrasound, the advantage is you can exactly see the bifurcation point, and you can avoid contrast injections in some patients who have CKD. Those are important things for a femoral artery puncture technique properly. Regarding the aortic valve crossing, you mentioned catheters, AL1, AR2 you prefer. But I think it is, if it is horizontal aortas, I think JR catheter could help because of orientation. Basically, you decide it by seeing the jet, how it is coming out. And probably taking a aortic root shot also will help exactly to see where is the jet coming from. And you need to cross the aortic valve also, like you cross coronary stenosis. Like you see the exact position where it is opening, and then take it straight and cross it. That enters easily, rather than blindly poking around all around. That is another easy method to cross the aortic valve, but obviously each of us have our own tips and tricks. Regarding the valve sizing, Ravinder, 20% oversize and 30% oversize or 0%. So how do you select the valve size? It's always important to keep the calcium in mind. Though if you include a big chunk of calcium on the other side, you might be getting a bigger valve size. But sometimes the valve doesn't expand at side, especially the balloon expandable valve. It could rupture the other side. So what are your thoughts on the valve selection in a heavily calcified valve? How do you size your valve in such anatomies?
That's a very good question, sir. If it's a heavily calcified anatomy, prefer a self-expandable valve, because the aortic annulus rupture complication is actually deadly. And, I would admit I had one aortic annulus rupture, and by God's grace, I was able to coil it and patient went home, discharged safely. But what happens is that if it's a heavily calcified valve and you want to use a balloon expandable valve, it has to be 0% oversized, something like 0 to 5% oversized. It cannot be more than that. So, if you look at the IFU, even -5 up till -5% undersize is acceptable in the heavily calcified anatomy. But measurements, as you rightly pointed out, has to be measured from the middle of the calcium chunk or from the inside of the calcium chunk. You cannot take the whole calcium for the measurements. Now, for valve selection, just two important things which I want to highlight. One is we need to avoid a patient process mismatch. If it's a very small annulus, prefer a supraannular self-expandable valve so that effective orifice area is more and patient process mismatch can be minimized. If it's a large annulus, prefer a balloon expandable valve, because larger self-expandable valve tend to dive in and create high chance of complete heart block and difficulty in positioning, provided the femoral access is good enough. So self-expandable valve for smaller annulus, balloon expandable for larger annulus, heavily calcified anatomy. A self-expandable valve with an outer skirt, like an Evolute Pro, would be more suitable.
I think TVL incidents must be coming down further, because your experience, you must be using the earlier version of valves also. Now, your data are all positive, but for the PVL slightly being higher, with the latest generation ones, that also would come down. I think
now,
this, yeah. Dr. Goyal sir, you're telling something.
Yeah, actually, I just wanted to point out a couple of points. In that puncture thing that I have observed, initially, we were told that you put the loop of the pigtail and try to puncture through that bullseye thing. So that gets you into the common femoral artery. That's right. But I have had an experience of doing that. You have to be very sure once you've done the puncture and then putting the ProGlide, you should have the pigtail back. Otherwise, once I had the ProGlide through the catheter, and it was a big, we resolved it. There was no problem. I did resolve it, but that can happen. The ProGlide needle going through and through the pigtail. So once you've done the angiogram, you understood where it is, then you pull back this thing. The other thing that I was just wondering, in a horizontal aorta, would you prefer a balloon expandable valve or a self-expanding valve? If the aorta is absolutely horizontal.
Balloon expandable valves.
Balloon expandable, you think is
the reason I would prefer a balloon expandable is you can come 90 degrees to the annulus. You can flex it and bring it 90 degrees to the annulus. Though everybody has done self-expandable also in a horizontal annulus, and everybody has got good results also. But if you ask me, and if I get a choice, a balloon expandable with a flexion handle. Now, if self-expandable can bring a flexion handle and you can make it 90 degrees, that would be better.
And the other thing is, I think these days what we are trying to do more and more, you did stress on that, is that RAO caudal rather than the coplanar view. Yes. Exactly. The RAO caudal view is better for getting the valve absolutely at 0 to 3 depth, to reduce the depth. That is much better, because otherwise in the regular coplanar view, you feel that it is in, but it is not in. It is still, so that is the difference.
Just one point I want to highlight, sir. If you end up doing a TAVI in an RAO caudal view, try to avoid post-dilatation, and that's because your valve is very high, and if you do a post-dilatation, it will pop out. So that's why I've started doing pre-dilatation for all self-expandables.
Okay.
I think, Ravinder, to encourage chat questions coming up, there is a
Yeah.
chat question which came from Dr. Rahul. How many per close prior to procedure for Indian patients, femoral artery, 2 or 3?
So now, sir, definitely no 3, not at all. 3, you would close the whole vessel.
1 or 2, you should say.
Yes. So I have switched to just 1 ProGlide. I do 1 ProGlide now and then see how my result is. And I end up putting a 6 French angio-seal. I'm trying to write that paper because now almost 50 cases of 1 angio-seal, 1 ProGlide, comparing with 2 ProGlides. 2 ProGlides, what it does in few patients, there is pinching of the vessel. And that is because, you try to crumble the whole tissue. But to answer your question, Dr. Rahul and sir, if you have a small vessel, just put 1 ProGlide. You might be converting that 14 French hole into a 2 French hole and somebody can hold manual pressure.
I think, do you have any experience? Manta, recently in one of the live cases, they were mentioning Manta can close with 1 up to 18 and 20 French with no appearance of pinching at that particular point, they were mentioning.
Manta is a large
if you use one ProGlide, till so you will use it till what French? Till 18 French hole or 14 French?
14 French, not an 18
French. 18 French is definitely
18 you have to put 2 French. Yeah. Okay. But for 18 French sheath, that means the artery is big enough.
Okay.
Yeah.
Regarding Manta, I have a point. It's too costly. Even people in the United States, they didn't kind of take it just like that. 3 times the cost of per close. And the advantage of per close is you have your wire access till Manta. Your wire access is out once you are done. Once you decide I'm going to deploy it, so you lost your safety point very early in Manta as compared to.
I think your voice is breaking in between. And other thing, what for early ambulation mobilization, previously we were all following puncturing of both femoral arteries and putting a vein on the left femoral. Now I think people are moving away from it and do only femoral artery puncture and then take radial artery for the pigtail positioning and then probably jugular, or people are pacing through the safari wire or whatever wire which you are using to cross. And did you do that? What is your protocol now?
So I did a live case at India Live. We paced it through the safari wire. But just to answer that question so that people don't, that radial and 1 femoral is probably a lot of experienced centers would do it. But if somebody is starting a program, they should have 2 femorals, because if there's a complication in 1 femoral, it's going to be very difficult to manage from the radial. So if somebody is starting a program, I would suggest both the femoral arteries, because at least you can go from the other side, put balloon, put some stent, wire, all those things. If you have a radial hardware, now if you have a hardware from radial which can go down to the femoral vessels, it's a different idea.
What people were suggesting was to put a 1 French puncture below the artery, below in the femoral artery, just to be on the safer side. And later on, you can avoid, patients can get a little early ambulant if you avoid both legs there. But as you said, it is always good to have both arteries if possible. I think if there are no further questions, we are finished our time. Dr. Goyal sir, you can introduce, I think, next speaker and then take.
Okay. So thank you. Next speaker, I think we had a good session on TAVI. So next is you're going to listen to MitraClip from Balbir. And as we all know, Balbir has experience on MitraClip. And I think he's just shifted to Max Hospital and we'll listen from him. So Balbir, you're going to talk on MitraClip.
Thank you, Dr. Goyal, and wishing the very best for your new venture. And thank you, Dr. Srinivas, and I thank Naveen for giving me this chance to speak. So we have done 4. I'll be presenting the 2 patients where we have 1 month follow-up. The other 2 are awaiting that. So 1 month follow-up is very important because you want to see what you did. So this is the first patient that we did about 1.5 months back. He presented with repeated heart failure hospitalization and was admitted only 4 weeks prior to his MitraClip. He has a very interesting history. He had an LCX PTCA in January 2018 for inferior MI, had a VT at 1 month, was implanted in ICD, had multiple shocks, had a CAR2 ablation in December 2018 for VT, then had AF, so had an AF ablation in 2019. 2021 February, because I thought AF is precipitating his heart failure. So I did his AF ablation. Then he had a cardioversion on the same day for AF. then a PTCA to RCA because he came with ACS in March of this year, but yet he was on heart failure, repeated admission, now class 4 symptoms. This is his TE echo. You see the valve not coopting. The ejection fraction is not bad. It is about 35%. So this was a clear indication that you have severe MR with the valve leaflet not coopting. So an ideal indication to repair this mitral valve. So obviously, he is a bad candidate for surgery with repeated admissions of heart failure. Not so, even though the age is favorable, but he was not so keen to get a surgical repair of this valve. So the ideal indication for us. This is a zoom picture to show the mitral valve is not coapting. You can see the leaflets. So what are all the things that we need to see? Leaflet length, the mobility of the PML, any calcium, the chordae. So you can clearly see the chordae here are intact. There's no valve perforation. The leak is central. Then you look at the mitral valve area, it's reasonably good. It was 4.5. So we had an ideal patient for a clip. So to start with, this was the patient. So we have two kinds of MR. We have secondary MR or primary MR. In the primary MR, transcatheter edge-to-edge repair was for high-risk surgical patients. And for secondary MR, which is heart failure, many patients are actually surgical rejects because of their heart failure, because of low ejection fraction. So transcatheter edged mitral valve repair will be a very interesting procedure for these patients. So now we have a patient who has severe secondary mitral regurgitation. His jet to the pulmonary veins showed in the reversal. On ARNI, on dapagliflozin, on ICD, best therapy that you can think of, STS score of 6, Euro score of 8%, was opted for a MitraClip. So what are the current indications? Severe MR, primary MR with a flail leaflet or mixed etiology, symptomatic patient, high risk for surgery. So what are the good favorable anatomy for this patient? Severe MR, we had an A2P2 defect, prolapse width was less than 15 millimeter, flail gap was less than 10, mitral valve orifice area was 4.5, and the mobile length of the posterior leaflet, which you could see. So these were good points, in all of them were good points in these patients. What are the contraindications for this clip procedure? Patient who cannot tolerate anticoagulation, who have active endocarditis, or who have rheumatic mitral disease, evidence of thrombus, IVC, femoral vein thrombus, ejection fraction less than 25%, and systolic dimension more than 55. So this is the procedural steps. So this is an SL1 sheath, which we routinely use for AF ablation. So this is the same sheath I've done. Puncture is guided with a TE, and after the puncture, you can see through the sheath, I placed two wires, one regular long wire and one an amplage wire to carry the clip and the other wire to carry the pigtail. So you see the pigtail has been placed in the left atrium to monitor the LA pressures, and the other amplage wire is lying in the pulmonary vein. T is an important guide to this puncture. You can see this is the aortic view. You see this is the tenting of the septum. This is very posterior because aorta is anterior. So the tip of the catheter is very posterior. So having achieved the posterior puncture helps you to align to the mitral valve quite well. This is the outflow view showing the two wires crossing the septum clearly. So whole guidance is on T. Actually, we hardly use fluoro during this procedure. The majority of the procedure is on T guidance. And the other part is that you should be as up from the annulus as possible, about 4 to 5 millimeters. So this was 4.2 millimeters, which was reasonably good. There was not much margin beyond this. So I was posterior and as high up from the annulus. So both the criteria were satisfied. This is the LA pressure from the pigtail. You see the aortic pressure and the LA pressure. Mind you, the LA pressure is a big V wave, which is in fact crossing up the aortic pressure itself. So we had a huge V wave, severe mitral regurgitation, and LA catheter really helps you to monitor the LA pressure throughout. The pigtail catheter helps you to monitor LA pressure. So you know whether you're doing the right things or not. So it's a very cumbersome steering system. And when I first saw the system, I thought it's a very tough procedure. I'll not be able to do it. The other good fortunate thing for me is that all this happened during the COVID era, and so there were no proctors. So if you're doing without a proctor, everything is on you. So you have to read it so carefully. You have to, each step you have to learn very well. So in fact, I did my T training with my echocardiographer for 10-15 days to understand the views. What is bicom view? What is outflow view? How do we assess MR? So it was good that I spent 1 hour every day for 15 days with him, with T probes, looking at MRs. Spent at least 4 hours on this system because it is a very cumbersome system to learn. And so we ended up doing this case, the first one, without a proctor. So you can see the multiple stents in the coronaries. Now we have the Amplatz wire into the pulmonary vein. I have the sheath with the MitraClip on it, and you can see the sheath crossing the septum. It's actually 24 French sheath, and I thought we'll have to do a balloon dilatation, but the sheath is so good that you don't need balloon dilatation of septum. It just crosses so smoothly. You can see how well it crossed the septum. Having done that, flushing and air, handling air is very, very important, and sucking the blood is extremely important. Now we see the clip entering into this sheath. So as it clip enters, you have to bend it towards the mitral valve. And all this happens not on fluoroscopy, but on, we have recorded this just because we wanted to record this case. Otherwise, we don't need fluoroscopy to manage most of the things. Now you see the clip is in mitral position. You see the two views that have been used, a bicom and the outflow view. Outflow view, you see the aorta. This is the clip which is open at 60 degrees and is holding both the leaflets. So you see the AML, how well it is held, and see the PML, how well it is held. Once you do that, you know exactly, here you see the clip is little outside. So we pulled the clip back, opened it, and tried to hold the leaflets. Now both the leaflets have been held. Once they are held, we close it. So having closed it, these are the two views again. The bicom view shows some MR. Now, in this MitraClip, since perfection is so important, this was my third attempt to capture it. And every time we used to see this MR and I was never satisfied. I thought I would want no MR with single clip. And finally, this was a third attempt, and it was an NTR clip. And I was still not happy to leave this jet. But I think finally we decided that 1.5 to 2 hours had already passed, that we'll take this clip, see how he behaves on the T after removing the clip. If we need, we'll put another one. So this is what we decided after this was the third attempt. Now you see there is some MR, but you see the clip has nicely held on to the leaflets. And now comes the release. Release is also a very integrated process. So this is the clip lying in the left atrium. This is the clip which is open. So you have to position the clip before it enters into the LV. You have to make that position before it enters the LV. And how do we make that position? This is the clip being released and having been released. So how do you make that position? This is the 3D end face view. So you see the aorta in front. This is the mitral valve. These are the two leaflets. You see the anterior mitral leaflet, it's flail. You see the gap when it closes. Now, when you place the clip, you have to place it like this, straight vertical, dividing the mitral valve into two. And you place this in the LA and then push the clip into the LV so that you retain that position. And you are not trying to manipulate too much in the LV because you have cardi and papillary muscle to play with. Now you see this clip is very nicely positioned, perpendicular to this mitral valve, cutting it into two orifices. So the two orifices are there. You see the double orifice mitral valve. This is what you want to achieve. This is the pulmonary vein, which was reversed. It's showing a normal pulmonary vein flow. And you see the LA pressure fall down immediately while we clipped. It was above the aortic pressure. We saw that. And it was now 23. From 77, it was 23, which was quite a relief. We left some MR at that point in time, which I showed you. But this is the 1 month picture, which shows hardly any MR. So the LV dimensions came down. LV ejection fraction improved 45%. And you see hardly any MR. This is what it is at 1 month. This is the 4-chamber view. Hardly any MR. There is a jet, I agree, but this was clinically, he's asymptomatic now and feeling much, much better. So what is new in MitraClip? The mitral FR trial, co-op trial, expand G4. So briefly, I'll discuss that in interest of time. So MitraClip helps to co-opt the leaflets, restrict annular dilatation, helps reverse the remodeling, and is a great tool to improve symptomatically these patients. So percutaneous, the MitraFR was the first trial, less number of patients, only 300 randomized to two groups, did not find any difference on all-cause death or hospitalization at 1 year. There was a lot of debate and discussion. The limitations were small numbers, exclusions of a lot of patients, not including patients with severe MR. They included some with mild MR also, and including some very sick patients with less than 20% EF, LV dilatation more than 7. So that's how these data was criticized, leading to a co-op trial, which was an American trial. Key inclusion was LV and systolic dimension less than 70. Inclusion was less than 70, and moderate to severe MR at least, with a functional class 3 to 4 in majority of patients, high BNP. So there were very sick patients included in this trial. All failure hospitalization to 24 months was a major primary outcome, and MR all-cause mortality were other endpoints. So they had about 665 patients randomized. Baseline characteristics, I'm not going to discuss. So this is the data at 2 years. So a remarkable improvement in the outcome of hospitalization for heart failure. So the 2 patients who have completed 1 month follow-up in our listing are asymptomatic with a 1+ MR on echo. Both had 4+ MR. So freedom for device-related complication, 96.6%, which makes this procedure very, very safe. So all-cause mortality also was a reduction at 24 months. Very encouraging results. So the question comes that the quality of life is improved, mortality is improved, heart failure hospitalization is improved in this group of patients. So the patient selection comes to be the very important criteria in these trials. So you can see MR severity definitely improved. Now we accept 2+ MR as an endpoint, which is also quite reasonable. From 4+, if you get 2+, it's quite a reasonable endpoint. So why co-opt results are so different from MitraClip results? The inclusion criteria were different. Like, for example, the regurgitant orifice area was more than 30 in the co-opt, while it was more than 20. So that means mild MR was also included. LV and diastolic dimensions were much higher in the MitraFR trial than the co-opt. So co-opt had a cutoff of the dimensions of left ventricle. So in March 2019, FDA expands indication for MitraClip therapy for secondary MR is indicated for treatment of symptomatic moderate to severe or severe mitral regurgitation with MR grade 3 or more in patients with LVF of more than 20% and less than 50%, with LV and systolic dimension less than 70, whose symptoms and MR severity persist despite maximally tolerated medical therapy now with SGLT2 and RNA. And a multidisciplinary treatment heart team approach is always needed in these patients. So in severe MR with suitable anatomy, this procedure will stand to really be one of the important procedures. And presently available in NTR are the NTR and XTR clip. In the second patient, we have used an XTR and an NTR both. XTR is really more difficult to manipulate, being a bigger clip. So we have co-opt and MitraFR trial as the major trials. We're waiting for expand G4 trial. And guideline recommendations of MitraClip change rather rapidly with increasing data. Thank you very much, everybody, for your hearing.
Thank you, Dr. Balbir, for that nice talk. I just had a few points on this MitraClip. One is, well, I feel it is technically a little more difficult procedure, as you also said, but I think if you read, then probably you do it. Okay. The second point is, I think age may not be as important here as the condition of the patient, because the patient has MR which is significant and LV which is in between that 20 to 50%. Then whether he is older age or he is even in an age of 50 years, I think a MitraClip could be done, because If MR continues or something happens and whatever, surgery may not be the right option at that time. So that is what my thought is. You can comment on that. And the third thing that I wanted to know from the technical point, if you could re-explain what is this, because what is this flail gap and what is the flail width? Can you do this? Because we keep talking of the flail, and why is it that only 3D? Can't you do it with 2D TOE and everything? Why do you need 3D? Is 3D a must? Because I was told, because I was wanting to work up a case, I was told that 3D echo is a must.
Right. So first answer the last question, is 3D a must? I think 3D is a must. You will not be able to place it well. You have to have end-phase 3D view to actually position that clip well. There is no other way. Yes, 2D was being done before 3D came. Saibal has done a lot of cases on 2D, but it's going to be very, very tough because you have to position that clip right perpendicular to the two leaflets, and end-phase 3D view is what will give you the absolute.
When you say perpendicular to the two leaflets, like the view that you showed, aorta at the top and the mitral valve orifice in circle below, and the leaflets. So you are going parallel to the two leaflets when you go in with the
no, you're going,
or you are going perpendicular to the two leaflets. You get
so you go perpendicular. So you make your position in the LA, use that same position, because you will get very little chance to manipulate in the LV. LV has chordae, LV has papillary muscle.
Right.
Your clip can get engaged there if you're moving that clip too much in the LV. So you have to rotate, do the rotation movements in the LA, make the position perpendicular right in the LA, then position the clip at 60 degree, enter with the same position into the LV, open the clip again, reconfirm that you're perpendicular to the two leaflets in the end-phase view, then close it at 60 degree, see whether you've held the leaflets well or not. As I showed you at 60 degree, both the leaflets were held, then close the clip. So these are very important steps. So 3D is an absolute must. If 3D was not available in the country, maybe some people would have tried on 2D, but I cannot imagine how difficult. I can imagine it's going to be very tough doing a procedure on 2D. Now, the second question is that it can be done at all ages. Yes, but one has to remember this is a long procedure, generally take up to 2 to 4 hours, and is all under general anesthesia because you're doing a T entire procedure for you're doing a T management. You will have to be on GA. So the general anesthesia patient has to have the general anesthesia clearance. So anesthetist has to hold on to the procedure for 4 hours or 5 hours, which may happen. The third thing is that it is technically challenging. There is no doubt about it. It's much more challenging than TAVR procedure. But the fact remains, in TAVR, you're rushing with things. Here, you're not rushing with things. You have time to think because you are not hemodynamically compromising the patient. So you have that time to think, redo, open the clip. If you're not happy, go back again. I did 3 times in this patient. In the second patient, we did 5 times. So you have chance to go back again. You have a chance to get another clip. TAVR doesn't give you that many chances. So this is the advantage you have with this procedure, but it is definitely technically more challenging than TAVR.
So can I ask?
So what is flail gap and flail width? The last one.
So this flail gap and flail leaflet. So gap is seen where they don't join. So that is the gap. The width is the leaflet. How much leaflet height is flail. So you calculate distance. So gap is the width, and the flail width is the length of the leaflet, which is flail. How much leaflet? So if it is more than 8 millimeter flail, you will have a tough time getting hold of that.
What do the guidelines say, Balbir? Now age is not at all, because we do see a lot of younger patients like 45-year, 50-year dilated cardiomyopathies, non-ischemic with severe MRs. Do you feel they could benefit by this? People say that LVs regress and pressures significantly improve.
Definitely it will improve.
The guidelines, do they have anything on that point? So
guidelines, I showed you the 2019 guidelines, clearly mentioned secondary mitral regurgitation. Now this becoming a procedure of choice in many patients. So earlier the STS score and operability was a big issue. It's not anymore now. So the guidelines are favoring secondary MR functional MR as a very important indication for, and the kind of improvement that we saw at 1 month in these two patients was really phenomenal.
Actually, what I would say is that if you feel that the patient's longevity will not be compromised as much by his ejection fraction, and MR is contributing to his worsening, I think a procedure should be done. If you have a patient who has a LV of 15%, he would otherwise die because of that 15%. Then maybe it may not be helpful. But if you have a patient with 35% and some moderate MR or moderate to severe MR, I think that is the patient who should be done irrespective of age. This I can only say from my wisdom of the clinical cardiology.
Yeah, so I totally agree, sir. And it was an excellent presentation, sir. Great presentation. And I agree. In fact, the very first case which I did has completed 1.5 years. And I'm going to come to that point which PK Goel sir pointed out about ejection fraction. What the studies have shown and our small experience tells us. What are the LV internal dimensions? So if you look at the COAP trial, the LV dimension was within 70 mm. So if you have a LV which is bigger than 70 mm, it's more like a globular, and those patients might not regress. But the most important thing we should also evaluate is the RV function. Now, sometimes these patients with severe MR and dilated cardiomyopathy might have poor RV function. These patients will not do better. But age for a functional MR, I would suggest that age is the age should not be into a consideration because nobody is going to operate a functional MR, and that is why you see the trial. Patients, I don't remember the name of the trial, but patients who are on the heart transplant list, after getting a MitraClip, they were off-listed and they did not require any heart transplant. So I think case selection is very important. Regarding the technicality, it's a very safe procedure because you are on the vein side, you are on the venous side, you are working in the LA, you are not even on the LV side, patient is not being hemodynamic compromised. It takes time, and I think proper understanding of T is very important to complete the procedure. The only way a complication can happen is if your clip embolizes or you can tear a leaflet. Now, the 3D TE is must, sir. The only way to get a perpendicularity on a 2D TE is somebody who is expert in getting a transgastric view. So if you get a transgastric view, only on a transgastric view, you can make an emphase of the mitral valve. But 3D TE is must, sir.
Regarding Dr. Goel's comment about flight width and flight length, these are all the criteria that was utilized in Everest 2 trial.
Yes.
Everest 2 trial, why the trial failed is an important point. They, irrespective of the risk, they include all patients with primary MR. Flight gap is if in short axis transgastric view, how much is the distance between the medial and lateral side of the particular P3 segment or P1 scallop. File width is the length, the length at which the PML is away from the AML. They initially took 10 millimeter and 15 millimeter. Nowadays, the patient feels, the surgeon or the operator feels that the particular patient is high risk. Those criteria are not being considered for primary MR clipping. Those criteria are not mandatory for secondary. These are only for primary MR. For secondary MR, it is whatever Dr. Ravindra told. LV internal dimension, RV should be fine. RV function should be, PAH should not be severe. Most important criteria is the 3 subset of tier groups in COAP trial. Tier 1, Tier 2, and Tier 3. 1 is the EROA more than 0.4. Tier 2 is EROA less than 0.4 but more than 0.3. Those subset of patients can also be included, provided we have other criteria like pulmonary venous flow reversal, vena contractus, then regurgitant volume more than 45 ml. Irrespective of the patients falling into Tier 2, Tier 3, or Tier 1, COAP clearly showed that beneficial effect was seen in all the 3 tier groups.
Can I ask a question to Balbir sir and all the experts? Sometimes you would see in our patients, in the OPD, a patient has severe MR, and then we called him for a follow-up at 1 month to evaluate for MitraClip, and now the MR is mild. Does anybody do a stress echo or maybe increase the blood pressure as an OPD basis to evaluate the MR, Bhupati sir?
That's a very, very important question. May I answer that? In COAP trial was very, very stringently done. That was the reason why it was successful. Every third patient was excluded. after GDMT. If you look at the co-op trial, ARNI was utilized only in 4 or 5%. AC inhibitors were more than 90%. The patient has to be on those drugs. 1/3 of the patient, the grade 3 MR becomes grade 1 or 2. And if it is grade 2 or 1, they exclude those patients. So GDMT really works in 3 or 4 MR. It drops down the MR by at least 1 or 2 grade if the patient is an appropriate dosage. So that is the plus point about co-op trial. Those such a stringent criteria were not utilized in MitraFR. That's another reason why the particular MitraFR filed.
Stress test to evaluate MR, sir? Anybody, Bhupati, sir, and anybody does there in a practice?
It's not been studied. So I don't have any experience with stress test related MR. But you know, we used to ask the patient to do exercise if the patient has got some amount of MR to assess the PAH function, PAH pressure in Cath lab. That is a different story, but definitely stress will increase MR. That's a terminology what they use called as a eclipsing MR. During specific exertion or specific activities, MR comes and goes. There are reported case series where eclipse MR was clipped or patient went for surgical.
Sir, we are running late by 10 minutes. Shall we stop here and move to the next session?
Yeah, thank you, Naveen, for the opportunity. And we had good discussion both on important aspects. Over to you now.
Thank you.
Thank you, sir. Thank you, Dr. Balbir. Thank you, Dr. Rao.
Thank you so much.
Dr. Goyal, Dr. Srinivas, Dr. Bhupati, Dr. Manik, and Dr. Ankur. So the nice discussion, nice, the session. Now we are going to move to the next session, that is on role of imaging in cardiology, and over to Dr. Devendra for further proceedings.
Good morning, everyone. And in the next session for next 40 minutes, we will be discussing on imaging, especially on OCT. And there will be 2 speakers, and the chairperson for the session are Dr. Viveka Kumar and Dr. Amitabh Yadvanshi. Dr. Viveka Kumar is Principal Director and Chief of Cath Lab at Max Hospital, Saket. He has more than 20 years of experience in cardiology with extensive experience in various cardiac intervention and electrophysiological procedures, including complex multivessel bifurcation and left main angioplasty, even in calcified vessels, and in various imaging procedures, including FFR, OCT, and he has many academic and professional excellence awards, including International Award of Excellence in Cardiology from St. George Hospital, London, Lifetime Achievement Award by Gastric Society of India, Chikitsa Ratna Award, Vidya Ratna Award, and many more. He has more than 50 publications in various international reputed journals, and he has been an investigator and participator in various trials. And our second chairperson for the session will be Dr. Amitabh Yadvanshi. He is Unit Director, Interventional Cardiology at PSRI Hospital, Delhi. And has more than 17 years of experience, specialized in the various complex cardiac intervention procedures, and also in electrophysiological procedures and various device implantation. And again, he has various national and international publications. His innovative work on renal denervation therapy of resistant hypertension also is there. And he has done various ECMO procedures also. So for the next 40 minutes, I hand over the session for Dr. Amitabh Yadvanshi for moderating the session. It's over to you, sir. Audio.
So you are mute.
Sir, your audio is mute.
Yeah. Can you hear me now?
Yeah.
Yes.
Good morning, sir.
Yeah, good morning. Good morning, everybody. And it's indeed a pleasure to have this conference, and congratulations, Naveen, for this wonderful conference. I am unfortunately at Srinagar, and the internet connection is quite dicey here. So can I request Naveen to present the slides of the speakers, the introductory slides, or do you have them?
So the first speaker will be Dr. Praveer Agrawal.
Yeah. So I just wanted to introduce them. So I don't have those slides right now because I am on my phone. So just give me a second. I will just. Sure. So Dr. Praveer Agrawal, I believe, needs no introduction. He is the Director of Interventional Cardiology. Can you hear me now?
Yes, Amitabh. Yes, yeah. Dr. Amitabh.
Yeah, Dr. Praveer is Director of Interventional Cardiology at Fortis Escorts, and He is a alumni of KGMC Lucknow and did his DM from Kanpur. And he's had more than 25 years of experience in interventional cardiology and has done more than 1100 angioplasties, does more than 1100 angioplasties annually. And he's master of complex calcified interventions. We all know that. And he has been guest to various national and international congresses. And he has trained more than 100 interventional cardiologists who are doing great work across the country. So welcome, Dr. Pravir, for this meeting. Our next speaker would be Dr. Mantri. Dr. Mantri is Director, Cath Lab and at Sir Gangaram Hospital, New Delhi. And he is also keenly interested in complex coronary interventions and multivessel PTCA, which includes rotablation, CTO interventions, and various imaging modalities. He's an expert in device closure for various types of congenital heart disease and pacemaker implantations. And he has more than 50 publications to his credit, both in national and international journals. So welcome, Dr. Mantri. The next will be Dr. Devendra Agrawal. He's our panelist, and he again is the principal consultant at Max Hospital, Shalimar Bagh. And he has more than 13 years of experience. He has keen interest in imaging and complex angioplasties. He has published in national and international journals and has abstracts that have been submitted and accepted at various conferences nationally and internationally. So welcome, Dr. Devendra. I would also like to introduce Dr. Samir Kubba. He is an associate director at Max Hospital, Vaishali, Ghaziabad. And he has done his DM from PGI Chandigarh. He has more than 15 years of experience and is proficient in handling all kinds of cardiac emergencies. He has been instrumental in establishing the primary angioplasty program at Gurgaon at the Artemis Health Institute. And he has numerous research papers and publications in his name. And he has been awarded with the most educational case at on PCI at the Asia PCR Singapore Live 2012 conference, and also the Best Case Award at Interventional Cardiology Conference at Washington, D.C. in 2014. So welcome, Dr. Samir. And the next person I would like to welcome is Dr. Preeti Sharma. Is a old friend of mine, Associate Director and Head of Department of Cardiac Sciences at Dehradun. Dr. Preeti has over 13 years of experience in her field of interventional cardiology, and her area of special interest includes complex coronary interventions, bifurcations, left main, and CTOs. Again, she also has various publications in national and international journals, has worked as an investigator in the Everest trial, Women's Achiever Award for Excellence in Cardiac Interventions in 2017, Health Icon Award of Times of India 2016, National Faculty for India Live Conference, International Associate Fellow of American College of Cardiology. So welcome, Dr. Preeti. And with that, I would request the first speaker to start his deliberation.
Thank you. With due permission, Viveka.
Yeah.
And Naveen, can we start?
So yeah, welcome to Dr. Pravir Agrawal. So he'll be, speaking on how relevant the OCT is just the hype, or the reality is that, this adds a lot of, dimensions and help in our complex interventions. So Dr. Pravir will be doing the justice to this. No better person than him who can, see the role of OCT in complex PCIs. So Dr. Pravir, please share your slides and go ahead.
Yeah. Are my slides visible? Can you see my slides, please?
Yes, you can see that. Yeah.
Yeah. So it's like a debatable thing. It's a hype or a necessity. So Naveen has put me into a great point that whether I'm what kind of message I give in the end. But I tell you the truth about this OCT, which is to me initially was looking maybe a hype, but now we realize it is becoming a necessity. Now to just see, for an experienced IVUS user, because all of us have been using IVUS for a long time, OCT offers an exponential increase in resolution, speed, and accuracy that we all know. It's a superior resolution, almost 10 times better than IVUS, and maybe it's a superior pre and post images. And not a rocket science. You can have some experience and you can just do it very, very easily. The speed is tremendous. You can take about 36 millimeters per second. Robust clinical evidence. Like we are not talking without evidence. Like it's a CLI, OPCI, and CLI OPCI 2, Opus class, Illumin 1, 2, and 3, and the future trials are Illumin 4, and other areas of concentration are complex procedures, DVS, and ACS. Let us see in the detail of it. OCT is a registry for OCT, CLI, OPCI that showed clearly at 1 year of follow-up, if you are using OCT imaging during PCI, you are having better outcomes in the term of cardiac death, MI, and repeat revasc. The numbers are not good, but still, it is really significant, about 15.1% as compared to 9.6%. Like you can have really not a great difference, but still the trends are really good. So they showed clearly that if you're using the device, you are like benefiting the patient. Illumin 1, that showed that the significant reduction in MACE at 1 year due to detecting 32% malapposition, 32% edge detection, 27% under expansion, which is in contrast to optimally like successful angiographic guided PCI. So it's a significant number if you compare with optimally like a successful angiographic PCI. Element 2, that again showed the MACE rate with these was less because of more detection of malapposition and dissections than IVA. But if you see a stent expansion was similar. Element 3, that clearly showed superior to IVA's guided PCI at detecting certain predictors like of major cardiac events. One is major dissection, second is malapposition. So these are the two factors which ultimately lead to the MACE X maybe sometime maybe years or 2 years later. Again showed if you just compare with the angiographic guidance, it's a significant better expansion of the stent if you just compare with the routine angiography for that. Third thing is that if you just see the IVUS versus like OCT in the stent expansion, they are similar in both. Like Clinical Research Initiative is a long experience with them. They say in about say pre and post procedure, if you are doing an like OCT, you are changing your like some or other point of like interest, maybe the pre-morphology, length, diameter, post dissections, position expansion about majority of patients. I would not name the number. Number looks huge. Eye optical study again is the South Asian study, and they determined that the pre-PCI strategy change involves need for lesion preparation, change in the intended stent length size, and intended device landing zone. And post-PCI, you can look at the like stent malappositions, as dissections, and stent under expansion. So all these factors were considered, and not to our surprise, the variables analyzed were lesion preparation, intended stent length, intended stent diameter, intended stenting strategy, and landing zone. And just see, in majority of patients, there were minor or major modifications, almost 90% of patients. So to me, it looks like it's a good device. Now let us share some examples. This is a 68-year-old gentleman, like who comes with an instant restenosis. Like the stent was placed a couple of years back, maybe about 8 or 10 years back. He comes with like a good angina. And after the initial 2 minutes of balloon dilatation, then OCT run was taken. Now see this plaque. This plaque is fibrotic and calcific. Like if you see the whole area, the arc of calcium is more than 300 degrees. Microns is about 700. So if you don't modify these plaques, the stent expansion within a stent becomes really difficult. So after seeing this one, initially we were not intending to just one rota. We were planning initially just take a cutting balloon down as usually we do in a like instant restenosis and put the stent and come out. So it's gentle and with the 1.5 bar good drilling, taking about 4 or 5 minutes of drilling time so that good heat is delivered and the plaque is modified. And still you're not leaving there. Then take a just balloon down for a like diagonal which was closing off, and then take a optimal size cutting balloon, right, and make a good lumen there. and then take a 2.75 as the vessel size, take a 2.75 stent, deployed at nominal pressure, then go with a high pressure balloon with the same diameter 2.75 and see the OCT run. The stent looks well opposed, well open. If you see the areas, it's fine at proximal distal edges, but in the middle of that, the area looks a bit smaller than what at the edges. But the stent looks well expanded. You don't see any areas of malapposition or like that, but still you want to improve on that. Just see this area in the center, it looks like slightly less done. So after doing in this OCT run, we took an 0.25 oversized balloon and did at nominal pressures, maybe slightly higher pressures, and just a reasonable result in this kind of bad freeze. We know that all these lesions with the restenosis, they come back very, very soon if you don't do a good job, at the second setting that you got a chance. Now see this lady. This lady comes with left main disease with the osteophyllary disease. Previously, she had an angioplasty to mid LAD and the circumflex about 6 or 8 years back. She's doing all right. And now this is a lesion. This is a bad lesion, but the circosteum is fine, and it's a fibrotic plaque that we know initially. So we took the initial run with the OCT, with the IVUS. We just see the morphology. So in IVUS, what we saw is that the diameter of the proximal LAD is about 3.75, and the left main is measuring around 5.5 or maybe 5.6. So the great discrepancy in the size of the distal LAD, proximal LAD, and that distal left main. So after the IVUS, and IVUS also showed it's a fibrotic lesion. It's not a very bad calcium there. So we just did a 2.5 balloon to just make a room there, and just to take a 3.5 cutting balloon at say nominal pressures to just cut the plaque as usual, because the osteal lesions behave badly if you don't cut them up. And then it's a 4-0 stent. Let's go to the next one. Yeah. Deployed at nominal pressure, reasonable opening. Then this opposed dilation because proximally the vessel was looking 5.5, 5.6. So this was about a 5 mm balloon, a short balloon. Did about reasonably high pressure, about 18 atmospheres. And see this, what happens. I see this area in the LAD looks a bit hazy here. It's still approximately not up to the mark, and the stent we took can go up to about 5.7. So circosteum is looking fine. So we just did an OCT run to just see why this haziness is appearing. Now see this image. This is a distal stent, which is doing reasonably well deployed, not much of ingrowth. In the middle, there's a small, you can see dissection, but it's not really compromising. And now this stent that we have used from distal left main to distal LAD to proximal, the proximal LAD to left main. Now see the proximal structure. You can clearly see here, the stents are underexpanded, despite we doing a 5 balloon till this point. But to our surprise, with a 5 mm balloon at say maybe about 16 or 18 atmospheres, the stent has broken across the circumflex ostium. That's obvious. We were seeing that haziness which we're looking on the angiogram. Keep seeing this picture. And you see the struts are slightly more open than what they should be, and the proximal edge is not deployed, as you can see it here also. And you see this, the struts are broken there. They are hanging. See the next picture. The same thing in zoom view. You can see that all struts have broken. There's no integrity of the stent at this place, but still is holding on. We knew the proximal the stent is not very well deployed. It's not opposed because the artery there is 5.7, and we have already done only 5. But seeing this architectural damage to the stent, we did not dare to go up with the stent, with the like balloon again. And let me show you the last angiographic picture. It was looking reasonable. So though it is looking like proximally underdone, but still, this was done in January and we left it because this was still around, say, maybe 4.75 or maybe nearly close to like 4.9 at proximal edge. So we left it there and till now she's doing fine. But supposing the OCT was not there, I would have gone easily with a 5.5 balloon at the proximal edge because the stent will take about, say, 5.7. So I did not do it, seeing that the circ is also doing fine. The lady clinically is doing fine. I saw last month, she's doing all right. So I left it there. Now see this patient. Let me just go, yeah. It's a lesion in the young, about 47 years old, and all these are diabetics have got fibrotic lesions. So the OCT run. Initially, it would look like just go with the balloon and just come out with the stent. The OCT run short. The lesion is mainly fibrotic. And there's some calcium also sitting here, and the fibrosis is good. It's a good fibrotic lesion. If you don't prepare the bed well, the lesion is not going to give way, and you will have an under result with your stent. Now it's a regular balloon, and then now the vessel size is coming 2.75. The 2.75 cutting balloon at about 14 or 16 atmospheres to cut it all around. After doing that, 2.75 26 stent as defined by the OCT, deployed at reasonable pressures, nominal pressure. Then taken a 2.75 balloon at high pressure, which is around 18 or 21, but the same size. And see the OCT run. The stent look well deployed, no doubt about it. But see these areas. This is near the proximal edge. You can see hardly any struts covering the lesion. Here you can see the struts, they are very well defined. Here you can see the struts, they are very well defined. But in the center of, like near the proximal edge, you can see it here also. The struts are like widely apart and they are not as close as in the normal architecture of the stent. Here the stent has gone elongated. When we measure it, the stent was placed at 2.75 and 26. Now this has become nearly close to 2.29 or 29.5, close to 30 millimeters. So the stent has got proximal stretching without any undue pressure on the stent, and this has happened. This all is a fibrotic lesion. And we often see if you oversize the balloon, you can do that. But this is a nominal size balloon, 2.75 versus 2.75. So you are concerned that this proximal LED is one thing that you don't want to just leave it like that. But still, we took a picture. Picture is looking reasonable. You can see some areas now, once you've seen an OCT, it looks slightly more maybe hazy, just as a thought. But we left it there. And this was done in October 2020. The patient's still doing fine. So what the clinical significance of this finding, I'm not sure. But still, it is to be noticed that the stent got elongated in the proximal segment. And it's clearly shown on the OCT, the length, which was, why we noticed that is, the stent placement was here. And we could see the stent is coming to ostium. We said, look, we did not place the stent in ostium. Why are seeing the stent as ostium? So that was the reason that the stent got elongated from 26 to 29.5. Now see, this is a like lesion, which is now the bioabdominal scaffold has come in picture. And we know that angiographically or by maybe an IVS, you can't see much of these scaffolds in today's life. So it's a regular balloon dilatation. And now the OCT run to see the fibrotic lesion. See this fibrotic lesion. There are all diabetic patients with a strong family history. And these lesions are really bad to dilate, very, very bad to dilate if we don't prepare them well. They look simple, but they are not. Now see, it's a like 2.5 cutting balloon at high pressure. High pressure means about 16 or 18 atmospheres to make a good room there. And the 2.75 scaffold, because it comes in minimum is 2.75, deployed at nominal pressure. Now it's a same 2.75 balloon at high pressure, about say 23 or 25 atmospheres, and an OCT run. You can see the scaffold is very well deployed. I'll show you the running picture. So that will show you the scaffold is very well deployed. But if we just compare the MLA in the center is looking less than what it should be. The proximal edge is fine and the distal edge is fine. Despite being the deployment is looking reasonable on OCT. We just went a quarter size up, 3 meter balloon at high pressure, and the end result is looking very, very gratifying. This is a different view. It looks nice. So it's a very well deployed stent, and for a scaffold, the high pressures are about 23, 25, not 17 or 18. Now see this one again, the same patient with RCA, which again, we will behave in the same way. And see the fibrosis. It's a gross fibrosis surrounding area. See this whole area. Again, the same strategy, put a cutting balloon of nominal size because we opened to 2.5, we'll use the same balloon. And a 3O scaffold here, and then 3O dilatation. And just see the OCT run. The stent is looking very well deployed, and you see these sets are looking so beautiful, these boxes. Here and there you can see mild malapposition, mild, very, very minimal. So with this scaffold, there's a quarter size over balloon, which is already provided with that. So after doing this, we just took a 3.25 balloon and get went hyper at the same result of that. So to summarize, OCT has become an important adjunct to the present day PCI procedures due to high resolution and short learning curve. If one has time and finance, it can be used in majority of patients to improve upon your PCI results. If one is in trouble, it can provide useful information to resolve the problem. And to me, it is mandatory adjunct to BVS therapy for adequate blood preparation and stent expansion. Thank you. Thanks for attention.
Thank you, Dr. Pravir, for a nice lecture on this issue. And I think at the end of the second talk, probably we'll have the question answer. Is that right?
Yeah, perfect.
Yes, I think, Amitabh, if you allow, we can go to the next talk. Dr. Mantri will be speaking on intracoronary imaging in acute coronary syndrome. So I think there's a lot of things to learn in, and the insight which is given by OCT, which I'm sure Dr. Mantri is going to highlight that. So over to Dr. Mantri for his talk on this topic.
Thank you, Pravir. Thank you, Vivek. Thank you, Naveen, for inviting for this talk. Now, I am in a remote town in Rajasthan where electricity and internet both are unpredictable. So I will try to finish.
You have the OCT there, isn't it?
Yeah, I have OCT slides. So I will be discussing few cases, some theoretical discussion and few cases about OCT and acute coronary syndrome. So my slides are not moving. How to move them? Can somebody help me in moving the slides, please? Slides are not moving. What should I do?
Hello.
You can
just
go
enter.
and
Just enter.
I think you can go back and before loading, you have to enable the content and then.
Okay, I will stop sharing and then I will share again. Maybe.
No. First write that click the button, enable the content, and then starts.
Where should I click?
When you open the PowerPoint, on the top, there may be.
Yeah. Share.
Yeah. Now share it again.
Okay. So let me come to. Okay. So OCT in acute coronary syndrome, it helps in determining etiology. So before OCT, we were reliant on largely angiography, and then there were IVUS. But after OCT, we had clear understanding that majority of MI are due to three phenomena. Either it is plaque erosion, plaque rupture, or calcific nodule. Rarely there are other things like spontaneous coronary artery dissection. It also helps in choosing the correct size and length, as has been highlighted by Praveer. It also helps in optimizing PCI result and so on. So the basic difference is between plaque erosion and plaque rupture. So majority of patients with conventional risk factor are with plaque rupture, 60 to 70%. Plaque erosion is seen in 20 to 25%. Now, patients with plaque erosion usually do not fit in conventional risk factor. Most of them are young, maybe women, maybe smoker, and plaque rupture, majority of them will present with ST elevation MI, erosion, non-ST elevation MI. In plaque rupture cases, there are chronic atherosclerosis, so there is positive vessel remodeling, what we call is Glauco phenomena. And there is no plaque erosion, there is no diffuse and chronic atherosclerosis. So there is no remodeling or rather negative remodeling. Plaque rupture is lipid-rich, thin-cap fibroateroma. They are fibrotic, no necrotic core, and intact intima in plaque erosion. And majority of thrombus is main content of thrombus is red in plaque rupture, white in plaque thrombosis. And this is the pathophysiology of plaque erosion because of shear forces and deleterious effect on endothelium. There is denudation of endothelial layer, and the present technology can't see whether the endothelium is intact or not. So we call the fibrous cape is intact or not. And these are the OCT pictures of some of the cases, how the plaque erosion may look like. And this one study was done in large number of patients of OCS. 7 centers were from Japan, 3 from US, 1 from Europe, and they have found that these are the mechanism given. So in ST elevation MI, majority were plaque rupture, but there were significant number of plaque erosion. And non-ST elevation MI, plaque erosion was more in number. And they have certified certain, investigated certain criteria, that is younger patient, anterior ischemia. So young patient, it means less chances of chronic atherosclerosis. Anterior ischemia, basically LED territory. So since plaque erosion is related to endothelial denudation, it has been found that the artery which more branches have more chances of plaque erosion because the shear forces are maximum at the side of branching. Now, these patients are usually non-diabetic, they have normal kidney function, and important, no anemia. So it has been found that patients who have high hemoglobin, that is more than 15, are having probably more viscous blood and more chances of plaque erosion. And when all 5 parameters were present in this study, plaque erosion was seen in 73.5% of cases. This is a plaque rupture. This is a wrong level. So in plaque rupture, there is presence of fibrous discontinuity. There is communication between lumen and inner core of plaque or cavity formation in the plaque. And it is usually lipid-rich plaque, thin cap fibroateroma, and necrotic core. Now in plaque erosion, there is attached thrombus overlying an intact or visualized plaque. Or there may be luminal surface irregularity and nothing else at the culprit lesion, and there is no thrombus if the patient is investigated late. Or if there is large amount of thrombus is present and you can't see the fibrous cape or underlying plaque because of this thrombus, then the criteria is that within immediate proximity of this, there is either no calcium or no lipid-rich plaque. So these are the criteria to diagnose plaque erosion. And these are the certain frames of plaque erosion. Here you can see it is dominantly thrombus, but you can see intact intima. Again, plaque with just attached thrombus. Most of the pictures show similar. There is plaque, intact this layers, intact this fibrous cape, and there is just some attached thrombus. Calcific nodule is usually seen in elderly patient with CKD, tortuous vessel, heavily calcified, and intimal rupture and protrusion of calcium into the lumen. And This is typically how the patient presents as calcific nodule. This calcific nodule erodes into the lumen of the vessel, and there is eroding of the fibrous cape, and this leads to thrombus formation. Then the three things were combined in this study together, published recently, that is near infrared spectroscopy to look at the amount of lipid, IVUS and OCT. And they have come out with certain criteria that in plaque rupture, within 4 millimeter segment, there is lot of lipid, and there is the discontinuity of the fibrous cape, and there is a communication between intima and the media. Then in plaque erosion, you don't see much of cholesterol, very small amount of lipid, predominantly thrombus. And in calcific nodule, again, the lipid amount is very small, and it is predominantly calcific lesion. And these are the criteria they have given. So if there is convex calcium, if it is present, it is calcific nodule. For other, they have given based on evidence of definite plaque rupture or probable plaque rupture based on lipid content of the at the lesion site. And we all know about erosion study which was published in 2017, and it started the debate whether all patients who present with ACA should undergo stent implantation or not. This was a small study of 60 patients, but majority of them, 92% roughly, were free of symptoms, just managed on medical therapy alone, if the underlying mechanism was plaque erosion. So just I will quickly go to 3 of my cases. Case 1 is a 30-year male, history of acute MI. This is the ECG at presentation and before the study. Initially managed with LMWH and DAPT, and then taken up for angiography. And you can see there is filling defect in the proximal LAD. So even in absence of OCT, probably most of us would have treated this case conservatively because there is no flow limiting lesion. But OCT has given us better understanding. So this is the OCT picture. And initially you see a side branch with thrombus, then there is predominant white thrombus. And most of the vessel is normal. And these are the OCT segmental analysis. So you can see this was plaque erosion. We left this patient on medical therapy. Follow-up after 2 months, patient remained asymptomatic. These are the angiographic pictures. So no visible intraluminal filling defect. And this is the OCT run. Now the surface looks very smooth. There is thick fibrous cape. The side branch ostium which contained thrombus, all thrombus has disappeared practically, and smooth lumen. There is of course some non-atheroma which is not lumen compromising. And these are the comparative pictures. So initially there was thrombus at the site of side branch, no thrombus now. And similarly, where there was marked thrombus, there is reduction in the lumen, increase in the lumen area from the previous. Case 2 is a 62-year male diabetic hypertensive post-pacemaker admitted with after 15 days with history of chest pain. ECG was inconclusive due to pace rhythm. Tropi was grossly elevated. Echo showed wall motion with EF of 48. The picture. You can say just about 50% plaque, but let us see what the OCT reveals us. So this was the OCT picture of this patient, and you can see a ruptured plaque communicating with the cavity. So this was the case of plaque rupture, and here You can see this OCT picture, and this is a cap of fibroadenoma, which clearly is ruptured, and there is communication with medial. So here the clear decision was to stent this patient.
AP level and pulmonary at least indication or tricuspid velocity. And
so thank you, Dr. Mantri, for nice lecture. So do we have any questions from the panelists? Can we ask?
Can I make a short comment over here, sir?
Yeah, please.
Definitely, OCT is something which, if we have with us, we must use it. But what are the absolute conditions wherein you cannot do without it? I mean, we don't have the luxury at all times. All centers do not have it, and sometimes you have to make it available before the case. So, Dr. Mantri, Dr. Viveka, Dr. Devi, what would be the, I would say, class 1 sort of practical indications where you just cannot do without imaging?
Yeah, Dr. Praveen, would you like to answer that? Do we have Dr. Praveen?
Can I answer?
So Dr. Praveer has left, I think, for some other commitment.
Okay.
Can I answer this?
Yeah, Dr. Mantri, please go ahead. No better person than
No,
you.
it is. So I don't think how the communication was lost. Last case was very interesting. It was spontaneous coronary artery dissection, which was presented as acute MI and managed conservatively based on OCT, because it was just spread. And we have 2-month OCT also, where there was a near total LA. So the absolute indication is in-distant restenosis. To understand the mechanism and decide the type of therapy you are going to use. Then in acute coronary syndrome, as we have discussed, especially patients who are younger, who do not have conventional risk factor, where we can, by using OCT, we can leave these patients just on medical therapy and without putting a stent. And the third is, of course, ambiguous looking lesion after putting the stent, or some ambiguity in the artery. So that if you want to see the lumen, OCT is the best strategy. Okay.
What about left mains? I mean, would you always do an imaging in a left main, or you can do it without it?
If available, we should always image left main. But I know we have many centers where there is no imaging facility available and patients present with acute coronary syndrome. So there they are fully justified in doing the left main intervention even without using the imaging facility.
There is one question in the chat box from Dr. Rahul. He wants to know that in acute coronary syndrome, even thrombosuction is not a label indication now. So should we do OCT in these cases? I think he's mistook with ACS and acute ST elevation MI. So I think Dr. Mantri, would you like to answer his question?
Yes, acute coronary syndrome. Now we have ST elevation MI, non-ST elevation MI. In ST elevation MI, the first priority is to establish the flow by whatever method you want to do. So first is to establish flow, and then if the finances and time permits, after we can still do, especially if the patient is young and there are no conventional risk factors, especially young smoker. We should do OCT and find out what is the underlying pathophysiology. And if it is plaque erosion and patient is hemodynamically and electrically stable, then OCT has a role, definitely. Otherwise, most of these young patients will end up getting a stent.
Yeah, so Dr. Preeti, I think she would like to say something on the role of OCT in complex. So these are the situations like stent failure, restenosis, left main. So there are certain situations where must be using imaging technique, be it OCT or IVS. So any comment, Dr. Preeti, on where one should use, must use rather OCT kind of imaging?
Stent failure, it is a must that we should image these lesions before we try and fix it, because sometimes there are surprises for you. And this is one indication I would recommend we should all try to image these lesions. And number two is young patients in whom after thrombosuction we feel that the lesion is borderline and we want to leave these lesions. So you should be confident about the morphology of the lesion and about the area stenosis before you take a decision. So I think, and the left main definitely. So these three in my lab are the indications where we try to use imaging in most of our patients.
Yeah, so I think our co-panelist, Dr. Ajay Agrawal, has not said anything. Let him. Dr. Ajay, would you like to say something on imaging necessity of OCT where you would not like to use IVUS?
Yes. Of course, as Dr. Priti has said, it's the stent failure, the stent-free stenosis is the prime indication for doing the OCT. I want to ask a question that what are the confidence markers where in case of acute MI, when you do thrombosuction and you see lesion is not significant, what criteria should be followed for putting patient on medications instead of putting stent?
So the answer is look at the vessel wall. If there is no, if it is fitting in plaque erosion or that is spontaneous coronary artery dissection, if these two criteria are met and the patient is hemodynamically and electrically stable, that is the time we can leave these patients on medical therapy. But as Dr. Priti has said, you should be very confident to leave them on medical therapy. That's why imaging is of a great help. If you want to decide that, okay, I want to leave this patient on medical therapy.
Dr. Mantri, if I may ask.
Sir, in that, one more question.
If I may ask,
one more question in continuation of that.
Once you have done a thrombosection, then how confident will you be in leaving the vessel? Because you know that thrombosection device is such a bulky device, so there would be a lot of injury if you have done thrombus. So in an acute MI where you have a lot of thrombus, I would really be very skeptical in leaving the vessel, even if there is no obvious dissection visible. Once I have done a thrombus. Dr. Vivek.
So to answer that, the first study which was presented, 11 centers, 6 countries, 11 country study of nearly 1,200 patients, they did thrombosuction in every patient.
Okay.
And then they did imaging. And once they find that there is only thrombus, because you don't have to see the lesion also, you can get a good picture by seeing the adjoining areas also. If the vessel otherwise is totally healthy all around, just report, doesn't have conventional risk factors, then patient must suspect in terms of plaque erosion.
Yeah, so I think in the interest of time, we will have to wind it up, and we must thank all the speakers, all the panelists and the chairpersons for wonderful contributions. So over to Dr. Naveen Bhamri to take the session further. Dr. Bhamri.
Thank you, Dr. Viveka. Thank you, Dr. Amitabh, Dr. Pravi and Dr. Mantri for sparing your precious time. And I would like to thank Dr. Sameer, Dr. Preeti and Dr. Ajay Agrawal for conducting this session. And now we should move to session 3, that is case in the box live, and over to Dr. Subhansu for this session.
Good afternoon, everybody, and welcome to the next session of our ICC conference, that is 2021. And that is a case in the live in the case that is presented by a team of doctors at the Max Shalimar Bagh Hospital. And I'd like to, for this session, I'd like to introduce our chairpersons. First of all, Professor Dr. Sanjay Tyagi. He is an director professor in the GV Pant Hospital. He is an eminent and leading interventional cardiologist and academician, having the more than 30 years of experience. He is in pioneer in inspiring and nurturing several generations of cardiologists. In the past and present, he is holding various positions like he has been the Vice President of Cardiology Society of India. He has been to DGHS, to the Ministry of Health and the Family Welfare, Delhi government. and he was also the dean of the Maulana Medical College, that is MAMC, and also the director of the GV Pant Hospital. He has been conferred various national honors like BC Roy Awards by the President of India, Lifetime Achievement Awards by the Delhi branch of Cardiology Society of India, and Dr. R. Radhakrishna's Memorial National Teachers Award 2014. He has done extensive work in the coronary, valvular, peripheral intervention, especially Takahashi arthritis, having the innumerable publications in national and international journals like JACC, Indian Heart Journal, European Heart Journal, Cath Intervention. And welcome Dr. Professor Sanjay Tyagi to the session. And the next chairperson is Dr. Manoj Kumar. He is holding the position of Director Cardiology and HOD Cath Lab, Max Patparganj Hospital, New Delhi. And he is also the renowned interventional cardiologist and national figure, having the more than 25 years of experience. And he has done extensive work in complex angioplasties like left main bifurcation, rotablation, intravascular imaging.
I'm heading the department.
And having the awards like the DP Basu Young Investigator Awards in the CSI Annual Conference, Dr. Kalam National Icon Award, Rajiv Gandhi Ratna Puraskar Award, even Suja B. Roy Award in 2008 CSI Delhi. He was an active member in the CSI Delhi National CSI, also a member of the Indo-European Interventional Counseling. He has done the numerous research, having more than 40 publications in reputed journals, both national and international. Okay. Welcome, Dr. Manoj, to the session. And the third chairperson for this session is Dr. Pramod Kumar. He is holding the post of Director and HOD, Medanta Hospital, Patna. He is also a renowned interventional cardiologist in India, having more than 30 years of experience. He has an expertise in simple and the complex pacemaker implantation, balloon bulbotomies, peripheral angioplasties, management of structural heart disease, etc. And he also conferred various awards like Best Research Award in Delhi CSI, Best Case Award in the TCD San Francisco, also been awarded the Times Editor Choice in 2014. Also, he has more than 50 publications to his name in all the leading national and international journal. Now I am hand over this session to the Dr. Manoj Kumar to carry forward the sessions and introduce our speaker and the panelist to looking forward to it. Welcome, sir.
Good morning, everybody. I congratulate Dr. Naveen Bhamri, Dr. Subhansu, and Dr. Devendra for organizing such an excellent conference and for doing such a good, excellent work in the field of interventional cardiology. We feel very proud of them. And now they have organized such an educative conference on this Teachers' Day. So once again, my congratulations to them. I think this is a case in box and you can start presenting your case. Thank you very much.
Thank you, sir. So,
Dr. Manoj will just introduce a little bit and we'll carry forward.
So shall we begin, sir?
I think you should begin. I think we are already
so
late.
This case in the box is basically a lesion with high calcium content, LSCC. As we all know that LSCC, high calcium content lesions by using percutaneous technique is a complex because of the increased risk of incomplete lesion preparation and suboptimal stent deployment. So there may be higher chance of acute and chronic failure. So this is the case of calcified LAD lesion case in the box. So this is a recorded case.
Here now we have a 65-year-old female who is a hypertensive lady, and she comes to the OPD saying that she has angina on exertion. She gets a feeling of substernal heaviness when she walks few steps and need to stop. So the lady is hypertensive, not a diabetic, not a smoker. On preliminary investigations, her echocardiography is having a normal ejection fraction, no regional valve motion anomaly, normal heart valves. ECG is like an active ischemia. So we advise the patient to undergo a CT coronary angiogram. So the lady goes for the CT coronary angiogram, and the first thing which we find is that it has a high calcium score of more than 600. And then there is a dense calcified plaque in the proximal LAD causing almost 90% stenosis. So presuming that this is the cause of the patient's angina, and since the CT coronary angiogram is significantly positive for the anatomical disease, we took the patient on the table and did a coronary angiogram.
So Gagan explained you the brief history of the patient. On the basis of the history, she is having calcific LED lesion, which is a long lesion on the basis of CT coronary angio, and imaging of the, the fluoroscopy also shows that there is a tram track calcification in the LED, which we can see because even without contrast injection, and the calcium score is more than 600, that is also suggestive of heavily calcific lesion, because if you go through the EBCT scoring, if it is more than 400, it means a severe calcific lesion is there. So what should be the plan, Dr. Devendra?
In heavily calcified lesion, for properly assessing the lesion, ideally we should go for intravascular imaging with help of OCT or IVUS, but this lesion is quite critically stenosed and it is difficult to pass a imaging catheter through this stenotic lesion. So dealing with the calcium is very important in these coronary lesion, because stent expansion is the most important predictor for long-term prognosis for stent thrombosis and restenosis. So we want to achieve the maximum expansion of the stent, and for achieving that, debulking of these lesions is very important. And debulking of these calcified lesion can be done mostly in two ways: by rotablation for the intraluminal lesion and with IVL for abluminal lesion.
Yeah, you are absolutely right, Devendra. So our strategy would be like this, because he is absolutely right that you cannot pass imaging catheter through this tight lesion. So first we shall go with the rotablation. What should be the burr size, Dr. Subhansu?
As I break that calcium by the IVL, so my strategy will be, after OCT you have to decide for this whether to go for the IVL or not. On that basis, we have to go for then after that stenting and followed by the routine angioplasty.
We can use directly, the atherectomy devices in the form of balloon. There are, the debulking balloons like Flexton is available. You can use the angiosculpt.
So my strategy will be going to rota, because as you can see in the angiogram, the proximal lesion is very tight, that is more than 90%. And to pass through this lesion, we need to debulk fast things, so that this angiosculpt or other devices has to be passes freely, or else it may get entrapped in the device, in the lesion.
See, the fluoroscopy image before the dye goes in shows the whole length of lesion from the ostial LED till the mid LED, around 50 millimeter more length of the lesion is quite calcified, and the calcium is quite significant. Passing a rotawire directly can prevent a step of microcatheter exchange and all those, but this has a drawback that if the rotawire gets kinked or there is a minor bend, then it can lead to future.
So let's start an angio. Let's do an angiogram first. So this is the you can see the coronary angiogram in the ariocaudal view and the PA cranial view. So we are using the 7 French guiding catheter through the femoral route. This is an EBU guiding catheter. We need an extra support, that's why we use this.
Where, please?
So this is check angiogram. Soft PTC wire followed by microcatheter.
Yes, yes.
So 8000 heparin given. Work of BMW choice PT wire, and we are using the fine cross catheter. So if you see the hemodynamics, patient is having pulse of 73 per minute, and the pressure is, she is 170/90 pressure, saturation is 99. So overall the hemodynamics are good. We are into the LED, we are crossing the lesion, we have crossed the lesion with the workhorse wire.
Radio opaque portion of the wire is around 27 millimeter here.
Yeah.
So we think that again the lesion estimated is around 48 or 50 millimeter or something.
So we need a long stent or a 2 stent. So while passing the rota wire, we should be very careful that it should not kink, because if the wire gets kink, then you may land up in the trouble sometime while passing the burr.
So we have decided to use 1.5 millimeter burr, and this system comes with a preloaded system. So we need not to attach the burr with the rota advancer.
The approximate size of the LED, distal LED, is approximately 2.75 to 3 millimeter. So the burr size ratio is, burr to artery ratio should be 0.5. So that's why we are using 1.5 burr in this case. If needed, we can upgrade this to 1.75 if needed, I think. So now we are with the rota wire inside the distal LED. So now we are into the distal segment of the LED. Now we are going to take out the ablation of more than 10 to 15 seconds. We have to stop in between, and we are using the ready-made flush wire. So we are checking the rota before going inside. Dyna close. 140 तक जाएंगे हम मैक्सिमम. बस. ठीक है. You can see here we are checking the rota bar outside the artery. एक बार check करना. Yeah. Fine. So we are going inside. There are few cardiologists that. Stop. So now we have crossed the lesion successfully without any interruption. So we are checking it to see for any slow flow, no flow phenomena. Everything is wide, but still you can see the tightest point where there is a burr. So we are planning to give one more run of the rota at this point.
Look at the speed. Center, rota.
This is the dangerous point actually.
Okay. Stopping door.
दोबारा करना. So we are done with the rota. Pressure is fine. Now we will pass the micro catheter again for the to exchange the wire. बस.
On करना live.
Now we are out with the micro catheter. Wire is inside.
Balloon deflate.
Deflate the balloon. Balloon is out now. So now we are going to do imaging to look for the diameter of the vessel, length of the lesion, and we are going to see whether that calcium has broke or not. So now we are on with the dragonfly catheter inside the LED.
50 millimeter is the length of these proximal 2 marker. The distal black marker is the tip of the catheter. So even we can have with the 55.
So we are injecting the dye. Shoot. So this is, you can see the distal end of the LED. This is clear. Now you can pull it back. You can see the dense calcification from the 9 o'clock to 3 o'clock position. Now you can see the dissections. You can see the length of the calcification is more than 5 millimeter. Depth is approximately 10 millimeter, 1 millimeter. It's more than 0.5. Now, yeah. So lot of calcium. This is heavily calcified lesion. I think we must use the circumferential calcium in this OCT image. Intravascular lithotripsy or shockwave lithotripsy, you can see 360-degree calcium in this image. So we need to debulk further. What do you say, Subhansu and Devendra?
Already we have debulking with the rota ablation, and we have created space. Now we can see by this OCT image that a lot of intramural and extraluminal calcification is there, and it is heavily calcified. So we need to debulk further. So IVL is needed at this case. I think that will be a better option.
So the house opinion is we should take 3 millimeter IVL, 3 into 15? 3 into 12. So we are going to use the IVL now because there is a circumferential calcium we can see. The beauty of the IVL is we can break the intimal as well as medial calcification with this break, we can, this
Plus-
IVL
plus
balloon
that.
can give you a pressure up to 50 atmosphere. So that is the beauty of the IVL over Rota.
I've just pressed it.
So now we are going inside with the IVL 3 into 12 millimeter balloon. Let's hope for the best that this will cross easily. Let's see.
Holding the wire.
Yeah, holding the wire. So strategy will be, we'll come from distal
Can you
to
make
proximal.
little aerocranial?
This is a little bit bulkier balloon,
एक मिनट
but
रुकना।
once we cross it,
इसकी हवा निकाल।
we are going to
हवा
achieve
निकाल।
the results what we are looking for.
Just show me the guide, please. Guide tip. And we're taking this IVL print.
जहाँ 360 था ना, वहाँ ज़्यादा यूज कर लेना।
ऊपर है ना।
Just
नहीं,
crossing.
मिड वाले में 360 था।
Crossing the.
वो 360 डिग्री कहाँ पे था?
And just crossing this lesion.
20 millimeter proximal to distal point
And
ना?
I think it is easily cross this lesion, and we just need to check the.
Yeah, so we are inside the LED at the, we should go distally, Sudhanshu.
Starting from distal will.
Yeah.
Okay.
So we are having 80 pulses. We can use 10 pulses distally, and proximally we can use up to 40 pulses. So strategy should be, we should inflate it at 4 atmosphere.
We can start from this point, I guess.
Pull. We can pull it.
So IVL, we deliver the electrical pulses. So you can see in the ECG, so there is a ventricular capture because this electrical energy can lead to myocardial stimulation.
Store this image.
So first pulse given successfully. We'll
Just
move.
pulling the little bit of proximal.
Yes.
And again go to 4 atmosphere. 4. Okay, start.
Ready?
Press. 4, 5, 6, 7, 8, 9, 10. Done, sir. And store this, deflate. Thoda sa, we'll just check this position of this balloon.
Ready?
Stop that. Ready, start.
10 की दो बार दे दो।
So here we are going to deliver 2 10 pulses after an interval.
Done. Step, store the. And again just to we'll taking little bit proximally, and here we have to give the maximum. Start inflated 4. Again the inflated 6. This time we will go to little bit of higher.
So this time we will go up to 6 atmosphere, 6 ATM.
Pulses.
And now we are
start pulses. Done.
So now we will come out.
I think I'll just check the balloon movement, and I think we have.
बढ़िया.
The lumen was also expanded.
You can see here very nicely LED diameter. What about the proximal diameter?
I think it's 3.5.
So we, what do you say, Sudhanshu? We should go with a single stent or a two stents?
No, I think the 2-stent strategy is better because we have a disparity of the proximal diameter 3.5 and it is 3. And another thing is it is borderline. We have the highest length of around 48. I guess. Okay, you want to try. You want to try with a single stent first.
There is 2-3 millimeter missing. I'll further push the stent. Take another stent.
Okay, you will start with this 1-stent strategy.
1-stent strategy.
So we take 348.
Then start. Give
So
us
the
a
house
348.
opinion is 348. 348 Zion's expedition. We are very comfortable with this stent. So we are able to go inside easily without any interruption.
इसी व्यू में कराओ, आर्यो कॉर्डल में ही कराओ इसको. प्रॉक्सिमल उसमें टेपरिंग अच्छी दिखाई दे रही है.
I think we are deep inside. We need to pull it now.
अभी भी एक्स्ट्रा पुल कर सकते हैं. You can pull.
ठीक है, next में.
So pressure is okay. 160, 90.
नीचे तक दिखाओ.
So now we are going to take a shoot.
बहुत बढ़िया.
डिस्टल एज क्या है?
Of balloon inside this stent by using stent boost technology. We are quite inside, I think. Go up.
Go.
15.
16.
We have done with the final OCT image and we are okay because stent there is no malapposition seen, there is no distal and proximal edge dissection. So this is, we are, you know, the OCT, we are very happy with the OCT image now, and we'll take a final shoot and we'll come out. I think, what do you say? Are you satisfied, Dr. Devendra?
Yeah, OCT image shows good.
Are done with the 200 ml contrast. I think this is acceptable with the normal renal function. So I have forwarded a little bit because we are running short of time. So this was the LED lesion with high calcium content, and we did a rototripsy, that is rotablation followed by lithotripsy. And the result was to us, yes, it was excellent. What is the house opinion now? We are not able to hear you, sir.
Dr. Manoj, your audio is not coming.
I think it's an excellent result and a very good demonstration of the combination of the two techniques of rota as well as the IVL, like what Dr. Naveen said, the rototripsy. Hopefully it is not rotatipsy. Rototripsy is actually very important. You know, we always thought that they are all competing with each other, the rota and the IVL, but here is a very good example where you have seen that they are complementary to each other. And as Dr. Devendra and Dr. Parida explained very well that, you know, the intraluminal can be taken care of by the rota, but the one which is in the media or in the adventitia or deep can't be taken care of by the rota. So beautiful example of the combination of the two techniques, an excellent result as expected from Dr. Naveen and his team.
Thank you very much, sir. Sir, any other question?
Dr. Naveen, if you can hear me.
Yes, Dr. Vivek.
First of all, I must again repeat the congratulations bestowed upon you, very deservedly so. Right from the outset, the decision, the clinical, the points that you pondered over before going into this particular difficult sort of a case. So could you also propose a short summary or an algorithm for the management of such calcified lesions?
Yes, sir. Very nice question, actually pertaining to this case and cases with lesion with high calcium content. So there is a classical algorithm mentioned. So you first have to see whether it is a balloon crossable lesion or not. If it is yes, then pre-dilate the lesion and do an imaging. If on imaging like OCT, if the calcium arc is more than 180 degree, if the length of the lesion is more than 5 millimeter and the thickness of the lesion is more than 0.5 millimeter lesion, more than 0.5 millimeter, then there will be a, if it is yes, if the calcium score is high, it is 4 or 3 or 4, then you have to go, because the deep calcium is there, then you can go directly with the intravascular lithotripsy. If it is not, if there is a superficial calcium also, then you can go with the rotablation, then pre-dilate again. If the optimal result is there, go with the stent deployment. If suboptimal, then you can switch over to lithotripsy again. Or if the calcium thickness is not like the score is 1 or 2, then you can use a scoring balloon or a Wolverine balloon or NC balloon, and then go then pre-dilate the lesion. If the result is optimal, you can go directly for the stent. Or if suboptimal, then you again have to use the IVL and then deploy the stent. So if the balloon uncrossable lesion, then you have to cross with the microcatheter. If it is okay, then it's fine. If it is not, then you have to put a workhorse wire or the rota wire, that is 0.009. If it is not, then you have to go with the laser atherectomy. that is the, but which is not available here, then you can use the rota ablation if the, and followed by the balloon expansion. If the result is optimal, go for directly for expansion. If suboptimal, then you have to use the lithotripsy to break the medial or adventitial calcium. This is what the algorithm is.
Dr. Bhamri, am I audible now?
Yes, yes, please, sir.
Very nice result, and end result was very good, and I congratulate you, Dr. Bhamri, Dr. Devendra, and Dr. Parida. Only one question is with you, Dr. Bhamri, that with the Rototripsy trial, you have seen that the 9-month mass was around 24%. So we are combining two modalities. One is Rota plus another is IVL. So what will be the long-term result or long-term incidence of MACE in this type of Rototripsy?
So you have quote the trial that shows the acute result was excellent, but the after the 9 months result was equal or not inferior, but equally good. So yes, I don't know the long-term results, but acute result, yes, was excellent. We were able to achieve the optimal expansion of the stent, and we have demonstrated that with the OCT. But yes, definitely the long-term result we don't know. Let's follow up with the patient, and if you are going to do such cases in the long run, we would definitely create a series and then publish it. But yes, your question is absolutely right that the long-term results we don't know.
Thank you. Thank you. Again,
Naveen, there is a question in the chat box just for the sake of discussion that it's by Dr. Rahul that could you have tried to use a small balloon, say 1.5 and then upsize to 2 and probably avoided a rota and did an OCT and then an IVL in this case, obviously.
Samir, the CT angiogram was done initially and the calcium score was too high. It was 600, more than 600. So definitely, and the lesion was very tight. And you know, if you are using a NC balloon or the scoring balloon or 1.5 OP and NC balloon, so there may be a wire biased. So there may be a, you know, there may be a break in the superficial calcium, but we were not able to break the deep calcium. So that's why the initial strategy was using rota, not the OPNNC or the scoring balloon in this case.
Naveen, can I come in? Naveen,
Yes,
can I come in? Hello.
Sanjeev,
Yeah. I feel that there are two important points to be considered if you consider calcium. If there is a suspicion of a superficial calcium, you've done an OCT, you know it's a superficial calcium, it's jolly well good enough to go with a rota ablation or orbital if it's not available or a laser. But once you have a deep calcium which is seen, as Samir is pointing it out, is asking about, the deep calcium will respond to a scoring, a cutting balloon or a IVL only. Add on OCT there being a superficial calcium, then this policy of using NC balloons might have worked if you don't have a rota on your shelf. But once you have a deep calcium, then the policy of using a scoring balloon or a cutting balloon really works if you don't have an IVL, because IVL really involves a lot of finances. But a scoring and a cutting balloon in a deep calcium will do a good work. The difference between a scoring and a cutting balloon is that the cutting balloon is that the flextome is much more on a non-compliant balloon. So it becomes very difficult to pass it through. If you are in an intermediate zone, a scoring balloon can do a job because it's on a semi-compliant balloon.
Yes, point taken, Sanjeev.
Actually, we are running short of time, and I would like to end of this session at this point of time. And I'd like to thank you all the panelists, Professor Mohit Gupta, Dr. Vivek Jindal, Dr. Sumit Dheer, Dr. B.S. Vivek, and Dr. Gagan Jain for the excellent session. And I'd like to carry forward to Dr. Naveen Bhamri to carry forward the further session. Thank you.
So, thank you, Dr. Sanjay Tyagi, sir, for joining us, Dr. Pramod, Dr.
Congratulations
Manoj.
for such an excellent case.
Thank you, sir. Thank you.
Very well done. So proud of you.
Thank you, sir. Thank you. So now we are moving to session 4, that is session on the left main bifurcation, and Dr. Guran has joined, I think. Dr. Guran is there, I think.
Yes, I am. Good morning from Belgrade to everyone.
So very good morning from India to you, sir. So I will introduce the chairperson for your session, and then we'll move on.
Thank
so
you.
with your permission, I am introducing the chairperson for this session, Dr. Saibal Mukhopadhyay, who is heading the Department of Cardiology at GB Pant Hospital from the same mother institute from which we have passed. Dr. Saibal has more than 25 years of experience in all kinds of procedures in intervention cardiology. He has more than 50 publications in various journals, national and international, like Indian Heart Journal, European Heart Journal, Journal of Heart and Valve. He has keen interest in complex coronary interventions, imaging, rotablation, and peripheral angioplasty, plus devices. Along with Dr. Saibal, there is Dr. Jamal Yusuf, who is the director and professor of cardiology at GB Pant Hospital. So me and Dr. Jamal is graduated from the same medical college. He was my senior during MBBS. He has more than 25 years of experience and the expertise in complex coronary interventions, left main bifurcation lesions, CTOs, and the coronary interventions. He has more than 50 publications and research paper to his name, like Indian Heart Journal, Pacing and Electrophysiology Journal, Heart and Valve Disease. He was awarded with Colonel K.L. Chopra Award, Naveen C. Nanda Award in the National CSI 2016. So welcome, Dr. Jamal. Then other chairperson is Dr. Samanjay. He is a senior consultant and intervention cardiologist at Manipal Hospital, New Delhi, with more than 30 years of experience, and his expertise in the field of complex coronary interventions, left main bifurcation lesions, rotablations, CTO, balloon mitral valvotomy, device closures. He has been actively involved in the many research, including role of stem cell in non-ischemic cardiomyopathy. Along with that, we have a very, learned Dr. P.K. Hazra with us, head of the Department of Intervention Cardiology at AMRI Hospital, Calcutta. He has more than 30 years of experience in the field of expertise, including extensive work in ACS, left main, imaging, bifurcations. He is known for the first to implant leadless pacemakers, TAVR, left atrial appendage closure, and many more in the Eastern India with more than 50 publications. He has been faculty to all major conferences like TCT, SKY, Singapore Live. He has been associated with research work in drug-eluting balloon, confirm treatment registry, and ACS Atlas TIMI trial. So welcome, Dr. P.K. Hazra. So over to Dr. Saibal for further proceedings.
Thank you, Naveen, and good afternoon to everyone. At the outset, I'd like to congratulate you for organizing such a educative conference. And more so, we are really honored and privileged to have Professor Goran Stankovic amongst us for this session. And there can be no better person than him to talk on left main bifurcation. And I don't think he really needs any introduction. In EuroPCR, most of the webinars on bifurcation are always presided by him, and we always keenly follow his lectures and the teaching points we try to apply in our day-to-day practice. Thank you, sir, for joining this conference. And sir is presently the president of the European Bifurcation Club, and he was one of the principal investigators of the EBC main trial. So without wasting much time, I would invite sir to talk and take us through the approach to left main bifurcation stenting, a provisional versus a dedicated two-stent strategy.
Good morning again, and thank you very much for kind invitation and for the kind words. This year is really for us at European Bifurcation Club extremely important, because after 5 years we finally have published the results of EBC main, and I really have a privilege to discuss the results of the EBC main and to put it in the context of DK crash, which is, I know, one of the most popular strategies in India. So at least this year I had several presentations, and I hope I will be able to share our philosophy of provisional as a strategy of stepwise layering and stenting, and not upfront two-stent strategy. So I don't have financial conflict of interest to disclose, and I would like to start by saying that European Bifurcation Club was created in 2004. Yves Louvard, Thierry Lefebvre, Olivier Darmon, Manuel Pan, and myself created the club. So it was 17 years ago. And our first meeting was in Bordeaux. This year, in 1 month, we are planning 17th meeting, which will be hybrid event in Brussels for European participants. And I invite all of you to register for free to EBC meeting to listen and maybe use chat box to share the questions and perspective. And I'm sure we can learn from each other, but I'll share the ethos of the EBC for treatment of bifurcations in general. So from the very beginning, we tried to use the procedure as simple as possible, but of course, safe for our patient. We tried to limit the number of stents, but the most important understanding is of the fractal geometry, and we try to respect original bifurcation anatomy, and we try to produce it with a tubular stent. And the introduction of proximal optimization allowed us to reconstruct the original anatomy using a single stent. So we aim for well-opposed and well-expanded stent, and we try to limit the overlap. And for us, provisional side branch stenting strategy is the standard approach for the treatment of vast majority of bifurcations, including the left main. So there is misunderstanding. Frequently people, when you mention provisional, understand that this is a single stent strategy. For us, provisional is actually treatment philosophy, not single stent strategy, because provisional means that we approach bifurcations in a stepwise manner. So we start by stenting of the main vessel, we do proximal optimization, and then we add layers of complexity whenever it's necessary. When side branch result is suboptimal, we stop when we have a good result, and of course we use second stent only when it's necessary. Here are the steps of the layer stepwise provisional. So we wire both branches, as I said, stent the main vessel, we do proximal optimization, and then we evaluate the result. A result in the side branch is critical to proceed with further steps, and what we don't want to leave is critical side branch lesion and impaired flow. So if we have critical side branch lesion or less than 3 flow, we continue to the next steps. So this is the result. We evaluate the side branch. If the side branch result is accepted, we keep it open and we stop at that point. However, if there is a lesion or impaired flow and further intervention is needed, after POT, we exchange wires, we balloon the side branch, aiming for distal rewiring, and next step after rewiring and opening with balloon access to the side branch is to do either kissing and repot, or just repot. Again, we evaluate the result. If side branch after ballooning is not accepted, then we continue with the provisional. And even if we put the second stent, this is still provisional stepwise strategy. And this is animation that I made with my colleague, Dr. Mehmet Begovic. We wire both branches, predilate the main vessel, we stent according to distal reference diameter, and then we do proximal optimization, making sure that we don't touch carina, recross the side branch, and then open access to the side branch and do kissing. And we finish the procedure with repot. So pot, kiss, pot is our preferred strategy. When we remove the tissue, you can see that we are able to reconstruct the anatomy, and we have two different diameters with wide access into the side branch. Is left main bifurcation different? Yes, it is, because it has specific anatomical characteristics which are different from other bifurcations. The most important one are listed here. So first, angulation is usually T-shaped, and the B angle between LAD and the circ is around 80 degrees according to micro-CT and CT evaluation by John Ormiston. Then a large main vessel proximally and caliber discrepancy with the LAD, which makes all the procedures requiring further optimization inside the left main, and we need to reconstruct again two diameters, larger one in the proximal main vessel inside the left main and the smaller one in the LAD. It's also area prone to calcification. Ostium could be involved. If ostium is involved, there is a high likelihood of longitudinal stent deformation, and side branch is circumflex, it's actually never small. In 1/10 of the cases, 10% of the cases, we also have trifurcation. But from the perspective of EBC, we always behave the same. We need to respect the original anatomy because of the caliber discrepancy. Proximal optimization is the essential step, and we need to know the stent design in order to know the maximum expansion capacity. In wide bifurcation angle, some techniques like Culotte give suboptimal opening and coverage, and aortoosteal involvement could create problems with a high elastic recoil and, as I said, risk of longitudinal shortening. For calcification, lesion preparation is the key, and I really congratulate the operators from the first session, the session before, because this rototripsy or rotoshock strategy really provided fantastic result in complex anatomy. I'll lead you through a couple of cases before showing EBC main and DK crash data, because I think it's important to understand that we need to look expected anatomy. According to the anatomy, we plan your strategy. And here in this case, for example, it's non-STEMI, 78 years old, distal left main 100 lesion, but most of the plaque was located in the lateral wall in front of the circ. So after predilatation with 3.5, crossover stenting was performed. You can see here Onyx 3.5 according to circ, diameter 22 millimeter long to cover the ostium was performed, and then track 4.5 was used to optimally oppose stent inside the left main, and this is result after pot. In a left main, we don't usually stop after pot. We would like to remove from the other branch jail stent struts. So we recross distally. After wire exchange, we actually use 2 balloons, open struts, and then do kissing. As you can see, 2 short balloons with minimal proximal overlap in order not to overexpand the stent. And this is the final result with the single stent, but with stepwise provisional strategy. We were quite satisfied with the result achieved, so we did not continue with stenting. However, this is from the document of the EBC 2019. We accept that based on DK Crash 5 and on definition 2 study, that two-stent strategies could be electively considered for important side branch with diffuse and extensive disease, with difficult side branch access or high risk of side branch compromise. However, selection of the stent technique should be based on individual patient's anatomy, but also the operator's skill and experience. And I frequently say that fantastic results with DK Crash were actually achieved selecting highly experienced group of operators, mainly from Asia, who were really at least 5 years performing more than 300 PCIs per year, and plus in addition more than 25 left main PCIs. So this kind of experience is really very difficult to reproduce in everyday clinical practice. And I frequently discuss the paper from the British Cardiac Intervention Society that is published in 2020 in JACC Interventions. You can look that article, and out of 800 operators in UK, only 6 of them will meet the criteria to participate in DK Crash 5. So that's why we put that it's extremely important that operator selects the strategy which he is familiar with. And these are micro-CT images of different currently recommended two-stent strategies. So we can have T and TAP. The only difference between T and TAP is actually the length of protrusion of the side branch stent from the circumflex into the left main. And if you see fly-through image here, in T stenting, you should not have any protrusion of the stent from the circumflex inside the left main, while in the TAP stenting, there is some protrusion and short metallic neocarina, which is the consequence of optimal coverage of the lateral wall of bifurcation. If we further pull back stent from the circumflex inside the left main, what we achieve is actually mini culotte with partial short proximal overlap between stents in the left main LAD and circ's left main. And finally, we have DKE crush. As I said, crushing the stent results in the short three-layer structure inside the left main. In this case, we again have short metallic neocarina, but because of proximal recrossing, metallic neocarina is created by the stent from the left main into the LAD. And this is the strategy of the European Bifurcation Club for selecting provisional versus two-stent strategy, and algorithm is based on the estimated risk of losing the side branch after main branch stenting. So if the estimated risk is low, then we recommend provisional strategy, and second stent we put with T, TAP, or Culotte stenting. If we estimate that risk is major for compromising, then we either use inverted provisional, stenting from the left main into the circ, and then finishing with inverted T-tap or Culotte, or for experienced operators, we recommend double kissing crush to start. I'll just show a couple of examples more, and this is again cartoon for inverted provisional, actually finishing with tap. So in this case, we predilate towards the circ, we stent according to circ reference, then we do pot in order to optimize stent expansion and malaposition inside the left main. We cross distal cell and we open access towards the LAD. We do kissing balloon inflation, and then we position stent with minimal protrusion, and we have balloon in the circ, which is positioned already. We do final kissing, and when we do final pot, we go far away from the carina. And this is the final result, full coverage of the ostium of the LAD. And as you may see, minimal metallic neocarina. If we are able to limit to 1 or 2 strats, this should not have clinical consequences on the follow-up. The main difference between T and TAP is, in our perspective, actually a recrossing point after provisional and pot. If we are able to recross through the distal strat, in that case, we push some metal and scaffold the ostium of the circ from the stent inside the main vessel. In that case, this scaffolding helps us to position stent in the side branch precisely without protrusion. However, if we cross proximal cell, we don't have scaffolding of the ostium of the side branch, so we need to pull back balloon and stent from the side branch, and as a consequence, we have this short metallic neocarina, and again, in the full screen mode, protrusion of metallic neocarina versus no protrusion is the main difference between provisional TAP and provisional T. And even when we know from the beginning, so this is diffuse disease in the distal left main and both ostia, even if we know from the beginning that most probably we will need 2 stents, our strategy is to start first by wiring, and then after wiring, we predilate towards the most angulated, most difficult branch, in this case towards the circ. After that, we jail wire and we stent from the ostium of the left main, covering completely distal left main and the disease segment in the circ. This is the positioning again in cranial view to make sure that we don't miss the ostium, stent deployment, and after stent deployment, we perform pot. As you can see, position of the distal marker is exactly in front of the carina. This is the result with partial compromise of the ostium of the LAD because of carina and plaque shift. There was a huge plaque burden. So we recross distally after pot. After that, we actually do kissing. This is the result after kissing with some dissection at the ostium of the LAD. So decision was made to position stent in the TAP fashion with practically minimal protrusion. We deploy the stent, we do the kissing, and we repeat pot staying away proximal to the ostium of the left main, and this is the final result. So in our perspective, we don't need to select from the beginning, this is two-stent strategy. We don't need to prejudge. We actually follow the sequence of steps and we evaluate the result at each of these steps. And when we finish the procedure with acceptable result, then we stop. DK crush has very well described 7 steps that I'm not going to teach you. You can teach myself actually, but I'll show you my animation, and I have really full respect for people who are trained to perform DK crush. So we predilate both branches, we position balloon in the main vessel, minimal protrusion of the stent, we sequentially crush with 2 different balloons, and we perform first kissing after proximal rewiring. We stent the main vessel and then we pot. This pot is extremely important, and again proximal or central position of the recrossing, and then sequential high pressure inflation and kissing. And this is the final result that you can see minimal 2 layers of the crush stent protruding, and here you can see what I described as a short metallic neocarina, in this case created by the main vessel. And this is the example which I took from Professor Shaoliang Chen when he was in Belgrade. So diffuse disease of the circ, diffuse disease of the LAD. So it's clear that we need to stent both branches in different projections. And after predilatation, IVUS was done, showing the left main with the lipid pool, minimal protrusion of the circumflex stent. Circumflex stent covers the whole disease segment, and then we deploy the stent. After deploying the stent, we first use 3.5 balloon for crush, which is according to LAD diameter. However, if you do imaging, you can see that you only partially crush because of the caliber discrepancy. So you select another bigger balloon sized according to left main diameter, and then you do sort of the first pot, which is actually sequential balloon crush. First balloon selected according to distal main vessel diameter, and second balloon selected according to proximal main vessel diameter. Then the steps are the following: proximal recrossing, the first kissing, and then stenting of the main vessel. After stenting of the main vessel, you perform second pot, rewire again proximal or central, you do second kissing, and you do the third and final pot. And this is the final optimal result with full coverage of disease in LAD and both limbs. 2 studies, I think the key is to understand the difference between these 2 studies. This is the primary endpoint of the DK Crush 5. Favors two-stent strategy DK Crush versus Provisional. However, when you see these Kaplan-Meier curves, my question is what happened here, because almost at the end of follow-up, you have sudden increase in the number of events in Provisional group. And if you stratify mortality and MI or TLR, you see that actually the whole difference comes from TLR, which in our interpretation could be partially driven by angiographic follow-up, because 2/3 in both groups had already before 1 year of follow-up, clinical follow-up, had angiography, and we believe that partially this angiographic appearance resulted in increased rate of TLR. Very important is to understand diffuse disease in this study of the circ. Mean lesion length in the circ was 16 millimeters. And even if you stratify according to definition criteria, simple versus complex, you see that only in complex diffuse disease, you have difference in clinical outcomes. So we know from the Benestant and stress study that for disease which is 20 millimeter long, balloon is inferior to stent, and 45% crossover rate in DK Crush 5 from Provisional to 2 stents, in my interpretation, is actually very low. So we could have much more stented lesions in the circumflex and I believe the result will be better. And this is what we saw in the definition 2, in which side branch lesion length was even longer, 20 millimeters. So of course, if you have 20 millimeter disease, stenting is better than just balloon. So EBC main was presented as late-breaking trial this year at EuroPCR and published in European Heart. We tested hypothesis that provisional as a stepwise layer strategy with mandatory pot and kiss is better than systematic two-stent approach, but we left to the operator to select any of the T-tap, Culotte, or DK crush. And this is the procedural flow. We were very satisfied that 85% of the patients in provisional had pot, 90% had kissing, and the key finding is that in true bifurcation lesion of distal left main, only 22% required stent. Here is the primary endpoint, no difference in clinical primary endpoint, which is total mortality, all myocardial infarctions, and TLR. And if we look secondary endpoints, no difference in death MI, and there is also 0.16, no difference statistically, but numerically lower rate of repeat revascularization in provisional, 6% versus 9.3%. These are the main characteristics which make a difference. So predominantly operators in Asia versus Europe. A syntax score was higher in DK crush as well as the circumflex lesion length. And as I said, there is no difference. Study was neutral for the primary endpoint. So I would like to conclude that if we focus on the left main PCI and the stenting technique, bifurcation stenting technique should be based on individual anatomy and also operator experience. Stepwise strategy does not prejudge the issue of 1 versus 2 stents, and in our interpretation should remain the approach of choice for majority of bifurcation interventions, including the left main. 2-stent strategy according to definition 2 study criteria should be used, and when we select 2-stent technique upfront, there is strong positive randomized evidence for double kissing crush. Thank you very much for your attention.
Well, thank you, sir, for your excellent lecture. There are a couple of points which I want to take up, and actually our case presentation will be in that theme only. In Europe, it seems Culotte is the preferred technique over DK crush. And there an additional kiss in Culotte has been shown to give better results regarding achieving the minimal area in the side branch, as well as decrease in in-stent restenosis. That is what was shown in a benchmark study as well as by Cath et al. And if we go through DK crush 3 trial, Culotte was shown inferior to DK crush. The main reason was increased rate of TLR in the side branch ostium because of in-stent restenosis or late stent thrombosis. So the key was the L6 ostium gets deformed when you are doing a conventional Culotte. This can be bypassed or avoided if you do a first case when you are trying to deform this stent to enter into the main vessel. So, and in your European consensus guidelines, DK Culotte has been addressed to have the potential to have an outstanding stent configuration. So taking this, my colleague, Dr. Sanjeev, will be showing the steps of DK Culotte and how it can help to improve over the Culotte technique. And I feel that the inferiority of Culotte to DK crush in that trial can be overcome if we add an additional kissing and make it DK Culotte, which is also your strategy when in your provisional, like Culotte is like reverse T. I mean, you are taking up a provisional theme, and if you feel, even if you don't go with an upfront approach, so if you go for a second stent, I think adding, making it DK Culotte over Culotte can improve the strategies. And so we will be going through these cases. And at the same time, I would like to say that we have 3 panelists, Dr. Rishi Sethi, who is a professor of cardiology at King George Medical College, Lucknow, And there are two other panelists who are my juniors and students from GB Pant Hospital, presently attached to Max Hospital. One of them is attached to Max Hospital, Dr. Chandrasekhar, and second one is Dr. Amit Gupta. He is also in Jaipur, and both of them are actively doing complex PCI, included left main PCI. And so I would request the panel to put forward their views also in the discussion, along with my co-chairpersons. So I think we can go forward to the case presentation by Sanjeev, and then we can have a brief discussion and obvious view of Sir Dr. Gordon after this. Sanjeev, I think we should start.
Very good afternoon, everybody. Are the slides visible, sir?
Yeah, they are visible.
So in the light of whatever Dr. Goran sir has said till now and whatever Dr. Sehgal has introduced, the basic crux of my presentation is talking about the DK Culotte technique. At the onset only, I like to say that though we have the provisional technique, which is considered now after the ABC trial to be a very nice technique, but the important thing is that the place where Culotte technique loses over many techniques is the first kissing of the first kissing step. That is where we don't kiss sequentially and we do a balloon dilatation simultaneous where we distort the first end. In fact, in a classical Culotte, we don't do that step. So what I'm trying to introduce is what is there in a DK Culotte, which might be the new kid on the horizon, helping us taking over the deformity of the stent which occurs with the DK crush. So moving forward. I need to share again.
We can see your slides, yes.
Yeah, you need to share it again and slide got stuck.
Can the slides be seen again? Can the slides be seen now?
We can see the slides. Start moving.
Okay, fine. Now it's moving.
You have to go to the slides.
Yeah.
Now.
So the important thing, as sir had already pointed out in his lecture itself, is what are the unique features of a left main bifurcation? The ostial position of the main vessel, the large side branch. You can have the longer length of the left main. The angulations of the L6 can vary. You can have L6 which is large, dominant L6. You can have catastrophe which is unusually long, longitudinal diffusion present along the lateral wall of the left main and extending into the two branches. Again, as I had already pointed out, the crucial role of pot, and of course the fact that there can be trifurcation in about 10% of the cases. One important thing to be noticed is that endothelial shear stress, wanted to believe, is less in the carina because it's more in the lateral walls because the fact that there's low external shear stress there. So it's important to know that the lesion in isolation in carina is very, very rare. Now, this is the DK crush 3 study which sir was mentioning about. And it's important to understand here that the DK crush technique has been compared with the Culotte technique, not a DK Culotte technique. And again, the Achilles heel of the Culotte technique is the deformation of the stent which takes place in the first kissing, where we are not protecting the first stent and we are going oversized in the other branch so as to make sure that our stent passes by. The other important thing is the instant restenosis rate in the side branch was 12.6 in the Culotte group and 6.8 in the DK crush group. This is the basic crux of a difference in the Culotte and the DK crush. As sir had already pointed out it's almost the same slide. We all know that the average syntax score in the EVC main was 23, while it was 31 in the DK crush. The lesion length was 7 and 16, the side branch lesion length. The part after the first stent was not a part of the precision DK5. And sir has already pointed out that the crossover rate was high in DK5 because the syntax score was high and the complexity of lesion probably was much higher in DK crush. Now let's go to one of the cases. Now this is a patient who has a left main disease, disease extending into the ostial LAD as well as the ostial L6. Since you have such a disease, we went ahead, wired both the LAD and the L6, and then first did a ballooning of the LCX. Following that, we did a OCT of the L6 lesion from the distal L6 towards the left main. And what we can see here are two important things, that in the distal L6 is having a good reference, good area, while the proximal L6 as well as the ostial L6 are diseased. After doing a OCT through this, we went ahead, ballooned the LED and did an OCT run from the LED also. And as you can appreciate in the OCT run, as I will be showing in the area, the proximal part of the LED is quite diseased as well as the distal L6. But the ostium of the left main is well preserved. This is the area which you can appreciate. The distal reference of 6.23, but the LED ostium is 3.8, the polygon of confluence is 5, and the proximal left main is 12.27. It's quite preserved proximal 6, giving us an idea that we can jolly well leave the proximal ostial part of the left main. Now we went ahead, we wanted to do a Culotte technique in this. So the first stent was placed from the left main to the LED, from left main to the LCX. The stent was inflated. And after that, as a part of the, we did a part of the proximal stent, which is now a recognized technique for a Culotte. After that, we did pull back from the LCX. Again, the slides are. I'll have to stop sharing and share again. So the basic crux in this was, once we had stented from the left main to the L6, and we did, after doing a part of the proximal stent, we went ahead and did a OCT. Just a second. OCT, we were able to appreciate that there are struts across the LED, and in that case, we went ahead and first did the OCT once again from the left main, from the LED to the L6, from the LED to the left main, and went ahead and stented our. Important point to note in this thing was that once you're doing another post PCA L6 run to left main, we were able to appreciate that there are significant struts present across the LED. So this is one of our main reasons that we was thinking about now. As Sir was pointing, we can think of a provisional stenting here, but we are able to appreciate the fact that the L6 ostium is well maintained, but we have significant struts across the body of the LED ostium. So we went ahead and did a sequential casing. Now this is very
Sanjeev, Sanjeev, this patient had significant LED disease also. So we were thinking of an upfront two-stent, but we wanted to do a Culotte. Now you explain the steps of the Culotte. That is the most important thing.
Now this is the most important step we must also have to understand. In a Culotte, if you are doing a casing, it's important to do a sequential casing. That is the crux of the situation. And you see the two balloons are across, but if you can see that the balloon in the LCX has been inflated first, which has the stent, and the balloon in the LED has been inflated later on. This is to preserve the integrity of the LCX stent, which is the Achilles heel of the classical Culotte technique. Put it in.
Just Sanjeev, let me just explain. What was done when you are trying to expand your stent struts for getting into the LED, even in the Culotte 3, they showed that the stent struts gets crowded together at the ostium of the LCX. And this has been shown to be a napkin sign. So when there is crowding of the stent struts across the ostium of the LCX, it later cannot be corrected even by the first kiss or the final kiss, which we do in Culotte. So to prevent this crowding of the stent struts, what they have suggested in sequential, you inflate one balloon, the diameter 1:1 with the stent in the LCX at maybe 10 atmosphere or at the nominal diameter, so that you prevent this stent struts getting pulled together while you are trying to inflate the balloon across its strut into LED. So you do a sequential dilatation. First, dilate the LCX, prevent the stent struts from getting crowded together, and then you dilate the LED stent struts at high pressure. And then you deflate both simultaneously. So this is sequential kissing dilatation.
This is the most important step which is to be taken. Again, important 2 points. Sequential, deflation has to be simultaneous. At the same time, the stent, you can take the standard balloon of the size of the stent which you have put and put it to the nominal. The other side, where you want to put the next stent, can be inflated to higher pressure, because the only purpose is to make sure that we don't deform the first stent. The sequential dilatation, first balloon introduced and inflated, and then the second balloon is inflated. After that, we went ahead and positioned our stent from the left vein into the LED. And after doing that, we did the standard procedure of crossing over into the L6 once again and doing a kissing balloon. Once again, this is an important step where we are doing a kissing balloon. I'd like to show once again here also, the kissing balloon is sequential. Now, in this case, the LED balloon will be inflated first because you put the stent as the second stent, and the L6 balloon will be inflated second. Once again, in animation, this balloon first inflated and only then this balloon inflated. Once again, to make sure that we're not distorting the previous. So the sequential dilatation and simultaneous deflation is the difference which is going to come up with the decay Culotte, is what we're trying to emphasize. After then, we went ahead with the pot, which is to be done as the third pot, repot. Now, this is an important step here. Most of you will appreciate it's a good result, and we don't see angiographically any problem with the LED stent or the distal flow. But this is what we did when you do an OCT run of this. What we could appreciate is that there is a distal dissection below the second stent, below the LED stent. Can you appreciate this medial dissection, which is covering water and is going towards the media? So this was absolutely not appreciable in the angiographic film, but was appreciated here. So we went ahead and stented this segment. And after that, we went ahead for another OCT run. The OCT run showed us a very good opposition as well as the expansion. Now, coming in the other side of the story, there can be cases where we don't have a disease in the LED and we have an osteal disease in the L6, and then how do we tackle that?
Katuria, just let me, before you start this case. And now this EPC trial, where when in the provisional stenting group, they did a routine kiss. The routine kiss was done even if there was a TIMI3 flow, and they did IBUs in 40%. So they didn't really see if the stent struts after a pot was really across the ostium. Sometimes what we have seen and what we are trying to highlight in this case, that by doing prot, the stent struts may get fractured and you may not have even a link. So I would like to ask sir also and the panelists that in such situations, do we really need to go for a routine kiss after a pot? This is what Sanjeev will now just explain, and then we would like to have a discussion on this point also. Go ahead, Sanjeev.
Yes, once I show this case, this is the only crux you want to know. But without the imaging, are we able to know that there are struts across the left ostium of the other vessel which is stented? The important thing in this angiogram is the discrete osteal L6 lesion, as well as the fact that there's an aneurysm at the mouth of the L6. So they went ahead, did an OCT. I'll just show you the imaging. The imaging showed a very well expanded the lesion in the L6 with an aneurysm which is present in the L6, and the left vein being, the osteal left vein being once again very well preserved. So we went ahead and with the single stent strategy, dilated our osteal L6 lesion, put a stent across the osteal L6 lesion, and after that, did a part of the L6 stent and did an OCT. Now, this is an important point which sir is trying to emphasize in this case. We have a well-expanded stent. We were quite sure that there's no malopposition expanded. But what you can see here is that there are struts across the LED ostium. So for this, there can be two techniques. You can do a kissing balloon. What we did was we did a high pressure inflation of the left vein ostium with a higher balloon. And this is what we achieved on OCT.
We did a pot.
Yes. Did a pot with a higher, with a bigger balloon and high pressure pot. And this is what we achieved in the OCT. We were able to appreciate the fact that now struts which are across the LED ostium had been distorted, and there were hardly a limb present over the LED ostium. I don't have the eagle's eye. Just to try to show you the eagle's eye view. And this is the important thing. Though we have the strut, it's a fractured strut as compared to what the crimping we were having in front of the LED ostium before we did the high pressure. So this is a concept which we like to ask sir once again, that unless you have done an imaging technique, we'll be able to appreciate the fact that we don't need to interfere with the LED osteum or not. Now, just a point about this technique itself, where I've just mentioned about the fact that you like to do a double kissing in the culotte, making sure it's a sequential kissing, making sure the first stent is to be inflated, the stented part is to be inflated first to the nominal pressure. The second can be at higher, and deflation has to be simultaneous. The principle of the DK approach, which I have been trying to emphasize again, it prevents the future deformation of the stent. Because what Dr. Sekhar also pointed out very clearly, if you have not done a sequential dilatation, the stent deformation of the first stent which takes place is not corrected even by the final part. So these are the steps. Yeah, these are the steps. I think we have already shown the steps. It's just to show that there are 3 parts to be done and 2 kissing, taking the 3 kissings to be done. But important thing is part after every step and sequential kissing. Now this is to prevent. This is just 2-step kissing is more effective just to make sure that your side branch osteum does not get deformed. All the emphasis on this only. So how is a DK culotte better than a DK crash? Lesser procedure time, minimally deformed stents, you have less floating struts, you have a tubular anatomy which is reconstructed instead of a new anatomy. That means you're preserving the normal anatomy which was there. You're not creating a new carina. Physiological integrity of the human vessel, less turbulence, less shear stress, and an important thing, less abnormal platelet activation, which is a cause of thrombosis. Less angulation changes, so you have a relatively maintained native angle relevant to the fluid dynamics. This is our data from our hospital. In the last year or so, we have done around 15 culotte technique patients. There's been no randomization with us. It's the culotte technique which we preferred. Wherever we found that we are thinking about going for a double stent technique per se. This has been our data, and we've been able to perform the technique successfully in most of the cases. And there has been only one case where, while doing from a provisional, we had to shift to a DK culotte because of the fact of the closure of the main side branch, and that is a patient who also had practically MI because of the increase in the CPK. So the technical success as well as the procedural success has been quite good. But we have been following the steps completely with all the parts and all the sequential dilatations. The part has been 100%, the kissing balloon after has been 100%, and the OCT guidance, we've done all these DK culotte only with OCT guidance. So the take-home message can be, till date for left main stenting, DK crash technique seems to be the most favorable if you're talking about a double stent technique. The DK culotte is a new, suitable, emerging alternative technique showing better hemodynamics than the classical culotte. More attention should be paid to optimizing the chosen technique rather than to choosing amongst the techniques. And ultimately, the decision to do 2-stent technique will depend, driven by the morphology, the familiarity, and the operator experience with a particular technique. Imaging is no longer just a flavoring agent, but an essential ingredient in the bifurcation optimization.
Well, with this, I would like the panelists and also the other chairpersons to for their comments and some discussion, along with Professor Gordon.
Yeah, very nice discussion. You know, this left main, we suffer from a lot of illusion and enigmas starting from the syntax trial. Syntax trial is not randomized trial based on syntax score. Still, the recommendation is based on syntax. This is a trial between taxes versus surgery. The second enigma and illusions is DK crash. And DK crash people, they thought that MI and TLR should be the differentiating point between these two group, and they do not know how to do a good provisional stenting. They know how to do a good DK crash stenting, two-stenting. If you contaminate your primary endpoint by MI, which is most controversial, like you are including a quality of life with death and heart failure hospitalizations. So this MI, you know, if you go by definition of MI, is controversial. Enzyme elevation, ST elevation. So this should be removed. And coming back to the EBC left main, again, we wanted to know the two-stent upfront versus two-stent provisional, which one is superior? Again, there is a lot of illusion and myths in EBC left main. First of all, they initially thought the 25% difference of absolute primary endpoint versus 17%. So there is 8% gap. Initially they thought, and they have calculated the power of 80%. Now, when you saw this neutral trial, it has come down to 11%. So obviously trial is fraudulent. And there is a lot of falsehood because the power has gone down to 60% with a lot of type 2 error. And again, they have included MI as a composite endpoint because the MI is a controversial thing. So we have not learned the best yet in the lab. There is a lot of controversy still. There are a lot of uncertainties whether upfront two-stent is good or upfront, the provisional two-stent is good.
In fact, sir, DK Crush 5 used cardiac death and target vessel revascularization rather than myocardial infarction, and as its endpoint. So that will obviously reduce the overall number of events per se also. That's a difference which DK Crush used, as you had mentioned, because they never used myocardial infarction as the endpoint. They used cardiac death and the target vessel related revascularization as.
No, MI was there. MI was there. Cardiac death here and total death there. Cardiac death was there, MI and TLR.
That vessel, that was actually target vessel failure. They had gone for target vessel MI. And that was what exactly I was hinting and emphasizing in DK Crush 3, which was by that Chen group. And there in the Culotte group, there was increased target vessel vascularization and ischemia-driven target lesion revascularization, because in the Culotte, they found that the ostium was the site of the problem. And so to overcome that, if you can have now equivalent results, we feel, with DK Culotte, if you can prevent this distortion of the ostium, which was very elegantly shown by Toth et al. In their study, that how you can perform this deformity. So if you want to switch from DK Crush to a Culotte, additional KISS can help you to give, we feel, similar results as DK Crush. And in Culotte, you are anyway doing all the steps, you're recrossing. So just you have to do one additional balloon dilatation.
Second is that there is a bias, a lot of bias, Sanjeev. Initially, they thought that it's 11% difference would be there between provisional versus upfront. When they actually did the trial, it came down to almost, I think, 5%, 6%, almost neutrality. So superiority trial became neutral trial.
So,
you know, there is a lot of statistical weakness in those UC11, though it is a nicely conducted trial, but it's not going to change the practice. Over to you.
That is also what we are trying to emphasize is the fact of an additional kissing balloon with the DK Culotte. And the fact is not of just the kissing, but of sequential kissing. That's the whole crux.
That is one of the techniques. That is one of the techniques. Yes, sir. And
if you give the same patient to Dr. Hirama, Dr. Subhinder, to any of these panelists, Dr. Wal, it can be done in different ways. I think a single patient can be done in many ways. And what about
sir? That is the one we want to highlight. Many of us will go for DK Crush if you go for a two-stent strategy, because that is the one which has shown better results over Culotte. But we feel this is the new thing which has come up, and we wanted to highlight this, that if you modify your Culotte by an additional KISS, like Crush was the first thing, then came DK Crush. It started all with single kissing, that DK Crush came. So additional kissing in Culotte can make your results maybe equivalent or even better than DK Crush. So I think we should now endeavor and do head-to-head comparison of a DK Culotte versus DK Crush. Like in DK Crush 3, we did Culotte versus DK Crush. So we think, as we have seen, that DK Culotte may overcome these limitations of Culotte, and we may have equivalent results if we are going for an upfront two-stent strategy. And even in the single-stent strategy, provisional, like you can go for TAP or Culotte. We feel Culotte is a better technique than going for TAP, because in TAP, anyway, you're in the neocarina, you have some stent struts hanging. That neocarina has a new stent struts are hanging in the neocarina, which is totally avoidable if you go via Culotte, or now we think a DK Culotte. I would like the opinion of Dr. Goran also in this aspect.
Yeah, but it's really excellent discussion, different perspectives, based again on bench testing data predominantly with lack of direct clinical comparison. The first misunderstanding is that upfront provisional does not mean one stent, and upfront two stents is always two stents. If you start with provisional, it means you can end up with single stent, you can finish with two stents. If you start DK Crush, stent the side branch, you will always have two stents. You don't have single stent. I shown and I tried to give our perspective on DK Crash 5, group of highly trained, excellent operators participating in 7 or 8 consecutive studies, performed the study in which we have, and I fully agree with you, a lack of statistical power to speak about clinical outcome. We speak about differences in TLR, and in our interpretation, TLR rates were driven by 66% of patients having angiographic follow-up. And when you finish the procedure with just balloon dilatation of the circumflex and you leave more than 50% lesion peri-procedural, at the follow-up, this lesion looks indicated for revascularization, and you do stenting, and this becomes increased rate of TLR. So angio guidance really increases the rate of TLR. And although angio follow-up was scheduled after clinical follow-up, 2/3 of the patients already had before the end of clinical follow-up angio follow-up. So in our interpretation, DK Crash is excellent, but it has to be done by well-trained and experienced operator. And I also agree that we need direct comparison now between DK Culotte versus, so 2 stents in one arm, the most contemporary versus DK Crash, again by the same group of excellent operators in both arms. Which one is better? We still lack the evidence. I just would like to stress that Provisional may end up after single stent and kissing, while for DK Crash you have these 7 steps and you can make mistake of any of the 7 steps, so you need to be well trained. In case you are well trained, I really have great respect for double kissing crash. EBC main reflects the most contemporary practice in Europe. So all the centers are inside the Europe, and we really try to find a possibility for the operator to start with DK Crash. Simply in Europe, DK Crash with so many demanding steps and 3 layers of metal inside the left main is not accepted broadly. People just used it in, I think, 5% of the cases. So it's very difficult to compare 2 studies in which you have 20 millimeter long disease in the circ on one side, or on the other side, just 7 millimeter long circ. 31 syntax versus 23 syntax. So it's not really directly comparable. And I think we learn from both studies, we can put both together. If you don't have 16 millimeter long disease in the circ, you can start with Provisional. You will end up in 1 out of 5 patients with second stent. If you do DK Crash, you will have 100% 2 stents. And what we learn from absolutely every study, every meta-analysis, you go to the literature, there are multiple meta-analyses showing that 2 stents at the follow-up of 1, 3, and 5 years have higher rate of stent thrombosis, myocardial infarction, and mortality. And this is why we believe if you are able to optimally finish procedure with less metal, with single stent, then it will be at the longer term follow-up better for our patients. So I think we should be very careful when recommending, this is 2 stent from the beginning. No, this is for single stent. I don't think it's necessary to prejudge from the angiography. You start, in our case, with Provisional, which means you can do T, TAP, or Culotte, depending on the angulation, depending on the vessel size. If you have relatively small circ, makes no sense to do Culotte with 2.5 millimeter circ and 4.0 LAD. You will never be able to open that stent from the circ. So individually select strategy for each individual patient. We will hopefully collect more data in the future. We can again discuss next year if some other new evidence comes. At the moment, in our belief, if you don't have extremely diffuse disease of the circ, in most of the cases, you can finish 80% of time with single stent and kissing, and you will need second stent in 1 out of 5 patients. And for that one, you can do T, TAP, Culotte, or if you wish, you can do internal crush, although it's just anecdotal cases. So you start with single stent, you may end up in 1 out of 5 cases with 2 stents, and you will have neutral outcome at 1 year with numerically lower event rates in the provisional. I'm eagerly waiting for 3 years and 5 years of follow-up from the EBC main. I'm sure we will learn more what strategy provides better clinical outcome. So that's my comment.
Just one question, Dr. Goran.
Yes.
The use of imaging, whether in EBC or in DK crush, has been around 40% only.
Yes.
So the decision to take care of the cuts which might be protruding on the
We are running short of time.
Just a second. This question. So is this how are you deciding that the studs are still protruding on the surface of the other vessel, whichever we are stented?
They are doing routine provisional kissing. No? That is what they have done. Even without looking for the struts, if you do a kiss, the struts will move away. But I want to ask, sir, that here there was no increased rates of TLR, even if you did a compulsory kissing at high atmosphere, 16 atmospheres in the EBC trial.
We don't have this data. We don't do kissing at 16 atmospheres. This is irrational.
No, sequential you did, I think.
We recommend sequential, but sequential, we don't need high pressure in provisional. Only if 2 stents are used, we recommend sequential, high pressure individual limb inflation, and then moderate pressure simultaneous inflation with 2 balloons. But kissing has so many important procedural aspects. If you cross proximally, kissing is not beneficial. You don't remove the struts. You actually cross proximally. You push metal in the other branch. So I understand that imaging is the key. Study, we wanted to do image guided, but we could not have resources. No company wanted to support image guided study. Now we are doing sub-analysis in this 40% of cases, combined IVUS and OCT to see if that was beneficial from certain procedural step perspective, and we'll be happy to share that as soon as possible.
Thank you, sir. So if there are any other, Naveen, are we running short of time? So I think we are running short of time, and I would like to thank Professor Goran and all our co-chairpersons and the panelists. And over to you, Naveen.
Thank you very much. Have a successful meeting.
Thank you.
Thank you, Dr. Goran, for sparing a precious time for us. Thank you, Dr. Sabal, Dr. Jamal, Dr. Hazra, Dr. Sethi, Dr. Amit, and Dr. Sekhar. So we are moving to a very thrilling session now. This is going to be a very exciting session. So all the stalwarts of cardiology are here with us to discuss the cath lab emergencies bailout procedure in cath labs by Professor Vijay Trihan. So for this session, the chairperson will be Dr. V.K. Bahel. He is the Principal Director of Cardiac Sciences at Max Hospital, Max Super Specialty Hospital. He has experience of more than 30 years. He is a former Dean and Chief of Cardiothoracic Center and Head of Cardiology at All India Institute of Medical Science. He was a President of Cardiology Society of India in the year 2008 to 2009. He was a course director for India Live. He has a number of awards to his name, like Amrut Modi Unichem Prize by ICMR, Lifetime Achievement Award by CSI in the year 2019. He is honorary editor of Indian Heart Journal, Dronacharya Award by APVIC in the year 2019. So I welcome Dr. V.K. Bahel. Dr. P.K. Goyal is also another chairperson in this session. He is currently the director of cardiology at Medanta Hospital. Earlier, he was professor and head of cardiology at SGPGI, Lucknow. So Dr. M.S. Hiremat is also with us as a chairperson for this session. He is a director Cath Lab, Ruby Hall, Pune. He has more than 35 years of experience. He's a known figure in doing all types of cardiac interventions, including left main bifurcation imaging, and proctored many intervention cardiologists and take a live course across the globe. In the past, he was president of CSI in the year 2017. He program chair many CSI conferences in the 2016, convener NIC CSI 2004 to 2006. His interest is basically in the coronary and peripheral interventions like iliac and carotids. He has received number of awards and more than 100 publications in his name, Professor Girish. He is Professor of Cardiology
अपना
at GB Pant Hospital with us, with more than 20 years of experience. We shared an excellent chemistry when we were together in GB Pant Hospital. His intervention, his interest is in the complex coronary intervention and imaging. Dr. Girish is a principal investigator of many research trials being conducted globally. So over to Dr. Girish for the further proceedings.
Thanks, Dr. Naveen. At the outset, let me congratulate on a very wonderful meeting on this Sunday morning session. And today being the Teachers' Day in India, I feel very proud to introduce one of my esteemed teachers, Professor Vijay Trehan, to deliver his lecture on these emergencies in Cath lab. Professor Vijay Trehan is Director Professor Cardiology at GB Pant Institute of Medical Sciences and Research Center. He has more than 30 years of experience in interventional cardiology. I would say he is jack of all and also master of all. And he is one of the most sought after teacher anywhere in any part of India as well as in other parts of the world, like United States. He is a teaching faculty at TCT, EuroPCR, C3, India Live, NIC, and his lectures at NIC usually is like Friday first show, first day first show of any movie stars. It is nothing short of houseful, and the crowds go beyond the seams of all the boundaries of that hall. And my association with him has been for a long time, and I have learned a lot of things from him. And no one better than Vijay Trehan sir to have delved the lecture on this emergencies in the Cath lab. I would like to now welcome Professor Vijay Trehan to deliver his lecture on that. Thank you, sir.
Thank you, Dr. Girish. I think this was more than what I deserve. I know about myself, but I don't know whether this will turn an anticlimax, because what I was supposed to talk about was the basics in Cath lab, because I had some difficult cases to show, but then I chose that I just talk about simpler things rather than some out of the box things. But I also tried to do a little bit of bench testing, which I like to share in this talk. So if you get into complication, which all of us get into it, and let me tell you, many of us, once we are dealing with them, we get lost because we hardly have any support as far as technology is concerned, because it's not TAVR, it's not MitraClip, not IVL. So the support from the industry will be not too much. And you will have to use most of the time your own skills and the material which you have in the Cath lab to bail yourself out. And all of us have different techniques and to use the available technology, and we have variable success. And I'll just try to share as to what I do when I get into one of them. Let me just start with a case, which is not my case. I just try to share it and just try to share it with you and see as to how we react to a free-flowing perforation in the LAD at apex. Well, we all know we have covered stents, PTFE, double layer of stent in the form of Joe, or a single layer of stent in the form of PK Papyrus and B graft, or a pericardium covered stent. But I'm sure they will not work in this case. Indigenously, people try to stitch a balloon. They try to sandwich a balloon between two stents and put tagadam and so on. When these stents, these covered stents were not available, so we all tried to devise few things, but I'm sure none will work in this case. So we'll have to work through maybe a microcatheter. And the options are, we have PVA particles. They start from smallest size, like 300 micron. It's like a very fine powder, which can be easily suspended in saline or contrast in a syringe and can be pushed through a microcatheter. Or it could be the largest particles, is about 4 times size. It's like a coarser powder, also looks coarse in a syringe, but require a much bigger ID. Routine coronary microcatheters cannot be used for it. And I'm sure none of them will be able to take care of this kind of a perforation. We can turn our face towards biological autologous material, which is typically fat. And where do you get it from? Those who are doing radial will get adjoining abdomen, but those who are at the groin, I think they can pinch out a piece out of it. But if you put it on a microcatheter, this big piece cannot be delivered through a microcatheter. We all know it. So we know how to tease it. We can tease it with various methodologies, but I find a blade and a needle is very handy to tease it. And then you can transfer to a ball, and finally to a syringe, and then to a smaller syringe with one piece, and put it in a microcatheter. And we all know that if it is only fat, it will float. If it also has a fibrous tissue, it may or may not. And if it is not floating nicely, or then maybe you can push it with the help of anything, needle or maybe wire, just close to the nozzle. And all what is required is you connect a syringe to it, and then a small syringe, of course, and then you push saline through it. But mind it, do not push it with the help of a wire, because if you push with the softer end of the wire, what you're going to get is the softer end is going to get stuck with this fat piece, which is a little bigger than the idea of the microcatheter. And if you push it with the hard end, that will just pass through this fat or cut through the fat without pushing it distally. So don't push this fat inside the microcatheter with a wire because of these nuances. Obviously, if you take a bigger piece of fat, it will not climb up the top of the microcatheter. The reason is you have a hub end which is tapering on. And you can force it through this microcatheter by a forceful injection using a small syringe. But then this might get stuck somewhere in the length of the microcatheter, because there the ID is small. Also, if it is pushed out of the microcatheter, the small vessel may not accommodate, and it might just spill out into some other part of the circulation. Thirdly, if there is a forceful injection, it might amount to something like a wedge injection, which might worsen a bleed if your microcatheter is very close to the bleeder, or it might also result into loss of the fat beyond the site of bleeding because of that push, because it goes like a missile. So you have to have a size which is typically floating up till the nozzle. And if it is so, then it can be very easily, if you see it, it can be very easily pushed out of the microcatheter by simple and gentle injection of saline. You don't need to push. And that is what is a size which I think we should be aiming at. The other biological material is blood, which you can take from a syringe. This may or may not gravitate down depending upon whether it's a retracted clot or not. And sometimes you might have to push it down with maybe needle or what. And importantly, this thrombus also, especially if it is a relatively fresher thrombus, which is typically what is there on the table in a cath lab, then this can also be very easily pushed out. But mind it, depending upon the size of the quantum of the thrombus used, you will have a length of the cast of the microcatheter. So if you put a bigger clot and then you push it, sure, you will be able to push it because clot is much more malleable than fat. But then you will find a longer length of the cast. And if it is not fitting the size of the vessel, again, it will spill out and get into adjoining circulation. You have other materials in the form of sponge, which comes in different shapes and sizes. You can convert it to a small powder by scraping with the help of a blade. And some people have even embolized suture material and even floppy tips of PTC wire, but they are unlikely to be working, especially if you deliver them through a microcatheter, because the size will be small, at least in the given case. You can inject liquids like thrombin or maybe cyanoacrylate glue, which I think will require a lot of technicality, I think beyond the scope of this talk. And this cyanoacrylate glue comes in these things. All of them are available in the market on any of the confectionery shops. And Fevikwik, I think all of us can very easily get it for just ₹5. But you have to understand the nuances and risk of injection into a main vessel. That is LAD in this case. So I don't think somebody with an ordinary experience should venture into injecting cyanoacrylate glue into this distal LAD. This, of course, can be done, but will require a lot of training. I think the best bet will be that you take coils, which come in different sizes and different shapes. I think all of us have experience in using coils. But let me tell you, the coils have a tendency to go off because most of the time we are using pushable coils. Ideally, we should use detachable coils, which can either detach with the help of electrolysis, or they can detach on the command of mechanical. Like if you push button, then this ball and socket system will get released and the coil can be released. This is only after ensure that the coil has reached at a specific point and the bleeding has stopped and the coil is not moving. Once I say 1/8 coil, I mean this is dies 1/8, and this could be like 101435 or 38 coil. If I say 2 millimeter 18 coil, then I mean it's a 2 millimeter diameter. Similarly, 5 and 10 millimeter coils are again 5 and 10 diameters. If I say 18 coils, 2 into 30, that means 30 is the length of the wire, which is unconstrained. That is 30 millimeters is the length of the wire. A wire should be, this coil should be pushed through a microcatheter, which is corresponding with the ID of the microcatheter should correspond with the outer diameter of the coil. Why? Because if it is pushed through a larger ID microcatheter, then the coil will become like this. And obviously through a smaller microcatheter ID will not go. Also, the pusher should also be of the same size, because if the pusher is of the same size and everything's, the ideas of microcatheter is also same size, then these are very, very uniform and easy pushing of the coil. But if the pusher is smaller, like coil is 1/8 and you take 1/4 pushing wire, you take a hard end of the 1/4 tapered wire, that will just get along the side, might get jumbled up with the coil. It may be difficult to even get out of the microcatheter. So I think I can just skip some of them because I've discussed. Now let's just get back to this. In this case, this coil was delivered. Sorry, not working. Video is not working, but the coil was delivered, but the coil went out of the microcatheter. I'll just show you that maybe in a that video is not working. Actually, what happened was the coil was delivered through this microcatheter, and the coil went down and out of the vessel. Can you just bear with me and I can transfer one image. I'm sorry for a miss out. I think that will show you well. So there is a microcatheter down this vessel, and through the microcatheter there is a wire, safety wire in the other vessel, and then you bring a coil from above, and then there is a pusher with it. This coil is reasonably good size, but what happens is the coil gets out of the vessel and is kind of lost.
So I think there's a lag in the slides. We cannot see the slides.
Are we able to see that?
No, sir.
We are not able to see the video?
No, sir.
Sorry.
You have to share that video.
I think you can stop the sharing and restart sharing again, sir.
Okay, I'll do that. I'm so sorry, because this video is not working, which is pretty important. Are you able to see the videos? Are you able to see the screen?
No, sir, no. We are able to see the screen, but no video. Yeah, video has started now, sir.
Video started. So I think this will work. Okay, fine. So this is a tip of the microcatheter deep down in the LED, close to the site of perforation. And what you see is through the microcatheter is coming a coil, which is straightened up with the help of a pusher. This coil gets into the LED. Obviously, the pusher sometimes has a tendency to overshoot the target. And then if you see, this coil stays in the vessel for a while and then gets out of the vessel. So this is lost. Now this has happened in this case. And if we look at the size of the coil which is used, if you look at the vessel, even terminally is around maybe 2 millimeters or so. And certainly this coil is much bigger than that size. So these coils, even if you sometimes oversize 50%, they can have a tendency to get lost into the distal circulation, especially if there is a pool of circulation distally. Also, let's say you don't have bigger coils. you have only smaller coils, and you also have some of the centers where you don't have microcatheters or coils. Then if you have to handle this case, and since this is a conference on so-called innovation, so I thought, let me bench test on some of the things which are already in the literature. I'm not describing them, but they are already in the literature. Probably a very faint description was there. So I thought, let me, for the benefit of the audience, bench test them. And there were a couple of things which were in the one was that if you can take a cut balloon, you can put a balloon here and you can push the balloon like this on a wire which is already there, and you can finally deliver this cut balloon on it. It looks fine as far as animation is concerned, but let's see what is there on bench testing. You can put a balloon on a wire, and if you look at the balloon here, especially if it is a new small short balloon like 1-5 sprinter, which is a compliant balloon, then the profile of the balloon here will be more or less the profile of the balloon catheter. So this will be able to take care of only small perforations. If you want a bigger profile, you will have to use maybe bigger, longer NC used balloons. Then you can close even a bigger vessel. But then if you're using a bigger profile balloon, you may not be able to deliver to this distalmost site. And somewhere in the middle of the procedure, if your balloon is refusing to go, you cannot get it back unless you try to use a snare, which is very, very difficult in these difficult scenarios. So maybe this can be used for closing only very small vessels, or if like in this LED, this thing will not work. And in this LED, if you want to use it, maybe you take something which is like sleek, you take like a smaller profile, and then you convert it to a bigger profile. And how can you convert it to a bigger profile is that you can take a new balloon, and then this new balloon, into this new balloon, you can telescope another balloon, and then you can funnel up the proximal end of the cut balloon with the help of the inflation. This is what I mean. If you try to push, this balloon will not go inside the cut balloon already, because if you cut it here, again, this part of the shaft of the balloon will not be able to enter the cut balloon. The reason is the shaft of the cut balloon will come in the way. So what you can do is you can cut the shaft of the cut balloon here, so that the cut balloon has a shaft extending from here to here, and this part has no shaft. And if this part has no shaft and you have already cut the shaft of the pusher, then your cut balloon can telescope into it. And if it telescopes into it, if you now inflate this telescoping balloon, then the cut balloon can also become like a funnel. Now you have taken it like a sleek balloon and you get converted into a funnel, which is now you are converting into a bigger. So this is how you can take a smaller balloon and you can close even a smaller, means smaller profile balloon, which is uninflated, new, and close a vessel up to 2 or 2.5 millimeter in size, like it was in this case. But if you cut it many times, the moment you cut it, your balloon can fly away from the table. So very simple thing, because when I was doing it, I realized that if you do not hold this end, this might just get off the table. Sometimes you just have one new small balloon which you want to take in, and on the shelf you may not have another balloon. Also, you might waste one new balloon just during cutting if you're not careful. So if you just, maybe somebody holds the tip of the balloon, this will not fly away. Or maybe tip of the balloon can be kept in a syringe, again this will not fly away. Or if you cut it with the help of a blade, again this will not fly away. So sometimes very, very simple things can help you. Now if you take this pusher balloon, and this is a cut balloon, and you try to push it, as we have seen it, the pushing cannot be done because of the nozzle part of the nose cone of the pusher balloon, which is getting stuck at the shaft of the cut balloon. And we know that we have to sacrifice this part. We also have to sacrifice this part. And finally, we should be able to push it. But how to cut the shaft of the cut balloon? The simple thing is retract the balloon material like you do a prepuce over a penis. Take it back. And after you retract, then you can easily cut it. Now you can easily cut it. And this way, if you do it on a plain surface, it is very, very easy. But it's easy if there is no wire inside. If you have a wire inside this cut balloon, it may be easy to stabilize it, but it is very, very difficult to cut it. If you see it with a wire inside, it's very difficult. These are very simple things which I learned, at least at the time when I did some bench testing for it. Now you can pull back the cut balloon, which is like pulling back the prepuce. Now, after this is done, then it is ready for embolization. One simple way is like the electrician do. What the electrician do is they will retract the insulation material. After the insulation material is retracted, and then they will use a plier to take the insulation off. And we can do it with the help of a scissor. And we can take this shaft of the balloon off after this is cut. And now you can put it back. And now this balloon is ready to be pushed. But if you look at the profile of the balloon, this profile of the balloon here is not very good. And if you have to convert it to a bigger or a smoother profile, because this will not be opposing with the vessel wall. What you need is you need to telescope a balloon into it. And after you telescope and inflate a balloon, this will become circular. It will be able to take care of the vessel. Now look at this. This new balloon easily telescopes into it. And now if you inflate this balloon, this will also become roundish and will become bulkier. Like this. And this is how the cut balloon proximal end looks like. This went like a smooth, low profile balloon. And after telescoping another balloon into it and inflating, this proximal end becomes like this. Now this will be opposing with the vessel wall. But you can still have some trickle of the blood through the wire lumen of the balloon. But sometimes just pushing the wire or a balloon over it can invert the proximal edge and may be able to at least you convert a bigger hole into a smaller hole. Or sometimes if you have then got a microcatheter, then you can push small things into it, which may be very easily constrained into this balloon. Means if you have a cut balloon embolized and now you want to push a coil into it, the coil will be easily held by this cut balloon. So I will say that you should use if you have a bigger guide, then I think things are pretty easy, but always use a new wire, because if you're taking old wire, it may be very, very difficult. And if you're taking a new wire, and then like you do it for embolization of delivery of a stent graft, use a ping pong technique to use two balloons, two guiding catheters, and a second wire will help you a new second wire will be helped stabilized by the balloon which is tamponading. So you should be able to deliver the material over the second wire, which is new. And I'll say that always try to do a dry run, maybe with an NC balloon, because if you're able to take an NC balloon on a second wire, either through a single or a two guiding, then you should be able to take this cut balloon to that side. Now, let us say you have fat. Now, people have described that you can take a fat, but I thought fat, if you look at this piece, you have skin on one side, this is skin, and there's a fat on the other side. Now, fat is very easy to pierce with the help of a wire, and but it will be much more fragile and is likely to possibly break in pieces during delivery. Whereas skin will be much tough to pierce, but it will stay intact during the time of its delivery over a wire. Now you can tease the fat off the skin, and then you have a skin like this, which is with very little fat. If you try to pass a wire through it, you find it is very, very difficult to pierce the skin with the help of a wire, especially if you're going from the dermal side. From the hypodermal side, you may still be able to pierce it. If you look at it, if you hold a wire very, very close to the tip, you may be able to pierce it, but otherwise very, very difficult. So simple thing is, I think don't get into all these nuances. Simple thing is you just take a needle, pass a needle over it. This is a much bigger needle. Take a smaller pediatric puncture needle, and through this needle you can then load a wire into it. And after it is loaded, it becomes like this. Now you trim off the pieces of the skin so that it becomes like a very, very small piece, which is tailored according to the size of the vessel which you want to close. And if you are just taking fat, I'll tell you that this fat can cut through, which is very, very difficult and to deliver, and it is much more fragile. Now, you should take care that you don't cut yourself if you're using blade, which is one of the nuances. Now, this is like a seekh kebab. This skin piece with little bit of fat on it can be loaded on a wire. Once it is loaded on a wire, then you can push it with the help of a balloon. Now, if you push a fat through a microcatheter, look at it, you can deliver only a very small piece, which can go through this. But if you are delivering a fat, if you're delivering a skin, then you can deliver a bigger piece, Second thing is you do not require microcatheters there. So if you do not have microcatheter there, and if you have a bigger vessel to close, like in this LED, I think this will be very, very simple. And I think available to almost all of us. You take a piece of skin, pierce it with the help of a needle, load it with a wire, trim the extra skin, tailor it according to the size of the vessel, and then just push it with the help of a balloon to the site. And how do you release it? Once it is gone to the site, then I think at that time, you just pull back the wire into the balloon, and then you pull back both the balloon as well as the wire together. So fat piece or the skin piece will be left there, and this will close the vessel. So I think if you do, all of us do some kind of a bench testing, then maybe one of the situations when you do not have a microcatheter with you, you do not have coils of the size with you, vessel is a little bigger, and you have a different varieties of stent grafts, and I don't think they will work in a situation like this. And a simple technique of either using cut balloon or a skin or a fat loaded on a bar without a microcatheter can at times bail you out of the situation. Thank you very much.
Thank you very much, sir, for the excellent demonstration, both bench testing as well as on the patient. And I would like to welcome our panelists also, Dr. Richa, Dr. Pankaj Manoria, Dr. Ravi Dalmia, and Dr. Rahul. I would now invite my co-chair, Dr. V.K. Bahel, Dr. M.S. Siramat, and Dr. P.K. Goel to add upon to the existing lecture.
Good afternoon, Vijay. I think it's always a privilege to listen to you. And I think the audience has only got a glimpse of his talent, which he has. So what he can teach you in the bailout strategies as a smaller part of his talent of innovation. So I think you can't have a better speaker than him to have in the innovative cardiology conference, because you talk of any innovation in India and he has something to contribute to it. It's always a privilege and learning to listen to Vijay, and I think this is what we learned today. So I think you should change your last slide. This is what you show every time. Nobody can sleep while you are delivering the talk. So I think next time you change the last slide. I told you previously also, I think in some of the interactions which we have. Excellent.
Hiramat and Dr. Goel.
Well, should I speak? Hello.
Yeah.
Yes, sir.
So whenever
Whenever
I read your name on the agenda, I make it a point never to miss anything from that talk and raise another area, a different area compared to what you talk normally. But again, a big learning for many of us from this. The issue is what you prefer to see under these settings.
I think my best bet is coils, because it's a very, very controlled delivery. Even though we do not have really detachable coils in most of our cath labs, either mechanically or electrically detachable coils. But I think if you size the coil, like in this case, like if I were doing this case, and what I would have done was I would have taken a microcatheter little proximal to this. I would have taken extra care, not pushing my coil too much, because this tip of the microcatheter is sitting very close to the perforation. In fact, it's like a vessel which is fully open.
Yes.
And, definitely try to size the coil as they have size. I think the size was pretty okay. The problem is probably it was pushed too much. And second thing, many times it is just the push of the contrast. If you push the contrast with a force which is in excess of the systolic blood pressure, then you try to shift them discretely. And in fact, the fundamental in any of the perforations is, if you try to see them better, you try to take your guiding or microcatheter close to the site. And sometimes in this endeavor, you forget that you are close, the force generated is also more. And if the force generated is more, then either the embolized material will embolize further, or if it is at the diagnostic stage, it is possible that you are just worsening the perforation. So I think if the care was taken, if let's say in this case only, if you have a proximal balloon which is inflated, and that balloon is working like a tamponade, so it gives you comfort during the procedure. You deflate the balloon only during the time when you're doing something distal to that balloon. And then if your injections are relatively gentle, your pushing of the wire is also relatively gentle. The tip of the microcatheter is also kept a little proximal. I think the same could have been very easily handled with the help of a coil. But the topic was that if you do not have coils, or if you do not have microcatheters, or they are there but you have run out of stock, which sometimes we do, because many of the cath labs are not so busy cath labs that they do not have too many things on the shelf. So what if either the microcatheters or coils are not available, and then can you do anything just on the wire itself? And all of us are I think all of us are very experienced in delivering things on a wire. And if your wire is there, if it's a big catheter, or you have put two catheters there, and you take another wire there, a new wire there, and you're able to do a dry run with the help of an aux NC balloon, and you're able to take an aux NC balloon to the side, then I think if you know how to make a cut balloon, or if you know how to take a piece of skin and load it on a wire, then I think for most of us it will be simpler thing to put anything on your wire and push it with the help of a balloon, and especially if microcatheter and coils are not available. And this is just a bench test, but I am sure if you have done, like I had a lot of problems during bench testing which I shared, and if we had done those bench testing, then I think we will be in a position to probably handle this kind of a perforation with these indigenized materials in the absence of microcatheters and coils. But as I told you in the beginning, my best bet will be coils, because according to me, you can do a very, very controlled delivery with the help of coils, even if they are not detachable coils, they are pushable coils. The only thing is you have to learn to size and be very, very gentle in delivering, and be very sure as to where is your tip. Like if you deliver a coil and if you are pushing it with the help of a wire, will go. This will also sometimes injure the distal circulation. Also, if it is not going, you generate too much of pressure with the help of your syringe. Not only it will get out of the tip of the microcatheter, it will just fly off somewhere, because there is a lot of force generated onto it, and it will act like a missile which will run away. But if you just drop your coil distal to the tip of the microcatheter, which is positioned just close to the site, and if your coil is oversized by about 50%, then I think it should stay there. And especially if you want to check it, you do not overtly over inject. Don't pressure inject into that circulation. Then I think these coils usually they don't embolize, they will stay there. And since you can see them all the time, for me, I think the best bet will be coils. But just in case they are not there, that was the discussion, because the conference was on innovation, and that was an innovation during the problems.
Sure.
If you have to say that in not a so busy lab, what are the toolbox one should have for the audience, like minimum toolbox to bail out?
I'll say out of the microcatheters, fine cross, because the idea of fine cross is very good.
So one is microcatheter, another is coil, third is
second is with the microcatheter you should have a pusher.
Okay.
If you are using a pro grade, then the pusher comes from the company. But if you are not using a pro grade,
I'm not saying about this case. I'm saying in a general, suppose you have a medium-sized lab, which all of us, many people have. So what is the minimum toolbox they must keep in the lab for because you keep on dealing with this. So it's just to give your say 4 or 5 things you must have, like a covered
as to what I mean is, most of the time, if you have a proximal big vessel perforation, we are able to help ourselves with the help of a covered stent. The problem comes with the distal perf. For a distal perf, I think the things which you require is a microcatheter which can go there, and fine cross is probably much more deliverable than is pro grade, and its ID is 1/8, so it can take all coils which are 1/4 or 1/8. Number 1. 2 is you should have a pusher. If you are using a pro grade, then there is a pusher from the company which is a plastic kind of a wire which you just push it with a metal at the tip. But with fine cross, you can take platinum plus 1/8 wire. And during the time when you're trying to deliver the coil through the hub end of this, you can sometimes use the hard end of the wire while you're trying to deliver out of the housing. But once the coil has gone inside the microcatheter, then use only the soft end of the 1/8 platinum plus wire. This is 2. 3 is most of these perforations will require a coil of 2 or 3 millimeter. Most of them, because if it's a big size vessel, then this store, because mostly you perforate either with the help of a wire tape or sometime the wire loop which exits, or sometime a balloon on the wire gets out of the distal vessel. So most of the time the vessel which you want to close are 2 millimeter or less in size. And if it is a 2 millimeter vessel, I think 3 millimeter coil is good enough. For a vessel which is less than 2 millimeter, we'll use a 2 millimeter coil, because 2 millimeter coils often are able to handle a perforation in a vessel of about 1 to 1.5 millimeter. But if the vessel which is perforated is less than 1 millimeter, then 2 millimeter again becomes a bigger size. And then this coil will not make a roundish. This will be straightened. For that, I think these indigenized systems like fat and PVA particles, because if there is a distal tip perforation, then many times this fat and PVA particles, because they are able to handle very small perforations. So I'll say 1/8 fine cross, platinum plus wire, 2 and 3 millimeter coils, and maybe a little bit of hands-on using PVA particles and harvesting fat and using it, and sometimes clot.
So you have concentrated on perforation. I just wanted to say, like, so you should have coils, microcatheters, a covered stent, and a snare. I think these are the 4 things which everyone should keep on the stock at least to take out, because you never know when you will land into trouble. And then you can't have, I know you can make these snares by the technique you also have described.
It is always best to have snares from the company.
At least these 4, I think every lab should keep. You agree or anything to add?
Can I say something?
Yeah, sure, Girish. Oh, Dr. Goyal, I think Praveen is there. Yeah.
Actually, very nice talk, I would say, as usual for Dr. Trehan. But trying to summarize and make it shorter, so these 2 on the wire techniques, if you don't have a microcatheter and stuff, well, the balloon thing, I think I'll have to understand from him a little better. So that's right. But what I usually do, I keep this, the glue. And I think people must have read my article in CCD, which was a long time. And there are a couple of them which came in the publication form, because I did not have anything that day. It was early, I think 98 or 2003, sometime that time. And I got the radiology guys and we used glue. And I'll tell you about that glue, especially for the distal perforations. It is very good. A few things one has to take care of. The glue has to work with a liquid, with a dye called lipoidol. Lipoidol is a sodium-free dye, which I always keep in my that toolkit. So you mix 1 ml of that. Sometimes it was not available and things like that. You mix 1 ml of the dye and 1 ml of the glue. So what happens? You can see the glue, because glue is dangerous, as Vijay also said. So you have to be very careful. So you will use it only for a distal perforation, and more distal the perforation, better to use a glue. Coils sometimes back up; they don't reach that side. Size is small. He talked about sizes and all. So glue will certainly percolate, and so distal perforation, and you can see it travel down because it will move like contrast inside the catheter. And you need dextrose. You will not use saline. So you will clean the whole thing, have dextrose flushed, because the glue solidifies in contact with sodium ions, and all dyes have sodium ions. Lipoidol is the only one which is sodium free. So you clean the stuff with dextrose, your microcatheter lumen, and then have this mixture 2 cc and gradually inject it. So, but you have to do it very stepwise, and the moment it goes in,
and then immediately you have to stop, and after stop, you pull back the microcatheter. If you don't stop and pull back the microcatheter, it will exit on the way and free and solidify the entire circulation. So it is that way dangerous, and one has to be careful. But it closes the things very easily and instantaneously. Coils can back up, can go here, there. It can come proximal. So that is also one thing which I think in this innovation thing. So when I did it for the coronary, I think that was the first one. That's how it got published. So that one can think of.
Let me just add as far as glue is concerned, because we have done ample number of cases and even used glue for perforation in the heart during the time of doing PTMC. We have been able to close a big hole into the stitch of the RA and LA and then bail the patients out. Couple of things important. First is if you're using a glue, be very, very sure that you are able to lead as well as trail the quantum of the glue with 20% dextrose. If that is not available, maybe 10% can work. What I mean is you attach a three-way to a microcatheter, and on one side of the three-way, you have that 10 or 20% dextrose. So maybe about 1/4 cc of the dextrose will be leading into your microcatheter before you add up that glue into it. And after the glue goes into the microcatheter, which is from the other syringe, after you switch over these three-way on that direction where you have a glue attached, after that said you have injected the quantum of glue which you want, which will be decided as to what is the volume of vessel which you want to close. It could be just 1/10 of a cc or could be half a cc. And if you are using a quantum which is in excess, then you are likely to get into problem. And for doing all these things, you have to be extraordinarily smart and calculated. You should know what is the dead space of your microcatheter. And thirdly, you should use either a 1 cc tuberculin syringe or maybe even sub ml syringes, which are like 0.5 ml syringe, because the quantum here to be used for glue is generally less than 0.5 cc. And even the leading and trailing by a 10% dextrose again has to be very small, because if let's say you have put 1/4 of a glue, 1/4 of a cc of a glue into, which is a pretty large volume for a small vessel, and if 1/4 cc of a glue has gone in and then you push in half a cc of dextrose after that, maybe you created a lot of problem. Thirdly, if you try to deliver these glues, it is always better to go through an over-the-wire balloon system, because over-the-wire balloon system will try to block any blood from coming and visiting the distal circulation. And finally, Lapadal is very good to tell you as to where the glue is gone, but definitely it takes away the performance, because if you add the 50-50 Lapadal with glue, its performance will go down to 50, because most of the time we are not concerned in looking at the glue. What we are concerned is we are looking at whether the bleeding has stopped or not. So I will say probably no Lapadal, use the smallest volume, be very, very sure about the dead space of these microcatheters, which let me tell you, it is like 1/6, 1/8 of a cc. And if that kind of a dead space you're looking for, you should use a syringe which is 1 ml or less than 1 ml. And then the leading and trailing by a 20% or a 10% dextrose should again be like 1/4 cc, because anything in excess of this will create problems. And lastly, the glue will polymerize in about 8 to 10 seconds. So it is like hit and run. After 8 or 10 seconds of the delivery of the glue followed by a dextrose, you should be able to deflate the balloon and pull it back. Because if your balloon tip stays there anything more than 5 to 10 seconds, then it is like a rescuer getting trapped at the site where he has gone for rescue. So you should deliver and quickly hit and run.
Yeah, you are absolutely, you put some added points, but I can tell you lipoidol is very good to see, because it tells you exactly where you are, and otherwise just a moment. Because just calculating volumes, I understand all that and we do that, but just calculating volumes, you may not be precise. And if you miss it, or you leave it with the glue there for 3 seconds, the damn thing is going to get stuck. So you must exactly know when it reaches, and the moment it reaches, you stop and you come out. So that is why I use lipoidol, and that's the safest way, I think, because the radiologist guy who told me that for the first time, we started lipoidol, and I have always done it with lipoidol.
Also, one of the ways to calculate the volume is if your microcatheter or a balloon catheter is there, then you are using a sub ml syringe, then you can calculate from outside that like you have injected only 1/8 or a 1/10 of a cc, and then you have filled up the whole vessel. So you will know that out of the tip of the microcatheter only this volume should exit, because this is also one simple way of calculating. Because as far as calculation of the dead space of the catheter is concerned, you can do it on the table. But what about the volume of the vessel which you want to close? Means size of the glue, the quantum of the glue coagulum which you want to form there. If it is a bigger vessel, then the quantum of dye which you inject from outside will be more compared to the one when you have to close a very, very small vessel. I think all these things have to be calculated. So what I feel is that glue can be used, is very handy, but probably will require a lot of expertise and calculation. So I always feel that coils are, I think, safer. You see them, you taste them, you can do everything under control. If you had detachable coils, then I think you are in luxury. But if they are not there, then maybe a smart use of these pushable coils.
Thank you so much, sir. I think we are already running 1 hour beyond schedule. I think with this, I would like to congratulate Professor Vijay Trehan and thank Dr. P.K. Goel, Dr. Bahal, and Dr. M.S. Remet, and also the panelists. And back to you, Dr. Naveen.
As Dr. Trehan is always full of innovative ideas, he has shown here also the innovative technique. And thanks for accepting the invitation, sir. Thank you very much, and happy Teachers' Days to all. So thank you, Dr. Bahal. Thank you, Dr. P.K. Goel. Thank you, Dr. Hiremat, Dr. Girish, Dr. Ravi, Pankaj, Rahul, and Richa. So now we are moving to session 6. We are running late by 1 hour. So next session will be on heart failure. And the chairperson for this session will be Dr. T.S. Clare and Professor Vimal Mehta. Dr. Devendra will introduce the chairperson. Now over to Dr. Devendra.
Yeah, good afternoon, everybody. And for next session on heart failure, we have chairperson Dr. T.S. Clare, and he doesn't need any introduction. He's have experience of more than 28 years. He's has FRCP, FSCC, and other various fellowship degrees. He has performed more than 25,000 numbers of various coronary or other interventions. He has also interest in electrophysiological procedures and doing various type of device procedures, including ICD, CRT, D, and other. He has also interest in his bundle pacing and conduction system pacing. And for his name has more than 150 national and international journal articles. Welcome to you, sir. And the next chairperson is Professor Vimal Mehta, who is Director Professor of Cardiology at GB Pant Hospital with more than 15 years of experience. And he has very keen interest in academic activities and has more than 70 index publication, and he's participated in principal investigator in many international journal trials, including DAPA-HF, Emperor Studies, Fourier trials, Surpass, CVOT, Epicor, and many of them. He has presented many lectures and research papers at multiple national and international conferences. And with this, I hand over session to you, sir, for next 40 minutes or so.
Well, thank you very much. Naveen, am I audible?
Yes, sir, you are audible. Yes, sir, you are audible.
Okay. So thanks very much for inviting me to chair this session. And, you know, they say that in every adversity, there is an opportunity. And that's what happened with me today. The session was being delayed and I had to travel somewhere. But in the bargain, I listened to Vijay Trehan's fantastic lecture and some fantastic comments by Bahal and P.K. Goel and Hiremat. So that is advantage always. So I think without losing time, we can go to the first talk. First talk is going to be delivered by Dr. P.C. Minoria. Minoria is my senior from PGI Chandigarh. Is a luminary in cardiology, and he was professor and chief of cardiology in MP for a long years. And his son Pankaj also was with us, and both have done fantastic work in their area. So I think without losing time, I will request Professor Minoria to give his talk, War Against Heart Failure.
Good evening, everybody. Good afternoon. For the next 15 minutes, I'll be talking on war against heart failure, the new weapons in the armory. All of us know the last couple of years has witnessed a sea change in heart failure care, both in terms of enhanced understanding and in the availability of a panoply of therapeutic options. The management of heart failure basically revolves around drugs, devices, and transplant. Non-pharmacological measures are used as an aid to treatment with definite. I will be talking only about drugs in heart failure, devices, and transplant. I will not be touching upon. In our ongoing war against heart failure, these are the old approved drugs, and these are the new approved drugs: ARNI 1B, SGLT2 inhibitors 1A, vericiguat 2B, tafamidis 1B. And omecamtiv mecarbil is still under evaluation and has not been approved for clinical use. Now, this is an overview of ESCHF 2021 guidelines for heart failure, and this shows the layers of recommendations for HFrEF. As you can see, these four fantastic foundational drugs, ACE/ARNI, beta blockers, MRAs, and SGLT2, must be used in all patients with HFrEF to improve outcomes. Loop diuretics are used to decrease congestion. I will not be touching upon ivabradine, hydralazine, isosorbide dinitrate, digoxin, and IV iron. But we'll talk about vericiguat and omecamtiv mecarbil also. Now, these are the new universal definition of heart failure, and all of us are aware of it. Interestingly, SGLT2 inhibitors have become a panacea for heart failure. They have produced positive trials in HFrEF, the landmark DAPA-HF trial, and the EMPEROR-Reduced. And last week, we had the EMPEROR-Preserved trial, the first trial which has shown improved outcome with empagliflozin. Now, when we look at the management strategies prior to SGLT2 inhibitors, most of the drugs which improve outcome, they act through modulation of the neurohormonal activation. For example, we have three important blockers to target the maladaptive neurohormonal system: the beta blockers for sympathetic, the ACE/ARB for the renin-angiotensin system, and MRAs for the aldosterone. And 2016, when sacubitril/valsartan was approved, it increased the activity of the natriuretic system by inhibiting the neprilysin enzyme. But 2019 initiated dawn of a new era when the first trial of SGLT2 inhibitors, DAPA-HF, reported positive results in diabetic and non-diabetic heart failure. And this laid the foundation stone of SGLT2 inhibitors in HFrEF. 2020, we have the EMPEROR trial, which produced similar results. 2020, we have two other trials with sotagliflozin, SGLT1 and T2 inhibitors from the SOLOIST WHF trial and the SCORE trial. And these two trials passed on three big new messages. Number one, sotagliflozin used in ADHF prior to discharge or 2 days post-discharge showed improved outcome. And the same strategy is being tested in DICTATE-HF and EMPA-HF. The second big message was that patients with HFpEF also showed beneficial results in these trials. And we have already the EMPEROR-Preserved trial, which is released, and we're keenly awaiting the results of the DELIVER trial with DAPA. And the third big message was that the SCORE trial showed 16% reduction in cardiovascular death, MI, and stroke, and that was a new finding. These are the completed landmark trials of sacubitril/valsartan, and all of us are very familiar with all these trials. The PARADIGM trial which showed a 20% reduction in the primary endpoint of cardiovascular death or heart failure hospitalization, paved the way for approval of sacubitril valsartan for chronic HFrEF. The Pioneer trial, which showed a 29% reduction in the primary endpoint of reduction in NT-proBNP, paved the way for approval in ADHF after hemodynamic stabilization. The Paragon trial unfortunately failed to reach the primary endpoint, but did show benefit in two subset of patients, females, and the ejection fraction in the range of 45 to 57, and FDA has approved sacubitril valsartan in this range of ejection fraction. What is the new data from sacubitril valsartan? The first new recommendation is that sacubitril valsartan can now be initiated in de novo patients, and you may not follow the policy of switch from ACI or ARB. The second big message from sacubitril valsartan is that PROVE-HF shown tremendous benefit in terms of reverse remodeling. And when we look at this data, 794 PROVE-HF population, 613 patients have LV ejection fraction less than 35, which means these patients were eligible for ICD. After 6 months, as you can see, as much as 32%, the ejection fraction increased to more than 35, and these patients become ineligible for ICD. And if you utilize the data after 1 year, as much as 61%, the ejection fraction increased above 35, so that 61 patients at the end of year previously were eligible for ICD because the ejection fraction was less than 35, became ineligible, clearly indicating that sacubitril valsartan has a very potent action on reverse remodeling and increasing ejection fraction. And you can see the ejection fraction may rise up to 10% by 6 months, and behind that, there's a further rise in the ejection fraction. So a new message is emerging for ICD implantation: optimize the use of RNA before ICD implantation for primary prevention of sudden cardiac death. We had the live trial in end-stage heart failure, and the trial was negative because as heart failure advances, chronic excessive activation of RAS blunts or overrides the effect of natriuretic peptide on the heart, the vasculature, and the kidney. We had the Paradise MI trial, which was negative, and perhaps the reason was because no run-in phase, which is not possible in MI patient, and hypotension was more common. What about SGLT2 inhibitors? These are the completed landmark trials of SGLT2 inhibitors in diabetes, heart failure, and CKD, and all of us are familiar with these trials. Now, SGLT2 inhibitors have completed the whole circle. We have trials in primary prevention, as you can see, secondary prevention. We have trials in HFpEF and HFrEF. So no single molecule in the world has improved outcome of both HFpEF and HFrEF, and SGLT2 inhibitors have performed this unique feat. They also improved renal outcomes, as shown by the Credence and ADAPA CKD trial. So SGLT2 inhibitors have not only completed the whole circle of cardiovascular continuum, but also the cardiorenal continuum. This is the landmark EMPEROR Preserve trial. All of you are familiar with EMPEROR 10 versus placebo, a 21% reduction in the primary outcome of cardiovascular death or hospitalization for heart failure. The primary endpoint was mainly driven by hospitalization for heart failure. No change in cardiovascular death or all-cause mortality. There was a decline in the slowing of GFR, but unfortunately, this does not transform into improvement in the renal outcomes. As you can see, EMPEROR reduced showed a significant improvement in the renal outcome. Preserved, there's no improvement in the renal outcomes. When we look at the subgroup analysis, unlike the Paragon trials, the males also showed benefit. All these subsets showed benefit. Ejection fraction, whether they're less than 50, 50 to 60, or more than 60, did show benefit, although the magnitude of benefit starts declining as ejection fraction rises. CKD also more than 60, GFR or less than 60. And this is the post hoc analysis. Again, this is a post hoc analysis knowing the pre-specified outcome. You can see as the ejection fraction improves, there is benefit till 64%, but after that, it vanishes. There is a win for EMPEROR Preserve trial. We are very excited, but this win is incremental and not monumental because there is lack of significant improvement in cardiovascular death, all-cause mortality, renal outcome, and total hospitalization. All of us are familiar with these three landmark trials. They decrease hospitalization for heart failure in patient at risk. The initial three landmark trials, the benefit was seen whether you are having ASCVD or no ASCVD, and decreasing hospitalization of heart failure is a great achievement, but all of us know every hospitalization, every re-hospitalization takes the patient closer to death. This is the landmark DAPA-HF trial. All of us are familiar with it. Diabetic, non-diabetic, HFrEF patients. And this is the result. The trial was prematurely terminated. Primary endpoint 26% reduction, worsening heart failure 30% reduction, cardiovascular death 18%, and all-cause mortality 17%. The benefit occurs very early. And there are three big messages from DAPA. Message number one, non-diabetic patients also benefited in a similar fashion compared to diabetic patients, and showed ARNI also showed benefit. And the third big message is it is poised to postpone device therapy in heart failure like the CRT and even LVAD. Patients with mild heart failure, those with prior hospitalization, and non-ischemic patients benefited more. Very safe drug. This is another new data from the DAPA-HF presented in ESC. Ventricular arrhythmias, resuscitated cardiac death, and sudden cardiac death showed a statistically significant 21% reduction, mainly driven by ventricular arrhythmias, as you can see. And this is a new finding, and all subset of patients showed benefit. We had the Emperor reduced trial presented in 2020. It showed similar result in terms of hospitalization for heart failure, but unlike DAPA, which showed a statistically significant reduction in all-cause mortality and cardiovascular death, Emperor reduced failed to show this benefit. Sotagliflozin, as I've already told you, a dual SGLT1, T2 showed big new messages. As you can see, the composite of cardiovascular death, hospitalization for heart failure, and urgent HF, 28% reduction, highly significant. HFrEF patient, cardiovascular death, HHF, and urgent, again, significant when it 22%, and HFpEF for the first time showed another 37% reduction, statistically significant. And this was the new finding. Cardiovascular death, non-fatal MI, and non-fatal stroke also decreased by 16%. So the other issue is what should be the sequencing of these four fantastic drugs? We have the conventional sequencing, which we do not follow because it takes a lot of time. Milton Packer rightly has advised a new sequencing that beta blocker and SGLT2 should be given preferential recommendation because SGLT2 doesn't require any titration, doesn't affect blood pressure, potassium, eGFR, potassium level, so it can be given very easily. Then we have the ECDF have REF ACC 2021 recommendation, which has given preferential recommendation for ARNI in HFrEF. For two reasons, it has shown excellent reverse remodeling data in the PROVE-HF trial, and I've already showed it has power to make ICD ineligible patient eligible patient into ICD ineligible patient by great increase in the ejection fraction. But interestingly, there's no sequence recommending from the Canadian guidelines, no sequence recommendation from the ESC-HF trial. So what should be the pathway? All of us must understand is all these four foundational drugs should be considered complementary to each other and never competitive. And depending on the heart rate, the blood pressure, and eGFR, one can sequence all these four drugs, but all drugs should be on the board within a week, 4 weeks or so. The mechanisms of SGLT2 inhibitors are multiple. I'm not going to discuss. You can see on the slide. These are the renal benefits. SGLT2 also decreases interstitial edema. This is perhaps one of the reasons why the trials in HFpEF have become positive, because once the interstitial edema decreases, the myocardial fibers will be able to relax better without any change in their pattern. The SGLT2 inhibitors can be used across the cardiorenal continuum. When we are treating heart failure, never forget that heart failure and CKD, they should never be treated alone because there is a close cross connect between heart failure and CKD. The cardiorenal continuum should be treated as a whole. And don't forget, targeting kidney disease triggers benefits for heart failure. And this has been the missing link which we have not recognized for several years. The CKD has been classified into 5 stages, all of us are aware of. And this is completed in ongoing trials in CKD. And the big messages are normal eGFR decline is only 0.9 per year. Diabetic CKD, the GFR declines to 10 ml per minute per year. And prior to the era of RAS blockers, most of the patients were shifted to dialysis or transplant. But the first revolution came with RAS blockers in 2005. This improved the decline in GFR from 10 to 4.59, a great achievement. The second revolution came with SGLT2 inhibitors, further decreased the slowing eGFR by 58% from 4.9 to 1.85. And the third revolution is now with the Finerenone, the non-steroidal MRA after the Fidelio DKT and the Fidelio other trial. And this drug has been approved by US FDA. They also slowed down the trajectory of chronic CKD and postponed dialysis by 15 years. So this is indeed gratifying. This is a big message. All cardiologists must focus on kidneys also when they are treating heart failure. And these are the 7 reasons why we must focus on kidneys in heart failure. Then we have the Victoria trial with vericiguatide. This is an oral stimulator of guanylate cyclase that stimulates the cyclic GMP production, which is important for vascular and myocardial health. And this is the trial design. It showed a statistically significant reduction, 10% driven by hospitalization for heart failure. And this is also useful for decreasing hospitalization. As you can see, the NNT is only 24, and it produced a clinically meaningful absolute primary reduction, 4.2 per 100 patients years. And lastly, this is the omecamtiv mecarbil trial. It increases duration of systole, increases stroke volume without any increase in myocyte calcium, DPDT, or in the myocardial oxygen consumption. And the galactic trial has been positive. A statistically significant reduction in the composite of HF event or cardiovascular death, driven mainly by HF event and not cardiovascular death. So what is our message? The first big message is utilize all 4 drugs for HFrEF. Beta blockers, ARNI, MRS, SGLT2. They provide incremental benefit on top of another. And the Emperor Preserve trial is the first trial to show benefit in HFpEF. If possible and feasible, all 4 drugs should be on board within 4 weeks or so, although the sequence of initiation may vary depending on the blood pressure, eGFR, potassium levels in the heart rate. Heart failure runs a malignant progression, and all therapies should be escalated to maximum dose if possible and feasible. One should not think of de-escalating because heart failure is never stable, potentially dangerous. Polypharmacy is the rule in heart failure, and the patient and the family must be motivated to accept it. And in heart failure, as already said, the cardiorenal continuum should be targeted as a whole and not HF. Targeting CKD triggers benefit for heart failure. And vericiguatide is a new weapon approved for HFrEF by ESCHF after RD and SGL2. And lastly, the big issue in heart failure is that the guideline-based therapies were highly underutilized. The ADSense is also suboptimal, and all of this make a cohesive effort to increase the utilization of all these guideline therapies. Thank you very much for your kind attention.
PC Vinoria, this was a fantastic mastery lecture. And I think I'm sure people have learned many new things, new trials. I think the most important message in your lecture, but I got was that before you implant an ICD, you must have used ARNI before you declare that patient needs an ICD. It's very good information. I don't think still it's a ACC, American Heart or European Heart Association recommendation, but I am sure that it will become a recommendation, and particularly for countries like India where cost is a big factor. I think that's a very good news. May I request Bimal to give a comment, and I feel that we can go to the next lecture actually, and Bimal, you can introduce the next speaker and we can have a discussion at the end of the second talk.
Yeah, sure, sir. Thank you so much, sir. And at the outset, I would like to congratulate Dr. Naveen for getting so many luminaries on one platform. And without wasting much time, I would like to introduce Dr. Karthikeya Bhargava, who does not need any introduction whatsoever because his great work has spoken for itself, which has been done over last few years. Nevertheless, for the sake of completion, I would say that he is a director of electrophysiology and pacing at Medanta Heart Institute, Gurgaon, Haryana, and he has more than 14 years of experience in cardiac electrophysiology, and he is well known in electrophysiology circles in India and abroad, and he is a section editor of Indian Pacing and Electrophysiology Journal and has many publications and many awards to his credit. Over to Dr. Karthike Bhargava.
Professor Vimal, for the nice introduction. And first of all, on this Teachers' Day, I feel my gratitude and honor to be delivering a talk in front of my mentor, Dr. Claire. Thank you so much for shaping our career and future. And happy Teachers' Day to you and all other teachers who have been instrumental in our lives. So I will be talking in next 15 minutes or so on left bundle branch pacing in heart failure. Now I'll start just by a brief background that primary pacemaker or purpose of a pacemaker is to stimulate the heart in patients with no ventricular rhythm due to heart block. And it was started way back in 1957 when the first battery operated wearable pacemaker was introduced. And as the technology grew by the year 2000, more than 200,000 pacemakers have been implanted in US alone and lot many in across the globe. And several trials compared atrial versus ventricular pacing and clinical outcomes related to different modes of pacing. And overall, they showed that pacing mode had no impact on mortality, but may play a role in stroke, prevention of AF, and development of heart failure. And so this is the quest for physiological pacing that has been grown. Once the VVI single chamber RV apical pacing started for complete heart block patients, it definitely saved life, but resulted in AV dysynchrony, rate non-response, and other issues like pacemaker syndrome and heart failure. And then rate response was added, which took away the rate non-responsiveness issue, but had still persistent with the other issues related to pacing. Now, once the dual chamber pacing came and AV synchrony got maintained, we thought that we have somehow found a physiological mode of pacing. But then we realized that RV apical pacing resulted in atrial fibrillation and heart failure. And there was then quest for alternate site pacing, where different sites in the right ventricle were tried, but none of them actually got found to be superior to RV apical pacing convincingly to avoid apical pacing altogether. Finally, we had CRT where atrial synchronous biventricular pacing actually resulted in better clinical outcomes and improved the survival in patients with heart failure. And it is now the gold standard in patients who have heart failure and left bundle branch block for improving their survival and morbidity. Now we know from that normal His-Purkinje mediated ventricular activation is ignored by RV pacing. Now the RV pacing results in myocardial conduction of the impulse to the left ventricle, which results in marked dysynchrony and alteration in the ventricular activation sequence, which is manifested as a wide QRS on the surface ECG and results in development or worsening of heart failure and other issues like atrial fibrillation. Now, we thought that biventricular pacing will obviate this issue, and it has actually worked quite a lot in this scenario. But we also know that biventricular pacing also results in a ventricular activation sequence, which is far from physiological, and the epicardial to endocardial activation of the impulse by the biventricular pacing is also not the anomaly that we see. Now, if we'll go back to our history, a very important study published way back in 1970 by the pioneers of electrophysiology, Dirk Durer, along with Hein Valens, they found that the earliest area of the ventricles to be activated were the ones that are actually the fascicles of the left bundle branch, that is the area supplied by the anterior fascicle, septal fascicle, and the left posterior fascicle. And the latest or the last part of the left ventricle to be activated was usually the posterobasal area. Now, we also know by a lot of studies which have been done to look at the cardiac conduction system anatomy that the Purkinje fiber network is quite vast, and this results in simultaneous activation of the different segments of the left and the right ventricles, and the higher rate of impulse conduction in the cardiac conduction, specialized tissues of the cardiac conduction is responsible for near simultaneous activation of the different parts of the left and the right ventricles. And pacing in the myocardium can never be able to achieve that, whether we pace in the apex or in the septum of the right side of the heart. And but it has now also been seen that his bundle pacing prevents ventricular pacing induced dystony in the normal heart, and whether it is selectively captures the his bundle or also captures the surrounding myocardium, the ventricular activation sequence looks clearly identical to that as has been seen in patients with intact AV conduction and normal narrow QRS complexes. Now, the studies have been done which have found that with his bundle pacing, the epicardial activation maps of the right ventricle and the left ventricle with different pacing modes in patients with normal intrinsic conduction showed that the selective and non-selective his bundle pacing, the activation map is actually more like intrinsic, even better than the biventricular pacing also. Now, if we talk about the history of his bundle pacing, though it is not a new concept, it was actually published first in 1977 by studies by Onkar Narula, who demonstrated that longitudinal dissociation in the his bundle is the reason for development of bundle branch block, and due to the asynchronous conduction within the his bundle in humans. And a year later, by great works of Al Sharif and Kenneth Rosen and Ralph Lazara, it was found that direct pacing the his bundle can result in normalization of bundle branch block pattern in humans. However, the interest was lost because of the non-availability of hardware tools and availability of data. And the mechanisms of QRS narrowing with his bundle pacing in left bundle branch block, there were multiple theories or hypotheses, but the most commonly accepted one is the longitudinal dissociation in the his bundle with pacing at or distal to the site of delay block, resulting in the normalization of the QRS complex. So this is an example where a patient has a baseline left bundle branch block, and with a pacing lead in the his region, you can see the his signal pacing at 1.5 volt results in selective his bundle pacing with correction of the bundle branch block, whereas reducing the output to less to 1 volt at 0.5 milliseconds results in his bundle capture, direct his bundle capture without correction of the bundle branch block. So we know that though the patient has a left bundle branch block, pacing in the his bundle region at a higher output can result in normalization of the QRS. With this interest in his bundle, the lot of studies have been done, and it has been found to be fairly convincing. And we have also adopted in our pacing strategies for many of our patients. But his bundle pacing has had many limitations. The most important one is that risk of increase in pacing threshold over time. Risk of lead dislodgement is more theoretical and less seen in our experience. And more importantly, there are limited tools available for implantation and mapping there. And there's a lot of learning curve and challenges in anatomy. With dilated hearts, it may not be feasible. And the success rate that could be achieved is in about 80 to 90% of the patients where it is successful, and a little lesser in patients where we need correction of bundle branch block as well. So with that came the concept of left bundle branch pacing. That is, we put our lead in the right ventricular side of the septum and screw in deep into the septum to target the area of the left bundle branch, and that may achieve a better synchronization of both left and right bundle branches with a better pacing thresholds and longer stability of the pacing threshold over the long time. Now, if we look at how to implant left bundle branch leads, now typically the Medtronic, the same the hardware is available that we use for his bundle pacing is used for left bundle branch pacing as well. We have a lumenless 4.1 French lead which has an exposed screw, and it's not stillet driven, so we need a guiding sheath. Typically, we use this Medtronic C315 his sheath, which has double angulations and has a fixed curve, and then we position it in the region of the his bundle with the lead inside, and then we map the his region, and then targeting the localizing the his region in the RAO view, we look at we target the left bundle location by about 2 centimeter distal to the his bundle location and the line joining the his bundle location and the apex in the RAO 30-degree view. And then we advance our sheath to that location. And then with fluoroscopy and electrocardiographic guidance, we pace and then screw the lead by directly turning the lead into the septum rapidly. And the way we do it is that once we have identified the location in the right RAO view, we turn our position to LAO view and then abut the guiding sheath to the septum. And then the lead with the exposed helix is then inserted for about 1 to 2 turns, and pacing is confirmed to see that you have in lead V1, you have a notch in the nadir of the QRS complex, and with the discordance in the lead QRS complex morphology in lead 2 and 3, and AVR and AVL, that is your lead 2 shows a positive QRS, lead 3 shows a negative QRS, and AVL shows a positive QRS and AVR shows a negative QRS, then you know that you are at possibly a good target site. And then you give 4 and 5 turns and looking at the impedance and the pacing at different times. And you find that initially the impedance actually increases. And then as we reach the left bundle region, the V1 starts to show this notch actually starts to shift upwards and results in an R dash pattern, which is typical of capturing the left bundle branch. And then the impedance suddenly drops by about 100 ohms. And that's the time we stop rotating the lead and then see the result. We find that sometimes we are able to see the left bundle potential, which is the about 10 to 20 milliseconds after the his bundle potential. And when we pace, we find that we have the right bundle branch block pattern with a relatively narrow QRS. And if we measure the left ventricular activation time in lead V5 or V6, we find that stim to QRS peak of the R wave, stim to peak of the R wave is less than about 75 milliseconds, whether we pace at a high output of 5 volts or at a low output of 1 volt. And similarly, if we pace at high output, we may have a non-selective left bundle branch capture with capture of not only left bundle branch, but also surrounding myocardium. But if we reduce the output, sometimes we may be able to see selective left bundle branch capture, and that suggests that we are at our target site. Now, there are different criteria. The article by Vijayaraman and Huang enumerated these criteria. And if any 3 of these following criteria are met, typically what we see is a phase morphology of RBBB pattern, presence of left bundle branch potential, left ventricular activation time less than 75 or 80 milliseconds in lead V5 or V6, which is constant and short at both high and low output pacing. These are the typical ones that we see in our patients. And then there may be evidence of selective and non-selective capture at different outputs. And sometimes there is evidence of direct left bundle capture. And you can see that from his bundle to left bundle potential, you have an interval of about 20 milliseconds. Compared to his bundle pacing, which has now a lot of data, the data for left bundle branch pacing is still evolving. And this was one of the first collaborative study, which was published again by Vijay Raman's group, including patients from US, Europe, and including patients from India. And this found that in patients who are candidates for cardiac resynchronization therapy, left bundle branch area pacing was successful in about 85% and resulted in significant QRS narrowing from 152 milliseconds to 137 milliseconds, with improvement in ejection fraction from 33 to 44%. And they concluded that left bundle branch area pacing is feasible and safe and provides an alternative option for CRT. And it provides remarkably low and stable pacing thresholds and was associated with improved clinical and echocardiographic outcomes during follow-up. If we look at the comparison between his bundle and left bundle branch area pacing, the target area for his bundle pacing is very narrow, whereas as we know the anatomy of left bundle, the left bundle branch fans out, and even if we are able to recruit some part of the conduction system, we generally have a good result, and so we have a wider target zone. This allows a shorter learning curve and shorter fluoroscopy times and procedure times with left bundle pacing compared to his bundle pacing. And though both result in a very narrow QRS, the QRS is narrower with his bundle pacing compared to left bundle branch area pacing. However, if you look at the long-term result, the sensing with left bundle branch pacing is better. The thresholds are relatively lower, providing higher longevity of the device, and this threshold stability over long term is also better. The requirement of backup RV lead is very low, though that is true with his bundle also in experienced hands, and the risk of complications is low. The only drawback is we do not know still what will be the result of extraction of the left bundle pacing lead, and whether with the lead deep inside the myocardium in the septum, what is likely to be the problem of lead failure over longer times. We don't have the data as of now. Another study looked at patients where the conventional biventricular pacing, that is the left ventricular lead, was complemented with a left bundle branch area pacing, which is now called as LOT CRT or left bundle branch optimized cardiac resynchronization therapy. And it found that if the result as seen by the QRS duration and the left ventricular activation time is not good with either conventional left ventricular pacing alone or conventional left bundle branch pacing, one can combine these two, and this study found that LOT CRT is not only feasible and safe, but also provides greater electrical resynchronization as compared to BIV CRT or LBBB pacing alone in some patients. So you can see the QRS duration is narrowest when the during LOT CRT compared to left bundle branch area pacing as well as with BIV CRT. These are ECGs from a couple of our examples with left bundle branch pacing. This is a patient who came with a 46-year-old lady, came with complete heart block, symptomatic with syncope and normal cardiac MRI and ejection fraction of 45%, and she was offered left bundle branch pacing. And you can see that very narrow QRS, which cannot be achieved by just right ventricular myocardial pacing. Similarly, another example, a 67-year-old male with left bundle branch block, ejection fraction of 35%, in symptomatic class 3 heart failure, cannot afford a CRT or even biventricular pacemaker or a biventricular ICD, and was offered a dual chamber pacemaker with a lead in the left bundle branch. And you see that the result, you see that there is incomplete right bundle branch kind of a picture, though the baseline QRS duration was around 160 milliseconds, and you see that you could achieve a QRS duration of 110 milliseconds with just a dual chamber pacemaker. The results on echo are yet to come during the follow-up, but we are sure that his LV function will definitely improve as his symptoms will also be improved. Now, if you look at the guidelines, the his bundle pacing has actually come into the guidelines both in 2018 ACC/AHA guidelines in patients who have AV block and requirement of permanent pacing with EF between 36 to 50%, or as an alternative to CRT, which is a class 2A indication now. Also seen in ESC 2021 guidelines as an alternative to CRT in patients where the coronary sinus lead implantation is unsuccessful. His bundle pacing is class 2A indication and is considered as an alternative to RV pacing in patients with AV block and ejection fraction more than 40% who have anticipated more than 20% ventricular pacing. They've also commented on left bundle branch pacing, but due to scarcity of the available data, and they have not even included it in the guidelines. The most recent guideline published only this week, but they acknowledge that the current recommendations will probably need to be revised once more solid evidence of safety and efficacy from randomized trials is published in future years. So I think I will end with this and will be happy to have any discussion and comments.
I think Karthik, a wonderful talk.
Yeah. So these are see the incidence of heart failure is increasing worldwide because of aging of the population, and as patients survive, their predisposing cause of heart failure like hypertension, long-standing diabetes, and long-standing diabetes, as well as surviving the coronary artery disease. So it is great to see so much of interest worldwide in the heart failure therapies, both drugs as a drug therapy as well as device therapy. We were fortunate, I was fortunate to be principal investigator from GB Pant as a principal investigator for DAPA-HF and Emperor studies, both reduced and preserved. And we recruited, I was the third largest recruiter in DAPA-HF study, where we enrolled 94 patients. Now the important, why I'm mentioning this thing, not to say the numbers, but because all these trials are placebo-controlled trials, and we do not know which patient is taking placebo and which is being given the active investigation product. So we could tell immediately, I mean, within 2 to 4 weeks, that likely which patient is on the dapagliflozin, because the symptoms were so markedly improved in these patients who were, had difficulty in walking, say 50 meters or so, and you used to get severely breathless. Now they immediately went into class 2 within 2 to 4 weeks. So this is a wonderful drug. And now the same drug, I mean empagliflozin, delivered with dapagliflozin, results will be out in few months. But empagliflozin has shown beneficial effect in heart failure hospitalization predominantly, and in composite endpoint of heart failure hospitalization and death in preserved ejection fraction also. And in the last, I would say that these drugs are more effective when the ejection fraction in the lower side, and many patients who present with heart failure and preserved ejection fraction will ultimately have decreased ejection fraction. They may not go into 20% or 25% range, but surely they go into mid-range, or some will go into reduced ejection fraction range. So these are very exciting times. Over to our panelist and respected Dr. Claire, sir.
Well, thank you. Thank you, Vimal, for your comments for the drug therapy. I think there is no doubt what Dr. Manoria has shown today, that the drug therapy, proper guidelines, appropriate drug therapy for heart failure can improve outcomes in heart failure. And I think this is not being realized by many of us, and particularly the physicians. It can make a lot of difference. And I tell you, many patients referred for CRT, they become ineligible for CRT when you treat them properly with all these ARNI and beta blockers and aldosterone antagonists. So drug therapy is becoming more and more important, and I think there is a lot of role of drug therapy. Appropriate doses, for example, people start, ARNI like Azmada or Bimada. Many patients will have hypotension in beginning, and then they stop. The patient doesn't tolerate. So what we need to realize that we, in those patients where the BPs are borderline, we have to start from a very, very low dose, and we should emphasize to the patient that even if you have little giddiness, little feeling of weakness, we don't mind gradually these people, the BP starts improving actually. And there is a trial, in a patient with low blood pressure and ARNI group of drug. Ultimately, many of these patients, they improve their LV and blood pressure starts to improve actually. So There are many patients where I failed first time. I said, okay, you stop their loop diuretics, for example, decrease other drugs which can cause little hypotension, then introduce RD. So that's one thing which I would like to emphasize as far as the drug therapy is concerned. I think still there is a very little less use of the glitazones in the treatment of heart failure, which also needs to be more and more popularized. And still the doctors don't give that much of importance to that group of drugs. Now coming to the conduction system pacing, which Karthik very elaborately described, I think the best thing we can do in medicine is if we can mimic nature. And the conduction system pacing is, we are trying to mimic the nature. We don't want to stimulate the myocardium of the right ventricle or the left ventricle. We want to stimulate the conduction system. If you can capture the conduction system, of course, then the distal conduction, the wave of activation will become normal, and that gives the best possible results. And I think the His bundle pacing or left bundle pacing is actually very exciting. And I'm happy to share with you, as Dr. Karthik told, that it was first demonstrated by none other than our own Mr. Dr. Onkar Singh Narula in New York, that you could, in a patient with left bundle block, if you pace the distal His, you can correct the QRS complex. So now we started His bundle pacing in 2015 at Scott's Heart Institute, and we have not looked back. We have done more than 160 cases. Our standard of care pacing, any pacing, is the conduction system pacing. And even as Dr. Karthik told you, that CRT, for example, first attempt is always to do a distal His bundle pacing or left bundle pacing. And believe me, many of these patients, we can send them home with a dual chamber pacemaker rather than giving them a CRT device, which is much less, much more expensive. So we have yet to publish our data, but we are very excited. And Dr. Karthik also showed how to be sure about the left bundle pacing. Like you have there's R pattern in the ECG, and many of the patients you can record the left bundle potential. The only thing I would say is that if you want to do conduction system pacing, you need to have some knowledge of electrophysiology. I think the average cardiologist may not be able to understand that. So you need some system of EP knowledge to do the conduction system pacing, but it can be learned very easily. It's not such a difficult topic. So I must compliment Karthik to make it very easy, the difficult subject. And I must also confess that Dr. Karthik has been one of my brightest students, and he's done very well. I'm very proud of him. On Teachers' Day, I would say that it's not a question of teacher being honored, but I think we are honored with students like Karthik and Avinash Verma, who's working with me. So if there are any more comments from the panelists like Dr. Sukhvinder Singh, Pankaj, Amit Malik, I would like them to say something on both these subjects. Dr. Bikram, Vignesh, Dr. Asit Khanna, Sukhvinder. Sukhvinder, I can see you on the dais. Some comments. I know you're getting delayed for your lunch, but still.
So just at the last, I would say, based on our experience with the dapagliflozin and epagliflozin, I would like to add, in patients whom we are starting these drugs, just for the sake of audience benefit, those who are being started because they do not, they are not, they do not do any imbalance to electrolyte levels, but nevertheless, patients who are on diuretics, the diuretic dose needs to be reduced, and those who are euvolemic, and we have just given them as sometimes we write Fusilac half OD, something like that, just to, because they are euvolemic and we want them to be euvolemic. So those mild diuretics may be removed and maybe added later if need be, because some volume loss will occur because of SGLT2 inhibitor use. Regarding genital infections, we did not see any which have been reported in literature with these drugs, because predominantly they cause glycosuria, and they can result in fungal infection and all that because of increased sugar in urine. So regarding that, a little just overall maintaining hygiene, nothing extraordinary needs to be done, just maintaining hygiene and washing with water after urination and all have to be explained to the patient so that they don't land in trouble. So these are 2-3 points which have to be kept. Otherwise, often a question is asked, which drug to start, and Dr. Manoria nicely dwelt upon that. If the patient comes to you, which drug to start to begin with, whether you start with ACE inhibitor or beta blockers, and so which drug to start? The answer is very simple, because most of these patients have comorbidities already, like hypertension, long-standing hypertension, coronary artery disease, diabetes. So most of them, when they present to you, they will be already on 1 or 2 disease-modifying drugs. For example, they'll be on beta blockers or Ramipril, ACE inhibitor, or maybe ARB. So you have to just add the remaining drugs. So SGLT2 should be added straight away in these patients. Only thing is that again the question arises: should it be given to all the patients? I mean, a patient who has ejection fraction of say 35%, and he has presented to somebody's OPD, and he's already on Ramipril, beta blockers, and aldactone. So should we start SGLT2 inhibitor straight away? So this question is to Dr. Manoria, sir. Then I would like to comment on it also myself.
We must remember that SGLT2 are very important drugs for slowing down the trajectory of CKD. RAS blocker also slow down, but RAS blocker has the problem that hyperkalemia is an important feature. Abrupt fall in GFR is an important feature of RAS initiation. So besides benefiting heart failure, they will also benefit kidney failure, and you can postpone dialysis to the tune of 10 to 15 years. Thought is emerging in the minds of some scientists: why not initiate SGLT2 as first drug in CKD compared to the RAS blockers? There's no data, there's no recommendation, it's true, but it is very exciting question that trial should be conducted whether SGLT2 should be the first drug in CKD compared to RAS blocker, because it doesn't interfere with potassium, it doesn't interfere with eGFR, it is only single dose, doesn't interfere with blood pressure. So its initiation is very simple, and that's why even if you have good response to the other 3 drugs, I will still add SGLT2 inhibitors. The benefit is incremental on top of all 4 drugs.
That is nicely said, sir, because the present, though lots of mechanisms have been, hypothesized for the benefit of SGLT2 inhibitors, and the question is still an open question. However, it is still believed, the present belief is, besides improving myocardial energetics by increasing glucose oxidation, one of the most important benefits of this drug on heart failure is by improving kidney function and decreasing the decline in kidney function, because both these reduced trials showed 50% reduction in the renal endpoints. So that is one point. Second point regarding the initiation of these drugs is that if we go by the trials based on evidence-based medicine, these trials had inclusion criteria of low ejection fraction of less than 40%. And besides that, in addition to low ejection fraction, they were required to have NT-proBNP of more than 600 if they were in Sanidram, and more than 900 or so if they are in AF. Of course, in Emperor, the criteria was a little bit more this thing, but in general, this was. So what I mean to say is, before starting these drug therapies to left, right, and center, we do not have data at this point of time to start these drugs in patients of heart failure who do not have raised NT-proBNP levels. So NT-proBNP levels should be raised ideally if we ideally have to go by, evidence-based medicine. So that is my comment. And regarding this comment that they can be started straight away, of course, in eligible patients who have raised NT-proBNP levels, one should not be waiting to start them after 2 weeks or 3 weeks, because by that time your patient may be dead and he may not be needing it. And as was shown in all these trials, that the benefit of these drugs, the Kaplan-Meier curves start diverging as early as even in preserved trial, they started signally diverging at 18 days, and even earlier in reduced ejection fraction. So benefit is fast. So it is good to start the drug not only for endpoint reduction, but also because KCCQ questionnaire, which is 23 questionnaire, which takes care where we ask about functionality, their symptoms, as well as their quality of life, their activities for entertainment like gardening and all that. Those type of questions are there, and it is the questionnaire which is there in all the heart failure trials. So it also shows significant improvement. So in appropriate patient, they should not, physician should not do, and Dr. Clare raised a very important point that people, still the uptake of these drugs is, though they were approved almost 15 months back, the uptake is still quite poor among physicians. So by CMEs or whatever means, the uptake of these therapies needs to be improved. I agree with Dr. Clare.
There is another comment I want to make for the audience, that many of the doctors, including me, we used to believe that ARNI group of drugs are very expensive, but there are cheap brands available, and I want to just tell few. Secutan is one, which is by MSN Laboratories. Zio is a Life Sciences Limited. Wellsec is another Netco Pharma Limited. I guess their quality is good, but they are much cheaper as compared to Vimada and things of that nature. So we are an option. See, as far as I think recommendations are concerned now, when we come to treatment of heart failure with decreased ejection fraction, out of the ACE inhibitors, ARVs, and the ARNI group, I think the standard of care is ARNI. So one must start with ARNI now for patients who are to start therapy new. As far as I'm concerned, I even change patients who are even stable on Remipril or on kind of telmisartan or olmesartan. I also give them an option that I would like to give a better medicine. And I think there is scientific evidence to go into that kind of philosophy because the difference is very significant as far as the outcomes are concerned.
Yeah, you are right, sir. The benefit with ARNI vis-a-vis ACE inhibitors or ARB is almost double. The patients are likely to, as far as cardiovascular death is concerned. So the benefit, you are absolutely right in saying that the benefit is double, and you have to start. Only problem, as was mentioned by Dr. Manuri also, and we all are aware, and you also mentioned it, that some patients do develop the incidence of hypotension, and hyperkalemia and a little bit of renal dysfunction if one is active enough. Most of our physicians will not get the KFT done so frequently, so they will miss it nevertheless. So hypotension is a little bit more, but if one is persistent at starting it at a lower dose, and will help, and later on one can escalate it. So these are practical tips actually based on our experience. And it is nice that you mentioned cheaper brands, because cost sometimes becomes an issue because these patients are on polypharmacy, and so we do not want to write them something which they will ultimately not take.
There's another comment which I want to make. As far as the pacing is concerned, now the Micra, the leadless pacemaker, came with a lot of fanfare in the whole world. But I tell you, I'm not much impressed with the MICRA, because MICRA still remains a non-physiological pacing. First of all, it's a single chamber. Anyway, dual chamber will be developed, and I guess it is almost completing trials. But even if you have a dual chamber MICRA, it still remains a non-physiological pacing. So my guess is that in the future, conduction system pacing will become the standard of care. The leadless pacemaker will have a small niche in those patients where you have SVC, bilateral SVC occlusions and access problems, very elderly patients where you cannot do the conduction system pacing. I don't know,
many patients
who
develop infection. I mean, patients
right.
who have recurrent infection. So
Absolutely.
those are the recurrent previous left side, right side, both are accesses are gone because of infection.
Right.
Because
So
of,
I think their niche will be very small. I would like Karthika to comment on that.
I think I agree with Dr. Claire. The biggest challenge is the cost. Now, compared to MICRA, the cost of his bundle pacing is his bundle or left bundle pacing is actually much lesser. And in fact, if we are using left bundle or his bundle pacing for CRT, the cost is actually lesser than the conventional biventricular pacemaker. So I think, considering the Indian scenario and in fact many other countries, conduction system pacing has the future for most of our patients.
I have one question to Dr. Karthike. Suppose we have a patient of complete heart block. Incidentally, I did one, this patient was a poor chap. He had a Medtronic pacemaker. This I did yesterday at around 9:30 in the evening. This patient had 10 years back. I'm not sure what was his ejection fraction at that point of time. We had very detailed records, but this is a real patient. And this patient had single chamber pacemaker implanted for complete heart block. That much we are aware of. So now, yesterday, so this was supposed to be a free PG pulse generator replacement, because he was having now recurrent syncope because CHB had recurred, because it was intermittently pacing only because of end of life. Now, once I started this, this was supposed to, PGR is supposed to be handled, it is a simple, straightforward job. Only thing is, you do not cut the lead. So while we talked to him regarding upgradation, but he totally refused. He said, I will not even go for the lead payment if, break the lead. So I was handling it myself. And during the procedure, the patient developed gross left ventricular failure, and so much so saturation was 82%. It was a harrowing time for me, and the chest was full of clefts till the upper 1/3. Nevertheless, at this point of time, patient is fine. He is minimal cleft. We put him on CPAP by great difficulty, and not only that, because he was moving so much, while I was retracting the pacemaker, I mean the pulse generator, the lead also got pulled. So I had to, and it will not go again. So I took out that lead, and there was no lead, though we could have given him free by this thing. But I wanted to take a chance, took a fresh puncture, put in the same old lead, which was 10, 12 years old lead, put in the same old lead. And luckily, and patient was, while howling, let me sit up. And luckily, I could get this threshold in one go and sit that lead, and, patient was put in on CPAP, shifted to ICU with. So, so my question is that this was just an incident. So, and I want your comments, how to manage these patients, number one. What will be best therapy? Second thing is, you have a patient of de novo complete heart block, and you mentioned in your talk that lead sometime at his bundle may be, unstable, and lead displacement is more in clinical practice vis-a-vis clinical trials.
Dr. Clay, Dr. Mehta, can I leave? I have to go to other webinar.
Yeah, sure, sir.
Can I leave, please? Thank you very much.
Yeah.
Nice.
Thank you,
it
was helpful.
Professor Manoria, thank you, sir.
Thank you, sir. Thank you. Thank you. Great having you, sir. So these are practical questions. So patient of complete heart block, if given a his bundle pacing, obviously he has low ejection fraction. That's we are considering this thing, and there is lead dislodgement. So he will have a sudden cardiac death. I had cases. We all have seen cases who had lead displacement, have died both in hospital and outside the hospital. We received a phone call, and I had one case who had pacemaker done it 2 years back. This lady had bout of coughing, and she said after bout of coughing she suddenly collapsed. Likely it was displacement. So first question is first patient which I mentioned in detail just for the sake of this thing. How will you further manage it? Secondly, what is your take on lead dislodgement problem, and how will you go for just for the sake of ejection fraction? I mean, are you worried about the second scenario? So your comment, Dr. Kartikeya, because you are an expert in this area.
So I'll answer the second question, which is a general question. Now, see, the lead dislodgement risk also exists with the existing pacemakers with right ventricular lead as well. And it again depends on the experience of the implanter, how comfortable they are with their lead placements and what is the likely risk of lead dislodgement. So though his risk of lead dislodgement actually is much, much lower with these leads we have seen, but the main problem is the risk of rise in thresholds over long term with the his bundle pacing lead, which is on the tune of about 10 to 15%. And typically when this happens, this does not happen suddenly, it happens gradually, and you have always the option to revise the lead in these patients. Having said that, the initial cases, including mine own cases, whenever I was doing conduction system, especially his bundle pacing, and the patient is pacemaker dependent, we were very cautious, and many of the times we actually discuss with the patient, and if cost was not an issue, we give a backup RV lead and implant a CRT device rather than a simple dual chamber pacemaker. So you have to be comfortable. Once you are quite experienced, then you can just leave without even an RV backup lead. And now with the development of left bundle branch pacing, which has usually stable thresholds and very low risk of lead dislodgement, this need of backup pacing is backup RV lead is actually eliminated. Now coming to your first question, now I don't know, I have no experience, but I personally feel that it's not a good idea to implant a 10-year-old lead, especially if it's a passive fixation lead, not only because you may be able to get good thresholds at the time of implant, but we don't know the lead once we have extracted it, it has come out, how much damage it has happened to the lead. And typically what we will expect is maybe a year or a couple of years down the line, there may be insulation failure or lead fracture, and then you may be in the trouble. So better is to, I think most of our companies are happy enough to offer a free lead in such scenarios. And screw-in lead would have been a more better option if a single chamber pacemaker was the only choice that we had in such situation.
Oh, okay. So you still implant, you will still go, I mean, do you think there is a need for better technology for his bundle pacing lead so that lead displacement issue is, a little lesser? And at this point of time, with the present technology, what would you recommend? Straight away in a CHB with low ejection fraction, straight away go for 2 lead pacemaker, or still backup RV lead you will recommend? Because obviously expense will increase.
LV dysfunction, if the patient is pacing dependent and we are doing for Brady indication, then I would suggest either go for a left bundle pacing lead or use a backup lead. And if you are using CRT, you can put one left ventricular lead and one in his bundle, or just a dual chamber pacemaker with one lead in the right atrium and one in the left bundle branch area. If the LV function is normal, then one can use the dual chamber pacemaker, and even normal RV septal lead should work well, and that's what the guideline also suggests. But you can always discuss this option of conduction system pacing if they want, for prevention of LV dysfunction and heart failure in future, which occurs in about 15 to 20% of our patients. then you can consider conduction system pacing, even in a patient who is normal left ventricular function, but has an Brady indication for pacing.
Let me add, Kartikeya, that first of all, we have experience of now around 160 patients. The lead dislocation is very, very, very rare. We had only one dislocation in these 160 patients. This lead is unique. It doesn't get out. It is such a lead that it doesn't get out at all. So one patient, we had done the left bundle pacing. The impedance was around 450 at the time of implant. Next day, the impedance became 300 and there was a pacing failure. So lead has perforated into the left ventricle. We retracted this lead and we put in new position, not at the same place, and we could achieve the left bundle pacing again. But believe me that the fear of dislocation is almost nil, practically nil. We didn't have, even in the distal his position, it doesn't come out. This lead is unique. It doesn't come out at all. That's not a problem. The only issue may be that if you do a distal his bundle pacing, the reliability of the lead parameters, pacing as well as the R waves, it's still not very well proven that how good it will behave. So what Kartikeya said is very right. If a patient is dependent, we would like to do left bundle pacing rather than his bundle pacing. But if a patient is not dependent, for example, you are doing a patient where there is a sinus node disease and sick sinus and you want to put a ventricular lead, there I think you are very justified to do a distal his bundle pacing. If you get R waves more than 3.5 or 4 and the pacing threshold below 1.5, this will not go away. I think with the experience, all of us will realize that the failure of this technology is very little. In fact, in my experience, the dislocation is less than the standard leads.
I would agree, and also just add just for last comment that whenever we are doing these kind of cases, conduction system, we are actually much more careful than doing a conventional RV lead. And so we look at all the things that are there in the literature, and then we are comfortable. Then only we'll leave the lead in place. Thank you so much.
See what we do, Kartikeya, that I'm sure you do the same thing. First, in the sheet, we test everything. Then we withdraw the sheet to some extent, then we check it again. Okay. Then when we cut the sheet again, then we check it again 3 times. At 3 times you check it, and then you check the next day morning. And I do even fluoroscopy next day. So if you do next day fluoroscopy after the patient has been made, you have mobilized him, and the parameters are good on the second day, I tell you that nothing will happen to that patient.
So with this, Dr. Clare, shall we stop here, or you need?
I think in the interest of time and this being a Sunday, people need some family time. I think we should close. But I would like to thank you for organizing such a wonderful meeting and wonderful speakers. A great show by you. My compliments to you.
Thank you so much, sir. Thank you, Professor Manoria, Dr. Kartikeyan, Dr. Clare, Dr. Vimal, Dr. Amit, Sukhwinder, Vikram, Asit, for sparing your valuable time, and happy Teachers' Day to all of you. So with that, my conclusion remarks will be, sir, I would like to tell you that approximately 513 participants joined this from all over the globe. And it was an honor to host the Innovative Cardiology Conference 2021 with Asia's most eminent speakers, chairpersons, panelists, and the attendees. I extend hearty gratitude to all the speakers for sharing their learning and experience with us today. I would like to wish a happy Teachers' Day and thank them for their valuable learnings they have passed on to us and helped us, all of us, become capable of what we are today. I am very thankful to each and every participant as well as technical and support team. Thank you so much, sir. Thank you all the attendees.